All right, sorry. So now what are the options available for a long-term, stability, or what would you like to do for a long-term stability for this patient? What are the options available?
So type 2 fractures are usually stable fractures, and there is no instability seen on this X-ray CT scan. So we'll go for the conservative management.
Okay. Anybody else?
What does X-ray show?
This X-ray shows instability, unstable type 2 odontoid.
Could you show the CT scan and the MR pictures? How much this, right?
Can you show us the MRI scan as well?
Yes, sir.
Right, okay. All right.
What does it show?
This is unstable fracture. Where we need to fix it. I think I would go for C1 lateral mass and C2 pedicle. C1 to fixation and fusion, that will suffice, I think.
Yeah, it's an old fracture.
C1 2.
That's an option for sure.
C1 lateral mass and C2 pedicle.
Mike is,
But I think the C3, C2, 3, there is also subluxation, so we need to fix C3 as well.
Where is it suffer?
Like they on the CT scan.
C2-3 is okay. I don't know.
C2.
Well, I don't know. I don't. So where exactly did you see the subluxation? C2-3, did you say?
Sorry, it was C1, 2.
C1-2.
Yeah, the posterior elements, they are also distracted.
Yeah. Okay. Well, there is a fracture there. So obviously there is instability. So that needs fixation. The patient also is presenting with neurology, so we need to do something about that. So what are the options? Who from the young guys can give us options? Anybody volunteer?
I think.
So what options do we have here?
I will keep on the as first option is C1 2 fusion, C1 lateral mass and C2 transpedicle. And this will be my only option. Otherwise, it can be done anteriorly, but C2 odontoid leg screw. But I think it should be done posteriorly because we may need to decompress as well because there is cord contusion or trauma.
Yeah. So yeah, C2 pec odontoid screw is, yeah, I know some people which will attempt that, but it's going to be probably will be problematic. Plus, this is an old fracture there, so
yes, and more chances of failure.
Yeah,
in C2.
I agree with that. I agree with that. Do you agree with that? Yes. Yeah. Okay. So do you? All right. Honor. Yes, he's slipping there.
So it's an old fracture. So odontoid fracture, odontoid screw, I think is not an option for it.
Yeah.
Posterior is the best one.
Yeah. Okay. Is that what you guys do? Do you want to present to us the outcome?
Yes, sir. So we did C1 lateral mass screws and C2 translaminar screws. And
Okay.
post-op power remained same. He was discharged and followed up in OPD. These are the post-op X-rays.
Okay, that's also a good option. So biomechanically, this is equally good as the others type of fixation that you said. So this is also an option. Why did you decide to go laminar screws? Was there any specific reason for that, or you just liked it?
Boss likes it. Because what happens if I'm operating anywhere else? Anybody can put translaminar screws and pedicle screws. Why would you do pedicle screws? You can get the same results like translaminar. You want to take that?
So the indication my boss likes it is also a valid indication, so we accept that.
So there's no point in trying to put in but if you have a or or you need to start it unless you're going to start it.
So basically you did it, so it is, so you just practice that.
That's a routine.
That's a routine now?
Yeah, because we use 3 papers, so I am in one of the papers, so anybody.
Yeah, this is obviously safer option.
Simple.
Yeah, okay, fair enough. Yeah, that's a good solution. Yeah,
When you use 3 papers.
okay, good. Okay, very
Thank you so
good.
much.
Thank you so much for a nice presentation. Nice case. Next one.
So for the next case, I would like to call Dr. Maksood to discuss about a case of craniopharyngioma.
So
Good morning.
This is not my.
43-year-old gentleman, right-handed, known hypertensive, he came to another hospital, and then from there he came to us. He came with the complaints of memory disturbance, headache, and increased urination for 3 months. And he was diagnosed as a case of suprasellar as well. We don't have any preoperative CT scans, so just the preoperative MRIs are available. So this is a MRI T1 and T1 with contrast. Yeah, anyone, any resident, please. What do you see here?
So these are MRI T1 and T1 post-contrast images. This is showing a homogeneously enhancing contrast enhancing lesion on the T1 post-contrast images in the sellar and suprasellar region. I would ideally like to have sagittal as well as coronal images of the same patient in
Are you
order
sure
to.
they are homogeneously enhancing, or
They look like homogeneously, but slight heterogeneity also there.
here is your other images.
So on sagittal post-contrast images, there seems to be a heterogeneously enhancing lesion within the suprasellar region, reaching up till the third ventricle and obliterating it. It could be a suprasellar lesion like
The sellar and a suprasellar. There's a slight sellar extension also.
right.
So, on the scan, so lateral view, we can also appreciate a cystic component in the center. Lateral view, there we can see this is a T1 post contrast image. Here we see enhancing component as well as a cystic component in the center.
Yes. So what would you do about this? How do you further manage this?
The patient should require, if it's a sellar extension also, you should also get a pituitary workup primarily and a complete neurological exam to identify the deficit. And
the pituitary hormonal profile is normal. The patient has DI, and he doesn't complain of any. He doesn't have any subjective visual complaints. Objective visual field testing we have not done as far. So, what would you do?
So this lesion appears to be more on the more on the center. I would like to approach it from the right side. I could go for a transcortical, transventricular approach.
Transcortical, transventricular.
Sir, the sella is not dilated. Sphenoid sinus is well nematized. There are few options available. We can either go by pterional craniotomy or we can go by a subfrontal approach. Both of them are available. So we need to decompress the lesion. It's compressing the brain stem. It's obliterating the third ventricle. So I would not go by transcortical approach. I would approach it by pterional craniotomy. Pterional approach, yes. By dissecting the sylvian fission and then approach the lesion and decompress it.
Why the pterional? Why not the subfrontal
Sir,
intrahemispheric?
Sir, both of them are available. The thing is that in subfrontal, we need a lot of brain detection. So if someone is expert in pterional, and he should go by pterional craniotomy, as it is more advanced and we don't need to retract the brain. Don't need to retract the frontal lobe in it. Yes, sure. That is also an option.
Yes, brainstem compression. A midline pushing towards posterior aspects, going towards brainstem, and suprasellar as well into the third ventricle or pushing the third ventricle. I think I would go eyebrow craniotomy and try to excise it endoscopically. Supraorbital. Right.
Yes, you could try and with neuronavigation to do a endoscopic approach, but I think the ventricles are rather too small. You'd
Yes.
much rather have I would consider it an open procedure rather than an endoscopic.
Yes. Calcified lesion. So for calcified lesion, what is it? Subfrontal transcranial,
So what did you do, Salman? Okay.
It is.
Yeah.
You want to tell us what?
Yeah. Okay. So. So someone did a right pterional craniotomy with maximum safe resection and a general anesthesia on 25th of April. And the intraoperative findings were a solid cum cystic lesion, grayish and fibrous inconsistency containing cholesterol crystals. Histopathology showed adamantinomatous craniopharyngioma grade 1. So the patient didn't improve. He came to us and we performed a CT scan. Here is the post-op CT scan. There are a few specks of calcification and these are the post-op MRIs. So what would you do now? What would we do now? Should we go in? Either is it residual or probably it's residual or recurrent, whatever it is. What would we do now? Would we go for re-operation or we should opt for radiotherapy?
What are symptoms now post-operatively? Is he deteriorated?
No, it's
No.
the same. He has headaches and
he's very sick all the time. Not the same word, but
so now
If he's worsened, then I think it should be re-explored and surgery again should be tried again with some other approach, maybe.
so why not? Why would you want to go for surgery in a field which is already scarred? Why not radiotherapy?
For radiotherapy, I think it is a large tumor. It should be.
I'm not talking about radiosurgery. I'm talking about radiotherapy.
Even radiotherapy in this area, it gives some complications later on, like optic nerve problems and hypothalamic, thalamic.
I'm not sure.
Yes, sodium
Yes,
level.
Things like he has sodium 180, for example. So the last sodium was normal, but we estimate.
Midi, can you use the microphone there? If you.
What just wants to be certain that he's biochemically normal, because you see some of these patients with very low thyroxine levels, very low cortisol levels, or very low sodium levels. If those are normal, then something's got to explain his impaired function, his somnolence. And I think he's got a tumor which will not disappear or reduce significantly with radiation therapy. So I think the most appropriate option, given that he's metabolically intact and normal, would be to give him an option of reducing that volume, and whatever there is residual be considered for radiation therapy. And that would be, in my view, a reasonable approach.
Yes, I think
when surgeons say that they have removed the tumor completely, they have removed 1/3, to be honest, most of the time, particularly these kind of cases. And of course, when you decompress it, you can see some fluid at the top. So that tamponade effect is also lost. So maybe that is extension of whatever was residual. So, and the second time you go in, I think it's much easier because the tumor is not that big and there is more space. So I would go for the other.
Actually, the reported MR says exactly the same size as before.
So this is a residual disease after transcranial approach or transplant. Well, these are difficult tumors, and I wouldn't operate on this patient unless we discuss in an MDT first. One option is to go back in transcranial, try and debulk, assuming that you are a better surgeon than the last surgeon, which is an assumption that we all have all the time. The other thing option would be to go transsphenoidally, in which case, again, the goal would not be for complete excision. Remember, these tumors are usually adherent to surrounding structures. The best you can do is an internal debulking. As soon as I see calcifications, I stop because trying to pull calcifications off can lead to problems. But you would like to decompress the tumor before you subject them to radiation because it's too close to the optic chiasm to radiate right away.
Yeah, symptoms now?
yes. So we all agree in the presence of the experts that now the option is redo surgery, not radiotherapy, because we can decrease the bulk of the residual bulk further, and that would increase the progression-free interval of the tumor. Radiotherapy has its own side effects.
So firstly, this is very unusual, and to have a cranio recur, I mean, it's clearly is a cranio, and to have it recur within 3 months, I don't think I've ever seen that before. But just to start with the initial debate about subfrontal versus pterional. So I'm a pediatric neurosurgeon. Pediatric neurosurgery almost invariably do cranios subfrontally. And I think the bottom line is the operation you do best is the operation you're familiar with. And most neurosurgeons who mainly operate on adults are very familiar with pterional craniotomy. And so I think it's a silly debate. I think you have to use the surgical approach that you're most familiar with. I do think, and quite a few individuals have a similar view, that craniopharyngioma is a midline tumor, and the closer to midline you can get with your approach, I think the better your surgical corridors and the less the risk that he's going to actually prang important structures like the hypothalamus. In terms of what you do now, I would take quite a strong view that there's no way you're going to get away without giving this patient radiotherapy. And I think the risk of reoperating, you've already got an injured hypothalamus. It's clear from the patient's clinical picture that he's got severely compromised hypothalamic function. That's going to be a lot worse after a second operation. So I would be inclined to go straight for radiotherapy here.
He was sent for radiotherapy, cyberknife, as well as for and both of the radiotherapy said do something, cut down and then
I think there's also a learning point here. I think the first CT scan was misleading. I think it was done for the right reason, but the reason I would do a CT scan is just to make sure that I haven't left a hematoma there, but not rely on it to tell us whether there is residual there. And if you want to make sure before the patient is discharged, do an MR. And I strongly feel that you'd have found exactly what we're seeing here on your MRI. At this patient, I think the radiotherapy oncologist is right. He's not confident that he can do a significant reduction or control of the tumor. And I do believe that if he's able to take the surgery, if he's in a good state, you've got to at least decompress that volume before you offer him for radiotherapy. So the CT scan was done correctly, but the conclusion that there is no tumor was wrong. I think there was no hematoma, and that's why one would want to do an immediate post-op CT. But to discharge him on the assumption of a report that says there is no tumor, I think was a bit of a lapse of judgment. So do an MR before you discharge him. You probably find that, except that you haven't debugged the tumor. Go in, if you're whatever familiar.
Can you put up that CT scan? Moody, I think that CT looked amazing. Do you really think there's tumor there? Yeah. I mean, there's some, but I mean, you've got a pretty good resection on that, I think, on that CT scan. There's some tumor there, but you've got a pretty good resection. I mean, to have this progress so rapidly in 3 months is extraordinary.
I've seen it.
Yeah.
Just move it to the right. Move to the right images.
Yeah.
Go to the right images, and it shows pressure, same pressure on the midbrain that was there before.
No, the CT.
Can you just compare these sources?
Go to the lower ones. The suprasellar, the midline suprasellar. Yeah, there it is. It's sitting there.
Okay. Okay.
Yeah, on the right mid row. Yeah, it's sitting there. I think there was a false sense of confidence that there was no tumor, and I would have done that just to exclude a hematoma.
Regarding the hypothalamic involvement, I think we can also give a trial of steroids, and if this hypothalamic symptoms like obesity and increased appetite, and it disturbs sleep-wake cycle, they reverse. So it means that you can go for surgery. If they don't reverse with steroids, then probably radiotherapy should be an option.
Why you actually did that CT scan? What was the reason for that?
I didn't do it. It was done by the person who did this.
And what
So
was
they did it usually after 48 hours, MR is done. So instead of MR, they did a CT.
We probably wanted to see the calcification also.
I thank you for all the comments. I think the literature, if you review the literature from the Cushing's and everywhere, these are benign lesions and they have, have tentacles to which like a spider, and they involve hypothalamus. And quite frankly, our colleague is saying that if you try to, redo it and try to take it out, it will definitely worsen the situation clinically. If the patient is having a hypothalamic dysfunction, probably if you do redo it, then there is a highly likely chance that the patient do worse post-operatively. I think we need to discuss in the tumor board, and we need to, talk to the people who are involved in radiosurgery. So I think we need to discuss it with the radio oncologist who's involved in stereotactic radiosurgery.
Does anyone know of any randomized clinical trial comparing surgery with surgery and post-op radiotherapy?
Yeah, there is.
There are so many trials.
I think there's significant concern that you might make the patient worse. I think you will make the patient worse if you attempt a radical resection. But if you debulk it, don't get into the hypothalamus knowing that you're already compromised because of tumor tissue in the hypothalamus. Don't go for bust, decompress it, go by what the radio oncologist says, and then offer him radiotherapy. And I think if one is very, very comfortable because of experience going through the Tirianol approach, then go by it. But I think you've been through a Tirianol, and if you're comfortable doing a supraorbital, you'll get there fairly quickly, and you'll be able to decompress and not go for bust. You will leave your hypothalamus fairly undisturbed, and you'll have satisfied the radio-oncologist's desire to hit him with radiotherapy after debulking. So I think that's the approach I would take, subject to him being able to withstand that surgery from a biochemistry point of view.
One last question. Should we go for an intentional subtotal removal and rely on post-operative radiotherapy?
Yes, that should be the primary objective. But if you're in there and it's oozing out at you, okay, it's coming out freely, you wouldn't stop. You just take out whatever. But I wouldn't try and get to very clean hypothalamic tissue as the primary objective. I'd take as much as I feel is safe without pulling on those structures, decompress it. And if you can even reduce that volume by about 40 to 50%, you're doing okay.
So
Okay.
to that,
Sorry, carry on. No.
I mean, I was going to say that if we have exhausted that interesting case, according to my program, we are now indenting into the next section. According to my watch.
We have more cases. Yeah, let's have one more case. Yeah.
Maybe, and then we have to move on.
Thank you. 5 minutes of this case, you make sure that it's a spine case.
Okay.
Can sit here all day discussing craniopharyngiomas.
Who is presenting the case?
So Dr. FIFA, please come on the stage to discuss the next case.
So in 1990, Fred Epstein convened a symposium called Craniopharyngioma, the Answer. 30 years later, we're still debating.
Still the answer is not here.
Good morning, everyone. I'll be presenting a case of pituitary adenoma. So we had a young male, 34-year-old, who presented to the clinic with complaints of left-sided decreased vision and weight gain over the course of last couple of months. On examination, patient had a GCS of 15. There was no significant motor deficit. There was only on examination, there was just left temporal field was found to be affected. So these were the images. This is axial T2. Amount. As you can see here. This was the axial post-contrast image. Then we have the coronal cuts. This is the sagittal cut. We can see that the tumor is coming down all the way into the sphenoid sinus and is causing compression overall above on the chiasm as well. There was no specific question. We did what we usually do. So we went transnasally, endoscopically by a transsphenoidal approach. So Imad, let's go fast forward करना है. Fast. So we're here into the cellar. We're taking the cell floor here. Next. This is the adequate debulking done, and we can see that the lamina terminalis has come down. Picha, वापस exit हो गई तुम्हारी. There was no specific question to it. It was just that this was recent on pituitary that we did endoscopically, so we presented that. There was no specific question. Yeah, that was because boss wanted to feel good.
I think this was an easy case to finish because easy cases don't
Thank
raise
you.
so many questions. So we are good. Okay, now next speaker we have Mr. Shehzad Shamim presenting on how to develop research questionnaire. He is preparing his presentation. He is going now.
Yeah, I'm sorry, we have a bit of a problem. Does anybody here have a MacBook connector? MacBook से connect करने के लिए.
₹11 के हिसाब से रहेगा.
So, Assalamu alaikum. My name is Shehzad Shamim. I work as the head of department at Aga Khan University Hospital, and I am thrilled to be back here this year. Good to see old friends, Nick, Hassan. So my topic today is how to develop a research question. And like a pediatric craniopharyngioma, we can talk about it all day. But if I have to summarize this talk in one sentence, I would just say that the word research comes from the word search. And the thing about search is in order to find something, you need to be sure what you're looking for. So the most important part of a research project is developing your research question. In other words, getting to know what you're actually looking for. I have no conflict of interest. I understand I don't have too much time, so I'll just talk about two things. Firstly, and I mentor a lot of students doing neurosurgical research, and we often see people who embark on extensive research projects, and only later on they realize that their methodology was all wrong. So I would urge everybody to consider developing a research question as the most important part of the project, because your entire effort can go to waste if you haven't done this part properly. We're only going to talk about two things: the Packard framework and the final criteria, and I'll come to that based on examples. But this talk is not a substitute for two things: a thorough literature search and an honest and blunt peer review. So whenever you think you have developed an outstanding research question, look up the research, look up the literature. There's nothing worse that can happen to a good idea than a literature search. You will realize that people have done it already and people have found what you're looking for already. The other thing that I urge every one of us to do is, once you think that you have developed a good research question, talk to an expert. Talk to an expert. A lot of times we don't realize the problems, the intricacies with the project until we speak to an expert, and an expert who is going to be honest with you and blunt with you. So the Packard framework was developed quite a few years ago and takes into account 5 things. It's an acronym for population, intervention, comparison group, outcome, and time frame. And I'll give you an example. So for example, and this is a real life example. So we received a proposal for somebody who wanted to study neurosurgical infections. It wasn't neurosurgery, but I've just changed it. So somebody who wanted to study surgical infections. Now, this seemed like a reasonable project, but if we apply the Packard framework, we can really refine it to something very specific, which can not only improve our methodology, but also make sure that our efforts are worth it. So for example, so we invited the proposers and we sat down with them and we dissected this topic, and it took us 2 hours. At the end of the day, we came. So I will invite people from the audience to comment on this title. What can we do differently to make it more specific? Now, this has to be quick because we have to end in 10 minutes. So that's one. Instead of infections, because infections is a general term, so we can just focus on post-operative infections. Post-operative infections can be 1 week, 14 days, 30 days, 90 days, 1 year. Yes. So we can maybe choose one. So maybe we can, and if you look at the literature, most post-operative infections are reported for up to 30 days. So maybe we can pick 30 days because it's easier to compare your work with the literature if you do what has already been done, or at least follow what has already been done. Okay, so post-op infections, 30 days. What else? So to be honest, this is not a great research topic. This is more of an audit, but it helps to try and understand how to develop a question. But I agree, you have to be more specific. So outcomes as in infections, what are the outcome of infections?
Like I'm giving just an example that the question should be complete. It should mention like what we want to do about the acute neurosurgical infection, like the risk factors for the acute neurosurgical infections, the impact of the antibiotics on the acute neurosurgical infections, or any preventive measures to.
Excellent. Yeah. So exactly what you want to study about neurosurgery infections. All right. So maybe we can make it more specific to study the risk of post-operative infections. Right. The other thing is, what do you mean neurosurgery infections? Neurosurgery is not just it's just impossible to read, to categorize neurosurgery under one heading. So maybe focus on one specialty, maybe spine. Even spine is very non-specific. So maybe just focus on one procedure in one patient population, right? And that's what the PICART framework is all about. I'll go back. So this is what the PICART framework talks about. So whenever you have developed a research question, make sure that it falls into this framework. And then if it doesn't, then go back at it and keep doing it until it does. So at the end of our discussion, this is what we came up with: to study 1 year SSI rates in healthy adult patients undergoing elective single level lumbar microdiscectomy at a university hospital. You see how only this exercise of refining your question leads to a more focused research topic. And this is what I wanted to talk about. So this is what the PICART framework helps you do. The other frameworks available, you can use those, but we use the PICART and it works for us. And I agree with the gentleman that we can further refine it in terms of what you want to study in these SSI rates. You only want to study the rates because that's something that most hospitals already do, or you want to do use a specific intervention, which is also part of PICART, to see whether the intervention affects these SSI rates. So that's one. The other thing I want to talk about is the final criteria. Now, this has helped us immensely in deciding which studies to take forth and which to abandon altogether. There are just 5 things to check in a study, whether it's feasible, it's interesting, novel, ethical, or relevant. Now, it may seem simple enough, but I can tell you over the years, we've had to abandon majority of the projects which we thought were quite that would have changed the way the word works. But based on the final criteria, we realized that it won't work. So I'll come up with another example and we can discuss this. So this is an actual example. This proposal was submitted to us a couple of years ago, and the gentleman had prepared, the team had prepared 4 or 5 page of proposals with all the methodologies, inclusion criteria, exclusion criteria, the stats that they were going to apply, the references, all and whatnot. And then we invited them and we applied the final criteria. So this was the topic: to compare the effectiveness of single dose of 1st generation and 3rd generation cephalosporins in prevention of postoperative VP shunt infections. Now, if you apply the PICART framework, this sounds like a great research topic. But then if you apply the final criteria, so let's go over this. So final mein 5 cheezein. Whether it's feasible, we leave the feasible for now. Is it interesting? Anybody? Well, it's you can say it's interesting. I mean, it's a common topic. We all have this problem. So, but yeah, it's not very interesting. It doesn't excite us, but it's important. Okay. Is it novel? Not exactly. There is tons and tons of literature. There are Cochrane reviews, there are systematic reviews which talk about it. So it's not novel, but yes, you can make it novel by changing the type of antibiotic, changing the procedure, changing the patient population, but still, so it's borderline novel, borderline interesting. Is it ethical? Yes, it's ethical. Is it relevant? It's extremely relevant. So for 4 of the 5 things in the final criteria, it makes sense. Now, the thing about final criteria is the study has to fulfill all the 5 criteria for it to be something that you can do. If it doesn't even satisfy one criteria, you abandon it. Now let's look at the feasibility point of view. So this team wanted to study postoperative infections between 2 patient populations, one getting one type of antibiotics, the other getting the other type of antibiotics. We asked them how many VP shunt infections they do in a year. They did 100, which is a reasonable number. Now, assuming that there's a 1% risk of infections in VP shunt procedures, it means that they'll have 1 infection in one group of patients, in 100 patients. So they'll have 1 infection in one group of patients over 2 years, right? So for them to get a statistically significant result out of the study, how many patients would they need? Assuming they're targeting a p-value of 0.05. $4,000, which means 40 years. or a multi-center. So that's what we told them. So this has to be either a multi-center study or you'll need 40 years to collect the data. So this study is not feasible at all. So these are the only two things I want to talk about, the PICART framework and the final criteria. And as I said, we subject every study proposal to these criteria, and this has helped us a lot. So thank you.
Nice and concise. Thank you so much, Shazan. Yeah, so maybe we have time for one or two questions. Because of time, we are running late, so please be fast. Any questions? These are important topics, and we have to. I think
trying to trap me. I think it's important to have a timeline, because for those that occur within the first few weeks, you might want to then audit your operating rooms. But if it happens later on, there may be social elements to those infections. So I think you can't just leave it open, because we've seen infections come in 4 months down the road for different reasons. So I think it's important to have a timeline.
I agree. So studying infections is now a science altogether. And one shouldn't assume that as surgeons we can study infections better than anybody else. These studies need to be properly powered and need to have a proper sample size, and that is in itself is a huge exercise. And in fact, I don't see a reason for surgeons to develop these sort of studies anymore, because there's so much literature now on antibiotic prophylaxis. There are now guidelines that all we need to now is do audits, and if our infection rates are not compliant with the international standards, then there's obviously not the antibiotics, it's something else that we're doing wrong. So I don't see the future of these studies even in a country with a high infection rate such as Pakistan. That's my honest answer.
Right, any more questions? Right, okay. Thank you, Reza Shamin. Right, next up is Professor Ahmed Ali Shah, who's going to speak to us about ethics and empathy in neurosurgery.
Thank you, Chairman. Ladies and gentlemen, I did not select this topic. I was asked to speak about it. So here we are. For many years, the senior surgeons in the Pakistan Society of Neurosurgery talked about forming an ethical committee to oversee the things in the country. But we didn't get to any decision for many years because nobody wanted to bail the cat. And because the society does not have any authority to sanction anybody, only the medical council can do that. And that was the reason that we couldn't do it. The ethics and empathy are not taught as a subject in the medical colleges because we think that perhaps everybody who joins a medical profession should have it. It should be natural. The credit, I must say, goes to Professor Farhat Muazzam, who was a pediatric surgeon at Aga Khan University, who in the late 80s and early 90s started talking about ethics. And she wanted to establish a department of bioethics, but Aga Khan wouldn't agree. And they still don't have a department there. But she got one of her residents, Amir Jafri, interested into it. And both of them are now at SIUT, and that is the only department in the country at the moment, as I know. So what is ethics? Ethics is an established system of moral principles that govern the rules of conduct of the doctors, conduct of the surgeon. Neurosurgeons operate daily in the theater of moral choice under Hippocratic oath. The core of surgical ethics is the surgeon-patient relationship and the surgeon's responsibility to improve and protect the well-being of the patient. So the emphasis is on protection. For many years, I used to sit in the theater from the time the patient went into the theater and the time that he was conscious and he was extubated. It wasn't because I had nothing better to do, but because it was my experience over the years. I considered the theater to be the most dangerous place for the patient because things go wrong over there. And I have seen patients catheter pulled out, endotracheal tube falling out, central line coming out, and I've seen severe burns or people not taking care of the metallic parts of the table, touching the patient. One of my patients fell off the table under anesthesia. So the only person that the patient and the relatives know is the surgeon. They don't know the anesthetists are the ancillary staff in there. Therefore, if something goes wrong with the patient, they would hold the surgeon responsible. Therefore, it is the surgeon's responsibility to be there. I have seen people being extubated prematurely, so they go into serious respiratory issues, particularly when you have done a posterior fossa and the patient is not doing well. So what is the moral dilemma? We face dilemmas every day. But I give you one example. When the relatives tell the surgeon not to tell the patient that they have cancer. Now, this is strange to my mind, because you are responsible towards a patient. Patients normally in this country, at least, they are poor. The majority of them are not educated, but they come from far-flung areas. And they have seen so many doctors before they come to these specialists. They have seen their x-rays. They have already got an MRI. So they have a fairly good idea what is wrong with them. So to hide things from them doesn't make any sense. I believe that there are two kinds of patients. There are some who are in a denial state. So they might say to you, doctor, I don't have cancer, do I? Which means that they are already making a statement, I don't have cancer. And do I means that they need reassurance from you that things are not that bad. And there is another in which the patient is educated, is intelligent, he wants to know if they have got cancer, because they have to do things before they go to Almighty. We do what ought naturally to come to us without much philosophizing. These are examples of internalized values of determining action in response to another person and ethics of responsibility. A rational ethics seems obviously appropriate to medicine, where everything starts and finishes with doctor-patient relationship. Now, there's supposed to be 4 pillars of medical ethics or biomedical ethics. The first one is autonomy. It's the prerogative of the patient to go through a surgical procedure or refuse. Our as a surgeon is to truthfully tell him the pros and cons of surgery that you are planning to do, and do it in confidentially. The second is beneficence, the duty to good and good alone. Thirdly is the non-maleficence, do no harm, that our surgical colleague from UK has been telling us, Professor Henry Marsh, for many years, and the harm comes from negligence. And the last one is justice, to treat all patients equally and equitably, and you have to develop a trusting relationship with the patient, treat them with kindness, dignity, and respect, and make fair and just decisions without fiscal interest. Now, I know that whenever you develop a fiscal interest in the patient, your judgment is clouded. You make wrong decisions. And then, of course, you get into trouble and the patient also gets into trouble. There are certain codes of ethics, your personal integrity, objectivity, your professional competence. You have to be competent to do a certain procedure. If you cannot do it, then don't touch the patient, because patient is not a guinea pig. You have to send this patient to somebody who is competent enough to do it. And confidentiality is important, and you must behave professionally. Empathy is most probably genetic, but it is acquired also through your upbringing, through your experiences, and so on. If you are a psychopath, then you are in the wrong profession. Empathy is the ability of doctors to build a rapport with the patient and family, which builds trust and improve outcome. We all know the science of medicine, but very few people know the art of medicine, which is through ability to connect with the patient, see the disease from the patient's perspective, and try to alleviate their fears and anxieties through compassion and connection. Now, it all boils down to your mannerism, your ability to treat other people nicely and gently. And eye contact and smile doesn't cost any money. The patient who comes to you is very worried, very anxious. You put them into ease by looking into their eyes, and by smiling, they get confidence and they think that you're a good doctor. Show them compassion and kindness. Listen to them carefully, don't interrupt them. Understand their body language and their illness. This is important because somebody comes with back pain, and during the interview, you find out that he is severely depressed. Your surgery is not going to make him better, because maybe that he wants to hang on to the pain. A lot of people who have erectile dysfunction, and they complain about back pain. And it is important to find out that, because they would hang on to the pain after surgery because they don't want to perform. So that is important, that you must know their illness properly. See their reaction to your spoken words. They might get frightened, so you modify your language. Accept responsibility if things go wrong. Things go wrong with everybody. We all make mistakes. We have complications. Somebody may have a CSF leak. Somebody may have infection, a pocket of pus inside. We may leave something inside the wound, and so on, or develop a hematoma postoperatively. It is difficult for surgeons to accept failure, but it is important that you accept it, accept the responsibility, talk to the patient and his relatives, explain the whole thing, and get on with the corrective measures, whatever you have to do early. Because if you delay it, then of course they lose confidence in you and they start complaining and they seek other opinions. Politeness is very important, and human touch. One of our colleagues, he's not here, Dr. Bari has this way of touching, and he would hold the patient's arm and then explain. So they all get impressed, because they think that he's a good doctor. And communication is very important. And all these patients, they come to you, they are worried, they are anxious, they are depressed, and they have spent a lot of money, particularly when there is a child involved. They're very emotional. And therefore, they go through financial difficulties and other problems. So you try to help them, take them to the financial people and get them some financial help from there. So in conclusion, neurosurgeon has to be polite, pleasant, protective to the patient, compassionate. Basically, he has to be a good human being. I would not advise you to do PhD in ethics because you won't get a job. This is my patient. I do a lot of photography, and these are my photographs. Thank you very much.
Thank you for that very thought-provoking lecture. There have to be some questions and comments. Let's have some discussion.
Ahmed, thank you very much. Without without saying something which I may regret, I think you're talking to the converted. The reason I say this is a lot of what you've just described needs actually to be given to our hospital administrators, because we all, by and large, follow the principles that you have mentioned. Yet our ethical dilemma comes when we've squeezed out every penny of that patient and the patient needs to remain in hospital for about perhaps a week or 10 days. Our hospital administrators will put pressure on us to release the patient to a public institution from a private. I work at the Aga Khan and the Nairobi hospital, and I face this dilemma when I know that keeping that patient for perhaps another 5 days because he's developed an issue which may not necessarily be related to the patient's condition, but some of the lapses that we have within our system, yet they do not follow those. So those ethical dilemmas that you pointed out are by and large not a neurosurgical problem. It is the system problem. And I think these folks who sit in the hospital administrative sector, and I speak as someone who's been on the other side as a medical director as well, and it was a push to the, even from a medical director point of view, to the finance department when some patient needed to be. So that ethical dilemma needs to be addressed to those individuals, particularly because we function in these environments.
I quite agree with you. I think the hospital administration is the most ruthless of all the people, because they would not, for example, surrender the body of the dead patient if they can't pay the bill, for example. And you are the one who is connected with the patient. You have sympathy with them, but there's very little that you can do. So they're terrible, I can tell you.
I have a question as well. I'm Hassan Said from the US. That was a great talk. On the same spectrum, I think as surgeons, sometimes we don't talk about this often, particularly for younger neurosurgeons. I just wanted to ask your comment about this. Oftentimes as surgeons, we are very stoic, and inevitably we do have complications, as you mentioned. How do you deal with these complications so it doesn't paralyze you from further operations, especially with the emphasis on mental health and well-being and moral injury? How do you deal with these complications, and what do you do to let it not affect your personal life as well?
Well, I have lost patients during surgery, and that has been very devastating effect on me for a little while. But then people talk to you that one death is not going to be judged against you, and you have to get on with the job. I've seen my peers sit on a stool and cry after they put the aneurysm clip on the wrong artery. But these things happen. You are a human being. You have to get on with the job. You learn a great deal from it, but you can't just stop working just because something has gone wrong. So this is how you deal with it. And the other thing, of course, is that you are constantly in touch with the patient and the family. So if you are very nice with them and you have always explained everything to them, then they don't actually argue. And I never had any problem. I used to be called from home by the residents that the head injury patient, their relatives are being very aggressive. They started beating the doctors and they run away. When I used to come to the hospital and explain everything, explain to what coma score is and what he's going to do, how he's going to behave after this injury, they were okay. So it's the way that you talk to them.
Thank you very much. I think the most important thing is communication. And that is something which has been lacking, I have seen in many people. And I think what we need to teach the juniors is to, as you said, have eye contact and communicate and explain everything in detail. I think then if anything goes wrong as well, they accept it and they're very grateful even in the end of that. Thank you.
Yeah, surgeons are very shy people generally. I have been, as you know, I have been a politician and I've been a member of the parliament. So I can speak to people, but I have no difficulty and they understand. But communication is important because whenever there's a problem between you and the family, they say there's a lack of communication. You always say lack of communication, which means that it is very important.
I think to on Saeed's point, I think what I have found very therapeutic in the institution, our morbidity and mortality meetings are very humbling. And also, if you're honest with yourself, you begin to then realize that it's not just you. And that, in a strange way, gives you confidence that you're really not that nasty guy. But I've found something which is even more, which is related to this. And that is, you will all have heard of Keki Turrell's famous webinars on complications. And it's amazing how sort of calming those conferences are, because you realize the big guns around the world who are really known for making no mistakes are sitting in those conferences and openly stating how they've made mistakes and how they had complications. And then you begin to, it's almost therapeutic to yourself, who as a tiny neurosurgeon somewhere deep in the LMIC countries is blaming yourself for doing wrong. And then you realize, no, even the big guns are having that. And that kind of gives you that mental calmness, almost a psychological therapy, that you're not alone in this wild world of complications. So yeah, that's what I would think.
Any other questions? Yeah.
Thank you so much, Dr. Ahmed Ali Shah sir. We always talk about these ethical issues, but do you think that where we are working in the lower middle income countries in the government sector, where always what we taught and discussed in these conferences, that is totally changed in our setup of the government side hospitals? Overburden of the patients, no any rules, and all the system is in the destroying system. So what we teach to the residents, actually we are teaching our residents about the ethics in these conferences, but contrary to that, when we are going into these hospitals, the scenario is totally changed. Even we cannot change this issue.
That's the unfortunate part of it, because in the government hospitals, most of the people are very poor, and the doctors don't behave that well. And when they go into the private hospital, their behavior changes. But on the other hand, I have worked in both. As you know, that I have been in government hospital, and then I went to Aga Khan. At Aga Khan, for example, people will order certain investigations without thinking about whether the patient can afford them or not. So that is the other side of it, and I always say that, you have to work in the government sector to realize how poor the people are. And some of these people have to sell their property to get treated. And, we don't realize that doctors, that, how would they, these days, it's so difficult for people to survive in this country. And now look at the expenses in the hospital. And if you do a second procedure, your, expenses go up.
So we've heard the physician's point of view on this, but to be able to understand this problem, we have to hear the other side. We have to hear what the patients have to say about this. And there's tons of data on this from around the world, countries with different languages in all sorts of hospitals, with state-funded hospitals, private hospitals, insurance-funded hospitals. And the data on patient complaints, the data on patient satisfaction both clearly state that there are certain things that the patients don't like in physicians. Firstly, most complaints arise from patient communication, and we've talked about that. And communication is the key. We all understand this. Wherever you're working, whatever language you're dealing with, communication is the key. And the other thing that they've looked at is what happens after a complication. And a lot of these complications end up in lawsuits, some of these don't. And then when they studied these patient complaints and patient complications and lawsuits, they realized that certain points in an initial encounter between a physician and a patient that can sort of predict whether this patient is going to be dissatisfied or going to complain or not. And one of those things is whether the physician makes a patient and his family smile. So if you can make a patient and his family so comfortable in your initial encounter that they're smiling, it actually predicts quite reliably that the patients are not going to complain or are going to be satisfied. And one other thing that has been shown to reduce patient dissatisfaction is investigations. If you investigate more, patients tend to be happier. That's what the data suggests. So there you go. But that's you can't argue with the data. And
Okay, thank you, Professor Shah. We need to draw the session to a close. Thank you very much.
Thank you.
Right, next up is Professor Tariq Khan, who's going to talk to us about management of TBI, I think, in LMICs. Is that correct, Tariq?
Settings.
Low resource settings.
And because Tariq is very good, he can squeeze that in 15 minutes instead of 25.
Although in the book is written 25.
But we know you're very good and you can do it in 15.
Yes, thank you very much, Professor Salman and your team for inviting me here. You have done great work in organizing these workshops, seminars, and especially the webinars, which you did during COVID time, really were very fantastic. So my talk is on neurotrauma care in low resource settings. If we get, this is where I work in Peshawar. Some of you have seen this place. So this is some data from previous times that 74% of surgeries for TBI are needed in LMICs, and that 89% of surgeries for traumatic spine injuries occur in the lower and middle income countries. And we know that 5 million neurosurgical cases go untreated each year. This is in part due to lack of neurosurgical care providers. And the WFNS has spearheaded efforts to monitor the number of neurosurgical providers around the globe since 2016. And you can see that how they made this map. Key Park and his team did a lot of work in that when Franco Servade was the president. And this is very interesting map. It shows exactly how many neurosurgeons are where in which country and what facilities are available. So when I came to Pakistan from Belfast, where Nicola is now, so we saw that we had to deal with such sort of traffic and such sort of activities. So we needed to innovate in low resource settings, and we need to integrate into the health system and in the today's universal health coverage and inform policy through research. And we felt that we need to take a holistic approach of this. Some of you may have already heard this talk. So going from prevention, very important pre-hospital care, and the most important then rehabilitation. This is a survey which we did from Jaipur, India, Peshawar, and from Indonesia, and Asian Association Society of Neurosurgeons. Peter Riley did this survey, and we saw that, looked at the use of the helmet and seat belt, and we saw that majority people are not wearing seat belts or helmets at all, and it's still the case even today, actually. And then we have this thing to try and get into the Guinness Book of Records to see how many people we can fit on a motorbike. And we think that one helmet fits, protects everybody. So we started with the strategy of prevention. We felt that prevention, as everybody says, prevention is better than cure. And we started doing seminars in every neurosurgical conference in Pakistan and many other countries. We started doing neurosurgical public awareness seminars, poster competitions with students as well. And then when I was the chair of the Neurotrauma Committee, WFNS, we engaged with the Think First International, which is an organization US-based, which works for prevention of head trauma. And we did our first public awareness seminar in ICRA in 2019 in Peshawar, for that. Then in that survey, we looked at who provided emergency treatment at the scene of injury, and we found that it was the lay people. There was no health providers available, no ambulance people available. And also did a nurse or doctor accompany the patient. And it was found that no, it was, even if there was an ambulance, there was no technician or no suction or no oxygen in that ambulance. So it was private vehicles which carried the patients to the hospital. And from data, we know that 50% of patients who die from TBI do so within 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. And we found this data again that 59% of trauma deaths occurred in the field in high-income countries compared to 72% in middle income and 81% in low-income countries, which is a very, very high rate. And that's because of poor pre-hospital care. And then also the length, we looked at the duration to surgery, and we found because of the long distances, lack of neurosurgical services, they had to travel to long distances for their surgery. Knowing that the treatment is geared towards prevention of secondary injuries and rehabilitation, and secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality, and longer the delay, greater the mortality. So it was agreed on with the governments that we needed to provide first aid care, and we got 111, 122 services in Lahore and in KP as well, which are doing a very good job in that. Then guidelines, we all know that are very important, and guidelines are setting the minimal standards of care from the exigent side, and we need to agree on minimal standards of care, core guidelines, and then a system of care which grows as trained personnel and resources become available. And guidelines should be made from assessment of the need, and guidelines look at the local resources, the profile of injury, the geography, the resources, and the protocols. We know that we have got the Brain Trauma Foundation guidelines, but it's very difficult to follow those guidelines. And this study was conducted in Colombia by Andres Viano. We had requested him at that time, and they talked about beyond one option of treatment for traumatic brain injuries, a stratified protocol called Bootstrap. And then we wrote a commentary on that, from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle income countries. So the scope of guidelines basically address treatment, interventions, monitoring, and treatment thresholds, and they're not intended to cover all topics. And these recommendations are intended to provide the foundation on which protocols can be developed that are appropriate to different treatment environments. And this is being now studied in Colombia now. And this is the areas which they cover: pre-hospital care, emergency room care, surgical theater, and ICU care. So we all know that in-hospital management is guided by GCS monitoring, CT scan, ICP monitoring, pupillary response, and the goal is supportive treatment and prevention of secondary damage. So the Brain Trauma Foundation Level 2A evidence that bifrontal decompressive telemetry has been shown to reduce ICP and stay in ICU, but not the outcome score extended at 6 months. And that we need a large frontotemporal telemetry, at least 12 by 15 centimeter. And you all may have looked at this study, the consensus statement from the meeting done in Cambridge some time back. ICP monitoring. So level 2B data from ICP monitoring reduces hospital stay and 2 weeks post-injury mortality, and ICP should be monitored in all salvageable patients with GCS 3 to 8 after resuscitation, and also indicated in severe TBI with normal CT. But then we have the high-end ICU in the high-income countries, and then we have ICUs in the lower-income countries. So it's literally impossible to be measuring ICP in these settings. So guidelines for lower and middle-income countries. The majority of severe TBIs patients globally are managed without ICP monitoring. No recent literature to guide management in non-monitored patients. Large part of literature comes from well-equipped large centers in high-income countries, and there are no resource-based guidelines in LMICs to guide severe TBI management. So the best TRIP trial, I know a lot of people have questions on that trial, but it's the only non-tested ICP monitor trial by Chestnut and all, and it found no evidence of outcome difference for monitored non-monitored patients. And then the same group developed the consensus-based management protocol, the CRE-wise protocol for the treatment of severe TBI, based on imaging and clinical examination for use when ICP monitoring is not involved. This is not a substitute, but a supplement for empirical data, an effort to provide for the vacuum left by the absence of evidence-based guidelines. So in Peshawar, how we do it? So if a patient comes in and with severe TBI, we would be doing a decompressive cranectomy on admission. And some people have started now calling these preventive decompressive cranectomies. And then, of course, if possible, we would do, if the patient is not someone we want to do a DC, then we would do IC monitoring through an intraventricular catheter, or we would use the Crevice protocol. So these are the things where we would do in decompressive cranectomy when diffuse brain edema without brain contusion, subdural hematoma, effacement of basal systems, midline shift, GCS low, and age less than 70. So some people question this, and I've started questioning myself as well as I'm reaching 70. So maybe that depends on the condition of the patient, really. So the management protocol is Marshall score on CT brain, interval CT scan, clinical score, GCS, neuroworsening, pupillary response, and then 4-tiered management response. So you all know, I'm sure, the Marshall grading system with the cistern, the midline shift, and the mass lesion. So how it works basically is that you initially do a CT scan and then repeat at 12 hours if initial was done less than 4 hours. And then every 24 hours, we do the CT scan. The CT scan is done, the patient sedation is stopped, clinically examined, and then depends on how the patient is either put back to sleep or then weaning process is started. And the tier 1 therapy is hypertonic saline, mannitol, and maintain normothermia. And then the tier 2 is to hyperventilate and increase the hypertonic saline by 3% continuous infusion. We've recently been able to get 3% saline, so we've started using that more than mannitol, really. And then tier 3 is decompressive cranectomy, and some people would do high-dose IV barbiturates, hypothermia, which is controversial. So we would go for the decompressive cranectomy in that. And tier 4 are untested protocols using nimodipine, magnesium, etc. So the escalation of the therapy is done when there is neuroworsening, decrease in the GCS of 1 or more points, new loss of pupil reactivity, interval development of pupil asymmetry, new focal motor deficit on the Cushing stride, or no improvement or worsening on follow-up CT imaging, no acceptable response to initial therapy. This is the matrix. I'm not going to that, but I think this is very important, the support matrix, because many people don't know when to then wean off from the ventilation. So I think it's important to look at the Marshall score, the pupils, and the motor response. And as you see, as the hours go by in 48 hours, you can see that there's more yellow. That means that there are chances of weaning them. And as time goes by, you can get an idea which patients you can wean or take off the ventilator, or whether you want to do a tracheostomy or whatever you want to do. When I initially came back in early 90, we did not have ICU. So we found that doing a tracheostomy for a severe TBI helped a lot with these patients. Now, of course, when in the ICU, depends on when we want to do a tracheostomy, early or late. In that survey, again, we looked at where were the patients discharged to, and we found that they were discharged home to the family, and we found a very nice paper from Aga Khan, and found out how to train the relatives in managing them at home to do that. So because this is a very important but neglected in developing countries because of poor resources. I just want to show you the comprehensive policy recommendations for head and spine injuries, care and LMICs. This was developed by Harvard School of Medicine, Key Parts Group, and the Northwest School of Medicine. And these were policy recommendations for lower and middle income countries for the government. And the idea was that 80% of the world has access to essential neurosurgery, and 80% of the world is within 4 hours of a neurosurgical center by 2030. And we were hoping that 90% of LMICs with National Neurotrauma Plan in place by 2025. And what we did in Pakistan was that the National Vision for Surgical Care 2025 was developed according to the National Surgical Obstetric and Anesthetic Plan for the Universal Health Coverage 2030. And we were able to embed hydrocephalus, spina bifida, and traumatic brain injury into the National Surgical Plan 2025. We did this workshop in Peshawar with the help of, again, Harvard School of Medicine. A little bit about global neurosurgery. In addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And this WFNS Committee of Global Neurosurgery was launched in 2019 in the ICON. It has been doing a great job. We helped a lot of neurosurgeons in Afghanistan. And now we have started, Moody might know that we started trying to help to develop neurosurgical care in Sierra Leone as well. And 2 students have already gone to Rabat for training, one for short-term training and one for long-term training. And the objective of the committee is to achieve universal access to neurosurgical care, to align and coordinate all global neurosurgery activity within WFNS to reaching the goal, to stimulate and facilitate relevant research to inform policy, to engage with surgical stakeholders for building integrated surgical system, and co-educate for investing in surgical care for all within universal health coverage. And I must tell you that in the G4 Alliance group, at this time, there were 13 neurosurgeons sitting in that meeting in Geneva, which is a very big achievement. So we are involved very much with universal health coverage as neurosurgeons as well. This is just something which I thought has become easier now because of the support by training and feedback, teleradiology, and virtual surgical assistant and guidelines. So now you can really say if you want to do task shifting or task sharing, you might be able to do that because of that. I don't know if they still practice this in Belfast or not, where the general surgeons used to operate in the periphery with the help of the neurosurgeons. In my time, they used to do that. Something very important for you, the Global Neurosurgery journal has come out, part of the Right Journal, and the head is Gail Russo. Moody's on one of the editorial board as well. And I think you will find that if you send your articles to them, they will be, able to try and print your articles there. I think that'll be very helpful. And I would like to invite you to the first WFNS International Global Neurosurgery Conference, 23rd to 26th February, 2024, Peshawar, Pakistan. And we will try and accommodate residents and young neurosurgeons and try and help them with their registration and accommodation. Thank you very much. On time?
It was great. And thank you so much for being concise. So the tea, I was said that the tea is served. If you still want to ask questions, having said that the tea is served, please go ahead and then we'll go for the tea.
Great.
Okay, that's it. Answer done. Oh, that was fun.
On कर देना है अभी
thoracolumbar fractures that do not need surgical management. For example, the wedge fractures or single end plate fractures or pincer fractures, or even incomplete or complete burst fractures without neurological deficits now no longer need surgery. We used to brace them a lot. Now there's a compelling evidence that even without bracing, these fractures heal without long-term differences in pain or neurological deficits, as long as the patients are mature to remain hyperextended in their postures and not bent forwards. I usually in patients who I feel that will not be compliant, I usually prescribe a TLSO brace in tailor-made for the patient in hyperextension and follow them up with serial standing X-rays to see how the fracture is healing. I don't routinely do CT scans or MRI scans unless the patient's job requires that he bears weight, for which reason you have to be sure that the fracture has healed. And of course, it's no longer indicated to fix these fractures unless there's non-union or other problems. Surgical management is indicated for alignment restoration, deformity correction, neural structure decompression, and achievement of a stable spinal column. For me, the biggest indication is the stable spinal column. Surgical decompression is almost always done with stabilization. I would never ever decompress a spine fracture without stabilizing it. And we sometimes see patients who have undergone that can only make these patients worse, whether it's an unstable spine from a trauma or unstable spine from a metastases. There's enough evidence to prove that decompression without fixation will make these patients worse. So whenever you're decompressing, make sure you're also stabilizing it. Fixation options include posterior lateral fixation, anterior lateral fixation, or combined approaches. And last time I presented topics relevant to this one, there was a lot of discussion about anterior or lateral or posterior approaches. And so this time I've come prepared. There is actually a lot of literature on the comparison of these. And we know now, in fact, there are 4 randomized controlled trials already conducted, one meta-analysis, which concludes that there's no difference in neurological outcome, in long-term pain, in return to work, or in the post-op Cobb's angle, whether you do an anterior approach or anterior lateral approach or only a posterior approach. However, there's one RCT which clearly shows that anterior approaches, and it's also our experience, that anterior approaches are associated with longer hospital stay, more blood loss, and a higher risk, a higher cost. It's been more than 10 years, I have not done an anterior approach for a thoracolumbar fracture. I feel almost all fractures can be adequately reduced and fixed with the posterior only approach. It depends the type of screws you're using or the techniques of your reduction. And this is just one example. So here you would notice that I've done a few things. I've used the fracture fragment for screw placement. I've gone 2 levels above, so it's a long segment fixation. Some would argue that I should have included S1, but that's just one example. The bottom line is you can reduce every type of fracture through a posterior only approach. There has been a lot of debate when we were in training about the timing of surgery. First, there was a lot of literature that early surgery, and you see the same names coming up with new papers every couple of months. So Michael Fellings published maybe 1 million papers on this topic. And the debate has been whether early surgery improves neurological outcome. And we know now that it doesn't. And then there was a debate that, well, maybe early surgery does improve neurological outcome, but early surgery is also associated with the higher complications because these are trauma patients with systemic problems that you don't exactly know of, and they're missed injuries, and early surgery may lead to more compromise, more physiological compromise. But now we know that early surgery actually does not even worsen outcomes. Now, the question is, what is early surgery? And on this, the literature is divided. Some people say that until up to 4 hours is early surgery. Some people say that early surgery is within 24 hours or up to 72 hours. But we do know that early surgery does improve length of stay, does improve cost, does improve risk of complications. So early surgery should be suggested. And early surgery, by early surgery, I mean within 24 hours, is supported to be safe. Now, there is a consensus statement from WFNS CNS, and there is a consensus statement that there are nice guidelines on it as well. And both have not been clear on the timing of early surgery because the literature is not clear on the timing of early surgery. But both these guidelines clearly suggest that early surgery is indicated. It does not improve neurological outcome, but it does improve length of stay and cost and improves risk of complications. There are other topics which have been of controversy. For example, short segment versus long segment fixation. There are a couple of clinical trials registered on Prospero on this very topic. There are some trials also which have been done on this topic. These are low powered trials, not a lot of patients, poor randomization, so I'm not going to quote that, but the bottom line is in certain fractures, short segment fixation works as well as long segment fixation. And this is the conclusion of most of these trials. But remember, there are certain cases where you can't do short segment fixations. For example, if there is fracture dislocation, or if there is a coronal imbalance, or if there is a significant kyphotic deformity or a sagittal imbalance, then short segment fixations, as we know from scoliosis surgery, is likely to fail, especially at the proximal levels. So even the trials do not include these patients in their inclusion criteria, but for patients where both of these can be considered, short segment fixation has the same results as long segment fixation. Incorporating or leaving fracture fragment, well, I almost always try to incorporate the fracture fragment. Sometimes I would only put in 30mm screws only to engage the pedicles of the fracture fragment. When there's a big fracture fragment that is likely to be displaced by screws, then I don't use it, but I try and incorporate every time we can. Even if I can get one pedicle in the fracture segment, I try and incorporate it. MIS versus open, there's no reason to suggest that in patients with thoracolumbar trauma who can be done with minimal invasion, they should get minimal invasion, because remember, in these patients, you don't have to put bone graft in. This is basically internal fixation, and the fracture will fuse on its own. So MIS should work. There are clinical trials registered on Prospero. We are waiting for the results. But theoretically, there's no reason why it shouldn't for certain types of fractures. Polyaxial versus monoaxial screws, I always use polyaxial screws because they're on the shelf all the time, but monoaxial screws tend to have better strength. So whenever you have a large fracture dislocation or a coronal imbalance, maybe monoaxial screws should work better. But there's no evidence to suggest the advantage of one over the other. The pull-out strength is the same for both. There's plenty of literature on the length and diameter of screws for thoracic spine and lumbar spine. Generally, any adult patient should not get less than 6mm screws, 6mm diameter screws, or a length of less than 40 but of course, there are all sorts of patients. I use at least 6 or 6.5 for thoracolumbar fractures, all segments. There is some evidence to suggest that fusion material injected within the fracture fragment or within the pedicles may improve fusion outcomes, but it's the technology that's scarcely available. We don't have it. But generally, if you're not decompressing, internal fixation is enough. You don't have to put bone grafts on. If you're decompressing, then you use the autologous bone, and you need that for fusion. I sometimes have to use artificial bone grafts. I'm not convinced it works, but it's all we have at the moment. I don't use BMP. It's expensive, it's controversial, and it has a lot of complications. And there's enough evidence to antibiotics not to talk about it, but I only prescribe a single shot of preoperative antibiotics and do not prescribe post-op antibiotics. Thank you.
Thank you very much, Shahzad, for an excellent talk. I'm sure you know that the spine committee is sitting here as well. So whatever you said, they are taking note of that. So any comments, questions from the young neurosurgeons and from the residents first, and then from the faculty maybe? So the faculty, anything?
from the Northwest University in US, there is a research on spinal cord injuries and their treatment. And they are using what they call dancing molecules, which contain nanofibers, and they have been shown to be effective in mice, that even in total injury, the mice have started walking. So now they are conducting human trials. So we should be aware of that. That's a good thing.
Yeah, that's something exciting to look forward to.
Maybe I would like to ask somewhat different question from the spine committee. That have you had any consensus statement on firearm injuries of the spine, and whether we know that neither the TLEX score nor the Dennis classification, whatever, really works in that, and of course, steroids are totally forbidden in that. Thank you.
Yeah, agree. There is consensus on that, and majority of the firearm injuries do not require any stabilization because they are majority of the cases tunnel injuries, and those tunnel injuries are stable injuries generally. And secondly, steroids do not work, and slowly and gradually, majority of them will slowly improve with time. So we know that as well. So there is enough evidence. There are lots of evidence on lots of statements made here, and but there's not enough time to go through the whole thing. So we agree with some of the points you made, and we disagree on some of the points according to the consensus of 15 people sitting and talking about it, that what should be the consensus. So, but it's all there on the WFNS Spine Committee website, and it's also, the papers are also there, and along with that, the recommendations are already there. So maybe have a look, and it might be interesting.
So for students, there's only one absolute contraindication for steroids in spine injury, and that is firearm injuries. So whatever you do not prescribe steroids in firearm injuries. And I completely agree, firearm injuries almost never need stabilization. And these are the patients who also have retroperitoneal abdominal injuries. So these are sick patients to begin with. And in fact, there have been initial concerns about the risk of CSF leak in firearm injuries because there's a penetrating wound going through the canal, but they almost never get a CSF fistula, whether intra-abdominal or externally. And whatever you do not decompress a patient with a firearm injury. You can only get into trouble.
Yeah, well, there are certain definite indications there for surgery in firearm, but more and more people try and treat it conservatively. Yeah.
Because you are taking all the button side and you come from the back, and then you cause more problems.
Shehzad, still I'm confused. Still I'm confused. If you have written a recommendation from a society, so what will be the legal and ethical importance if we are not following these guidelines?
So, Dr. Mumtaz, guidelines word over are not rules. They are suggestions. And guidelines are based on evidence, which we must remember is ever changing. The guidelines for certain pathologies 10 years ago do not apply here anymore. And as I said, it's an evolving specialty, and guidelines. That's why are also revised every few years.
Yeah, the other thing is that we don't call them guidelines anymore. We call them recommendations. And it says clearly that in all the statements, majority of the statements, you say there is not enough evidence to clearly say that this is really the case. But there's a suggestion, because majority of the data is not high quality data. And majority of the data, it really does not prove anything, because me and you are just doing it. We are not doing it in any structured way. And that's why there's a problem. So Spine Committee itself is going to start from January, our own big study from all over the world, and see if we can get any data on many of the topics that we are seeing.
Okay.
Isn't it true that most of the surgeons do spine work at the behest of the patient and his relative, because they want some surgical procedure done in order to, and there's a lot of pressure, obviously, on surgeons, and particularly from the rural areas and from Northwest province, that people think that a bullet is poison. It should be removed. I knew a patient who came from Balochistan, I think. He had a lot of pain. He had a foot drop and pain after he had a bullet injury in the leg. And he came for several months. He didn't get better. Then he reappeared after a year and said that my pain is gone. So I said, what did you do? So he said, I killed the man who had shot me. And the pain went away.
One thing which I want you to discuss. Most of the time there are the recommendations and there are also the rules. But one thing which is neglected is the experience of the surgeon, because most of the time when you have the burst fracture and you think the patient has no neurological deficit, but more than 50% of the canal is compromised. In that very case, this is the little bit questionable whether you wanted to do the surgery or not. So you have just told us that the surgery and the conservative treatment has no any difference at the end. But again, who will decide? So one factor is the surgeon's experience factor. Sometimes you also think if the patient has neurologically intact and the canal is compromised by that burst fracture is more than 50 to 60%, then who will decide? Again, you have to take the decision to open and fix it or not.
So Dr. Das, that's not the argument, I would say. The fact that there are so many clinical trials on these topics and there are so many different guidelines and recommendations tells you that the decision making is not easy. And at the end of the day, as a physician responsible for that patient, you will have to decide on what in your hands is the best thing for that patient, in the patient's best interest. However, if the patient does ask for an intervention that is not recommended, you will not be able to defend that intervention in any court of law. So we get a lot of pressure from our patients to asking us to operate on hypertensive hemorrhages and cases where we know that the outcome will not be good. And I do not do it on the patient's behest. And because, as I said, the patient hasn't gone through 10 years of education to come to this level. I have, and it's my responsibility to educate the patient and not vice versa. But I agree that sometimes in certain situations, pressure can be mounting. And so at the end of the day, is the physician who's responsible in how to best care for the patient and also for himself. So there may be...
Thank you very much, Shahzad. Thank you for your talk. Very grateful. We'll move on to the next speaker. And that is Dr. Yusuf Sheikh on cervical trauma guidelines.
Right, left, right. Okay, so I think a lot has been, a lot of is going to be repetitive here because the guidelines for cervical injury and thoracolumbar injury are more or less the same, particularly the role of steroids. And I agree with 95% of the things that Dr. Shahzad Sameem said, that all of the cases of thoracolumbar management, the points of fusion versus non-fusion. So moving on to the cervical injury, we know that all patients who have cervical spine injury should be managed aggressively. And the first and foremost aspect is to identify such patients. And any patient who has the minimal possible neck pain, apply the collar and have a very low index of suspicion whenever you come across patients who have any sort of cervical spine injury. The objective of primary immobilization is that you prevent the secondary spinal cord injury, that is from the edema and the underperfusion, hypoperfusion, low circulation, that you have to prevent. Whenever the patient comes in or in the field, you have to immobilize the cervical spine immediately. Transfer him to a board and then you have to strap him adequately. I've seen patients come in through the ER with cervical spine head strap, but the body is completely freely moving. The neck, in fact, acts as the fulcrum for the body to move. So you need to adequately strap the shoulders and as well as the pelvis for proper transportation. And once the patient is inside the hospital, then you can have a dedicated, detailed examination, assessment, CT, MRI, and all those things. Now, in terms of guidelines, now it is very clear that any sort of cervical spine injury, either suspected or indicated, CT scan is the modality of choice. And if you do not have CT scan, only in those circumstances are X-rays indicated. But generally, I personally believe that if you do not have the facility for CT scan, instead of wasting precious time getting X-rays, which will not be helpful if the patient is getting transferred to a definitive treatment facility, it is best to transfer these patients to a setup who has a dedicated spinal unit or who has a 24-hour availability of CT scan. So yes, the guidelines still say that, because in the third world countries, there are countries who do not have 24-hour availability of CT scan. But I think in Pakistan, we have things significantly developed and most of the hospitals have a CT scan. So CT scan is the modality of choice. If you are doing plain X-rays, then there has to be complete from the base of the occiput down to the level of C71. You need to have open mouth views, but I don't do that because we generally get a CT scan that is done immediately for good reconstruction, pathology description, fracture identification. This is good. And in most circumstances, it is said that after CT scan, whether you need an MRI or not. Now, MRI is not always available immediately. So on the basis of CT scan, you can immobilize, admit, and start the management of the patient. In most circumstances, you will come across patients who will have locked facets. So the question comes, whether do you want to do an MRI or you're going to manage the locked facets with the help of tongs or close reduction. So a general practice that we do and we generally advocate is that if you have the facility to get an MRI done in the next 30 minutes or so, because we work in a tissue care hospital, we can get it done immediately. So we get an MRI and then apply the tongs. But if there is any delay, I think tongs or decompression works better. In case of locked facets, I've yet to see a patient who has unfortunately deteriorated after application of tongs and the MRI was not done. So in case of CT scan, X-ray, I see locked facets, I prefer to put in the tongs, and then whenever the MRI becomes available, we can do that. So the guidelines say that all patients who are neurologically intact, awake, have no neck pain, no tenderness, can adequately move the neck, arms, they don't need any radiological investigation, not even an X-ray. You can discontinue immobilization. But in a patient who is symptomatic, having any sort of neck pain, then a CT scan is the modality of choice. X-rays are only indicated if you do not have a CT scan. Patients who are unconscious or intoxicated, have low GCS, we immobilize them and get a CT cervical spine along with the CT brain at the first instant. Role of methylprednisolone. Yes, this is again a controversial topic. We don't use it. And the evidence largely suggests that the use of methylprednisolone was historically more on the basis of faith. And a lot of surgeons previously used to do it to avoid digitations because there were some studies indicating that, yes, there is a role of steroids. But now there's been level 1, 2 evidence, as Dr. Shazad Shamim suggested, that there's absolutely no role of steroids. I still see people who give them a single shot of methylprednisolone or a loading dose, but the continuous infusion that is required is a very high dose. And I think the patients who actually improve are those who develop steroid-induced myopathy and recover from myopathy. So in terms of guidelines or evidence, there is no class 1, 2, or 3 evidence that actually indicates the role of steroids, either in spinal cord injury, cervical or dorsal spinal cord injury. Now, there is a new aspect that I've been looking at, that is the medical management, that is the cardiopulmonary assessment. Now, there is level 2 evidence that any patient who presents with spinal cord injury, the neurological outcome can improve provided that you keep the mean arterial pressure more than 85 millimeter mercury for the first 7 days. Now, majority of such patients, especially in patients with cervical spine injury, we see patients who are Asia A or Asia B or whatever, and they have spinal shock. The blood pressure is low. You need to optimize that. Generally, as residents or as surgeons, we see patients with Asia A injury, cervical spine, and we just sort of get relaxed that this is Asia A, he's not going to improve, there's not much we can do. So we just counsel the patients badly. But I have actually seen maybe 1 or 2 patients improve Asia A. Now, I'm not saying that Asia A patients are going to improve, but there is a possibility that because these patients are in shock, he might actually be Asia B. and you misinterpret these patients as ASIA, or the resident did not actually check the sacral sensation. So there is a possibility. So irrespective of whatever the grade of ASIA is, a patient with cervical spine injury, we always treat them aggressively, immobilize. If they're locked facets, apply traction, and keep the mean arterial pressure more than 85 millimeter mercury. Now, a lot of work has been done in terms of what medical drugs can be used to elevate the blood pressure. Now, phenylephrine has been recommended for patients above 55. And in cervical or high thoracic lesions, norepinephrine is recommended. Dobutamine is not recommended because of its effects on vasodilation and possible risk of reflex bradycardia. So we commonly use norepinephrine, and in patients above 55 years of age, even with cervical spine injury, we use phenylephrine to keep the mean arterial pressure above 85 millimeter mercury. 40% of these patients do not get extubated. Yes, cervical spine injury, C4 level injury, C5 level injury. We see these patients have respiratory difficulties. You ask them to cough, they are unable to cough. But irrespective, if the patient has dislocated facets, dislocated injury, and the cervical spine injury classification score suggests instability, we plan early surgery and tracheostomy if needed, and early rehab, physiotherapy, occupational therapy, and all those things. Now, in terms of early versus delayed surgery, yes, this is again a topic Dr. Shahzad covered it very well. Now, we know for sure that early surgery is beneficial because it reduces the hospital stay and complications. Late surgery has more problems. But the role of early surgery is, the timing has not been completely defined yet. Early, very early, very, very early, because some studies go on to describe early surgery as within 4 hours. But a generally accepted criteria is that within 24 to 72 hours is considered early surgery. So if you plan early surgery, the hospital stay and complications tends to reduce. Now, this we have now. So there is evidence that a surgical decompression and stabilization within 6 hours of partial spinal cord injury will lead to 70% of patients improving by 1 or more ASIA grades. So probably that ASIA A will go on to ASIA B. So not much of a difference, but imagine ASIA C going to ASIA D. So these patients will be able to move independently. We know predictors of outcome ASIA A that we commonly use, the Frankel grading, and the basic score. Now, I'm not sure if any one of you is aware of the basic score, but this is the based upon the cross-sectional appearance of an MRI. We try to use it now because it says that basic 4 has poor outcome, basic 0 has good outcomes of injury, but we try to use it now so that we can properly validate that whether or not this score is effective or not. For documentation purposes, we have started using this score for the past 3 to 4 months. Now, we have these WFNS spine committee recommendations that are there on the website, including thoracolumbar classification, spinal cord injury, spinal treatment, and then these are the recommendations that are there on the website for all of us to see. Now, there is again the role of traumatic syndromes. Now, from the historical perspective, we have been taught that central cord syndrome should not be operated. I don't believe that is true. If the patient is neurologically stable, if the fracture is stable based on the anatomy or the type of fracture, then yes, no surgery is indicated. But if the fracture is unstable based upon the cervical spine injury classification score, if the patient has neurological deficit, ongoing compression, or there is deteriorating neurology, then yes, this patient needs surgery. Now, there are certain radiological findings that predict the outcome. The presence of facet dislocation is suggestive of poor neurological outcome, is suggestive. Okay, so MRI T2 sequences is acceptable method to rapidly screen patients with cervical injury. Predictive findings on T2 sequences including the sagittal grade, the length of the injury, the diameter of the injury, basic grades, and some studies suggest that yes, these are the radiological parameters that can predict outcome. But instead of embarking upon the radiological parameters, we have clinical parameters, the most important ASIA. So we can use radiological parameters as a means to predict, and then we can validate them further when we have bigger studies or bigger number of patients. Decompressive surgery is an effective treatment in spinal cord injury and should be performed as an early modality. And there is no clear evidence that non-operative treatment is better or equivalent to delayed surgery. Yes, there are papers that suggest that non-operative management may be as good as operative management. But is non-operative management better than operative management? I think there were previous studies, but in the past 5 to 8 years, things have changed and evolved significantly. And I think early surgery is recommended. Pharmacological treatment, yes, there is no role of steroids. The blood pressure has to be optimized. Mean arterial pressure has to be kept above 85 millimeter mercury. And I think that's probably it. Thank you.
Thank you so much, Dr. Yusuf. Any questions, comments?
There are many spinal surgeons sitting here. Can I just ask an innocent question? You know that when the spinal cord gets injured, a lot of chemicals are released into the CSF, and they cause more damage to the cord than the earlier injury. So does anybody believe that releasing the CSF, which contains all these chemicals, does it do any good? I know that people don't do it, but it seems like an attractive idea.
I think this is an excellent question. I have read about it, and a lot of studies being carried out on it. What they do is that even in patients who are Asia A, they have spinal cord injury, no dislocation, no fracture. Now, what they're trying to do is do an expansile duroplasty. They say that at the level of injury, there is inflammation, edema, cytokines. So what they do is they perform a durotomy and they do an expansile duroplasty, indicating that there's some sort of local CSF flow or microcirculation that can improve. Now, this is something that is being done experimentally. There are no long-term studies, but yet, yes, I've gone through it and I've seen some papers on it. This is currently being investigated, that there might be benefits of expansile duroplasty that will improve the local circulation and mediator flow.
There is a lot of group that is experimenting some preliminary results, but still not in final.
Yes, not finalized.
Yeah, so there is a London group that they're experimenting with this, basically they're applying the principles of the cranial decompression to the spinal structures and spinal decompression. So nothing final yet, but there is people which are working on that. Yes.
In the same prospect, I would like to ask, is there any role of stem cell implantation in Asia A?
I don't know, but we as surgeons, I don't think there is any role. I have seen some people do it here, but my personal experience and based on the evidence that we have, the surgical evidence that we have, I don't think there is any role of stem cell transplant. There is absolutely no role. In fact, there are possibility of causing infection, probably inducing the role, possibility of cancer, but there is no role.
Actually, there is not enough evidence at the moment that it works. There are 2-3 centers who claim they have some results, but if you give aggressive therapy, physical therapy, then it works. We know at the moment that brain-machine interface does work. We know that people who have had a stimulator put in at the same time through Wi-Fi and pass the signals. And if you do that, and if you do aggressive therapy of those patients, 7 out of 7 patients in Switzerland, 7 out of 7 patients in Duke are walking. And these are old injuries, 80-year-old injuries. Those are the people who are walking. But at the moment, the cost is humongous and nobody can afford it at the moment. There is a lot of work going on and there are many other centers who have taken it up. So, but for stem cell, there is really no evidence at the moment, but because, if you give aggressive therapy, etc., we know the stem cell do work. The problem is, what else do you need to put in that area? We don't know, and what dose. So we have seen cancer, we have seen other negative effects, and we have seen some benefits, but we have seen some benefits in people who do not put stem cells. So we don't know what's happening. There is no evidence. It's written down in recommendations that no evidence that it works, and it should only be done as a trial and nothing else. I think we have to be very careful. Nowadays, everybody's putting stem cell everywhere, but you have to be careful what you're doing because there could be serious repercussion in future.
So I would like to ask a question from Dr. Salman and Dr. Shazad. So if we get an MRI with a patient who has a unstable spine and we see that there are signal changes on the cord, like that edema or contusion is there. So will it change anything on the plan of fusion or the stabilization?
No,
Or
we, generally speaking, if there's any fracture dislocation, we pick it up on CT scan. On MRI, if the CT scan is normal and the patient has deficit, then we also do obviously an MRI. And if the MRI shows extensive signal changes in the spinal cord, or if there is cord contusion, we don't do anything. If there is extensive soft tissue injury, posterior cervical spine injury, even then we generally don't do anything. Unless and until there is evidence of instability, we generally don't fix or fuse. For spinal cord injury, contusion, the length of contusion, all these parameters predict outcome, but we don't use that as a parameter for surgery.
Okay, I just coming back to the question asked by Professor Ahmed Ali Shah that there are certain chemicals which you know is there is a study actually, and they did actually microdialysis in the brain, and the spinal cord tissue behaves the same because there are also glial cells.
Yes.
And when there is a neural injury occurs, the glutamate, aspartate, these are the excitatory neurotransmitters which actually catalyze the cellular injury more. So what they have done is that they have actually take out those samples. And when the neural injury occurs, they took out the samples with the help of microdialysis, and they have devised a medication which stops these neuroexcitatory transmitters, which aggravate the more cellular injury, but it doesn't work actually. So still, the thing is in the trial.
Yes.
And I don't know whether you take out the CSF through the lumbar puncture, you can get all these excitatory neurotransmitters and their levels, which can judge you or give you a clue that the quantum of that neurotransmitters should be calculated and need to be, given a trial of medication that stops or prohibit the further cellular injury. So the people are working on this, and I don't know, but this is a good,
So there have been a few papers who have looked at lumbar drainage after spinal injury for two reasons. One, to wash out the inflammatory nutrients there. The other was to reduce the spinal pressure. On the same principle that reducing ICP will improve outcomes from traumatic brain injury. But as Dr. Salman mentioned, the results have been disappointing. Coming back to the gentleman's question about the role of MRI, my indication for MRI in this acute spinal cord injury are only two. One, where you do not find a fracture in the cervical, in the CT scan, and the patient is stable. I will consider an MRI, although even then I'm not in a rush to do it. And the other, when you're suspecting a traumatic disc herniation, especially when we're about to reduce a dislocated spine, a cervical spine with jump facets. But the risk of that happening is very, very low. In fact, there are hardly any cases reported. So the MRI may be helpful, but I don't do it anymore.
Dr. Salman?
Sorry,
Are we getting late, or you wanted to continue that discussion?
I just want to wrap this up.
Okay.
So my request to everybody is you should know that 20% of ACI will improve. We know this. And we know 3% of them who will improve will walk. So my request to everybody in government sector is do not disregard these patients. So it's just that only private sector should not do this. Everybody should do this. And if at all possible, do whatever is required as soon as possible. You do exactly what you do for B, C, and D, because those patients do the best. And they're the most gratifying patients. And I have a huge number of patients, and we have a list, and we're just going through adding it up, and we're just starting to write it up. But my request, it's proven. If you do these simple things, do as soon as possible surgery. Make sure you hypertense them. Make sure you give them whatever fluids, whatever medicine is required, and aggressive nursing care 7 days in at least high dependency on a spinal unit. Then your results are going to be different than anybody else. So every center should try to do this. That's all I'm going to say. So let's move on. We are running very late. I apologize.
So next topic is improving neurosurgery training by teacher of teachers, our favorite personality, and I like him most as my teacher. I remember him since long time when I was a resident, Professor Tariq Salahuddin Saab. Thank you, sir.
Thank you very much, Riaz. I think I'm really humbled by your comments, ladies and gentlemen. I think it is the burning topic. Why all we are here is to improve the neurosurgical training program. Neurosurgical training program is a big responsibility and a major undertaking. My paper and my talk looks into the recommendations, guidelines, and the strategies that needs to be devised when we have to run these programs, because I personally feel that these programs should be run in an appropriate setup, which have got the numbers, the number of patients, the number of supervisors, the backup services, the radiological and the lab facilities, but one can always look into the facilities where we do not have that, and we can sign MOUs with other institutions. To start with, I think it is the recruitment of the neurosurgical, the interns or the residents that we come to us. Neurosurgery is one of the cornerstones corresponding to a large scope of clinical pathologies and is a highly regarded surgical specialty. So what is the problem? Why we do not get the right stuff? A lack of early exposure to neurosurgery, whether it is a pre-med or during the clinical time, lack of quality mentorship programs, institutional curriculum, entering program, which are prolonged period of training and study in neurosurgery, duration of required training, and last but not the least, people talk of the quality of life the neurosurgeons have. So I think these are the things which really matters. And I think the factors for decreased number of applicants in neurosurgery obviously shows that people have complaints regarding the lifestyle, job dissatisfaction, long period of surgical training in neurosurgical residency, depression and anxiety, the pressure of type of surgeries we handle, the malignancies, cervical spine injuries we have seen, patient coming after a neurotrauma, GCS3, axonal injuries. So there's a lot of pressure from the family, and of course, the type of doctors handling these patients. And of course, at the end of the day, we also see women forced are not applying that much and they are not being attracted. And I will discuss the factors why there is a less number of female neurosurgeons. How to get the best of the best? Strategies for resident recruitment, mandatory clerkship neurosurgery program, and medical student mentorship in the days when they are into a medical school programs. The strategies, few of them, neuroanatomy lab initiative, NLI, creation of neurosurgery interest group, student interest groups, surgical exploration and discovery programs. All these above programs have shown up to 85% increase in recruitment of residents. A global perspective and contribution factors of barriers to access in neurosurgery. Now, there is a clear differentiation between lower middle income countries and the setups you have in higher income countries. And if you look at that, in lower middle income countries, there are estimated 2.5 neurosurgeons per million people compared to 14.1 per million in higher income countries. The average cost of neurosurgery training in a higher income country is above $200,000 as compared to average cost in lower middle income countries, which is about $50,000. Only 1% of neurosurgeons are trained in lower middle income countries, even though 80% of world's population lives in these countries. it is estimated that there will be a need for an additional 23,000 neurosurgeons by 2050. There is a diversity in recruitment and training, at least in the United States paper, which I've shown in systemic review, and it needs to be increased investment in neurosurgical training program. These includes the development of new training programs and the provision of financial support for the trainees. Development of standardized training modules and curricula. This needs to be taken away with the previous old model of the curriculum, and we have to devise new models. Increase support for research in neurosurgery. The new knowledge has to be there, and there has to be more review papers that has to be seen. Development of mentorship program. I think every paper talks about the mentors. They have to be there because they have the experience and they can promote and they can give you the incentive to be trained in a better environment. Is simulation in neurosurgery important to improve neurosurgical training? Yes. This study recommends that the study included a total of 2,500 participants. The authors found that the simulation training was effective in improving the skills of neurosurgical residents in a variety of areas, including technical skills, decision-making skills, and teamwork skills. The author also found that the simulation training was a cost-effective way to improve neurosurgery training. The future of neurosurgery training in low and middle income countries is something that we have to look into. There has to be a flexible program. The training program would be flexible enough to accommodate the needs of trainees in lower middle income countries. The training program would be responsive to changed needs of the neurosurgical workforce in lower and middle income countries. They have to be cost effective so that it is accessible to trainees in lower and middle income countries. Locally, there are about 2 to 3 papers, and I was talking to Shahzad. I think 2 papers came from AKU and 1 from Liaquat National. So there is a lack of papers that has looked into this area of the neurosurgical training. These looked into the lack of access to training, high cost of training, lack of standardized training, and shortage of mentorship. A critical analysis of the current state of neurosurgery in Pakistan at the present moment, it shows that there has to be a development of new training program. The authors recommended that the new neurosurgical training programs be developed in rural areas to increase access to training. You may or may not decrease at what level you can take this neurosurgical program, but sure, they have their observation. Reduction in the cost of training. Neurosurgical training has become very expensive. The tools and the backup services are not ordinarily available in institutions. Development of standardized training curriculum is very important to needs to see what they need to be taught. Increased mentorship. The authors recommended that the government provide financial support to experienced surgeons to mentor trainees. Hands-on workshops, are they important? They're very important. They are an important component of neurosurgery in training because they allow trainees to gain practical experience in performing surgical procedures. Hands-on workshop can be conducted in using cadavers, animal models, or simulated patients. There are a number of benefits to hands-on workshop. They develop their technical skills to learn more from experienced surgeons and allow trainees to practice in a safe and controlled environment. Research. I think the research base has to be an important component of the training program. Research is an essential component of neurosurgery training because it allows trainees to learn about the latest advances in this field. Research can be conducted in a variety of settings, including academic institutions, hospitals, and private practices. There are a number of benefits to research, including trainees to stay up to date on the latest advances in neurosurgery. It allows trainees to develop their critical thinking skills. It allows trainees to publish their work in peer-reviewed journals. Medical database, I think that is which is lacking in most of our training institutions. A medical data-based record keeping in neurosurgery provides a comprehensive learning resource with real-world cases, enhancing trainees' educational experience. It enables evidence-based decision-making by analyzing clinical data to identify treatment efficacy and complications. Additionally, we database supports continuous quality improvement in training program by monitoring outcomes and refining educational strategies. I think another important area to bring in the women folks into the mainstream. At the present moment, different studies shows different percentage of women into neurosurgery. And I think the US figures are about 17%. Locally, I think probably it is about 13%. Female neurosurgeons in the United States can earn on an average of 120,000 less per year than the male counterparts. That is another factor. Female neurosurgeons face a number of challenges, including lack of role models, work-life balance, and gender bias. How to increase the number of female neurosurgeons? I think we need to provide them more role models, address the work-life balance issues, and of course, challenge gender bias by educating and trying to solve this problem by different strategies. Fellowship program. Are fellowship program important? I think you cannot train the neurosurgery resident over a period of 6 to 7 years in every area. So once they have completed their residency, or maybe in some program at the end of their training program in 5th or 6th year, they would be sent for fellowship into the areas or into the institution who specializes in that very type of surgery. Fellowship program offers specialized training beyond standard residencies. Neurosurgeons gain expertise in fields like skull-based, endoscopic brain and spine surgery, functional neurosurgery, and endovascular procedures. Benefit includes improved patient outcomes, reduced complications, and advancement in neurosurgical techniques. It definitely has an impact as it exposure to complex cases and cutting-edge technologies, mentorship from experienced specialists, collaboration and knowledge sharing among institutions and regions, development of specialized centers of excellence, and strengthening the neurosurgical community through networking. It is all about technology and the latest technology. What used to be something, routine procedures or technology about 10 years back is no more valid. Now, are we going to talk about robotic surgeries, animation labs? Yes, I think we should have robotic surgery exposure to our trainees. And of course, if they want to excel in that, they can go to the specialized centers. Animation labs, immerse simulations, replicate neuroanatomy and surgical scenarios. Trainees can interact and practice procedures in a controlled environment, facilitate understanding of complex neurosurgical concepts, and it reduces the risk to patient during the turning phase and shorten learning curve for trainees. Continuous skill improvement through feedback and repetition. At the end, I personally feel that it cannot be, be a program which can be run by, one single institution without the help of interaction by the institutions like WFNS, ANS, CNS, and SNS. These, institutions need to have a collaborative and concerted support from development countries can significantly enhance neurosurgery training in the underserved regions. And I think that has to be by knowledge exchange and training programs, technology and equipment donations, research collaboration and funding, training workshops and outreach program, a sustainable long and short-term partnerships, and of course, a mentorship program. The last WFNS course was conducted by us in 2007, and I thank you all for your patience.
And thank you very much, Professor Salahuddin, for an excellent analysis on the training programs across the world, and especially in Pakistan. Any comment? Yeah, Professor Ahmed Ali Shah Sahab.
Sir.
Professor Ahmed Ali Shah Sahab. Please, can you give the mic to Professor Ahmed Ali Shah Sahab?
I've been into this business probably longer than anybody else. And I've come to three conclusions. The first one is that majority of the supervisors don't teach. We don't teach. Secondly, the college does not monitor the training program at all. Thirdly, our emphasis on not on training, but on assessment. We are fond of taking examinations, examine the candidates and tell them.
I think you very, on the ball. And I did not want it to include that, but I think if you look at the ACMCGH, which is, I think, those who have come from states, they have a monitoring system. And it's a very stringent monitoring system. And they not only that there are, there is a committee, on top of that committee, there are specialist training, specialists available who would monitor a program. Then you talked about the assessment program. So I think they all have to be, sort of interlinked. And thirdly, I think the selection of the programs which they have to be run. I personally of the firm believe that until unless you have got all the facilities available and an appropriate, supervisors, we will dilute the training programs.
You
Sir,
back?
Bit longer comment. Like a resident is going to enter like a 24-year at the age of the MBBS, 1 year for the house job, and then he get into the residency program. 5 years for that, then 1 year for the exam preparation, and then the second fellowship. So he's most likely around 36, 37 years to into the market. Our curriculum is competency-based curriculum, except few, you can say, centers. Are the residents, when they are out of this part 2 FCTS exam, they are eligible enough to perform these simple procedures independently? So my suggestion is that we should change this competency-based curriculum into EPA-based curriculum, which is the entrustable professional activity curriculum. We should include the basic 5 or 6 procedures that when the resident is at the end of the training, his supervisor must ensure that he can do these basic procedures. All of us are not working in the big centers. Some of us have to go to the district surgeon, other peripheries. So in my suggestion, if this competency-based curriculum is changed into the EPA-based curriculum, then it will be much more better for the residents.
I very well understand your sentiments and the point that you're trying to make. But I think it is we're talking about a comprehensive training program and how to improve the neurosurgical training. People who have come from different parts of the country, of the world, they probably will be able to, if you discuss with them, there is no consultant who is less than 35 years of age. You cannot become, a consultant unless you are about 30 years of age. So there is, a distance that you have to travel in your training, which is not only from the, from your internship, that is the period that you're including, but the shortest program is in our country, which has, I fought for years, and I think Professor Ahmed Ali Shah is there, and we were not, very much liked by the people who were making the policies. You need to have a program which is at least 6 or 7 years exclusive neurosurgical program. And I absolutely understand it is not about 5 procedures we're talking about. Where will you go if you have a base of the skull meningioma that we have discussed it, CP angle lesions? We are talking about a comprehensive program, and you have to have a baseline. You need to train all your residents up to that level. So it is not one thing that we are not talking about 5 procedures that you need to do. We are talking about a quality neurosurgeon that will produce at the end of the day.
Thank you very much. Thank you. I agree with you, Professor Tariq Salahuddin. I think we come to an end of this session because we are running late. Thank you.
Any question? Is that the end of the session?
So
Okay.
thank you, Professor Tariq and Professor Riaz Raja. So now for the discussion on the topic of pediatric neurosurgery, I would like to call the moderators, who are Dr. Ahmad Ali Shah, Professor Ahmad Ali Shah, who is instrumental in teaching and training a number of neurosurgeons, and who remained and I would like to call Professor Mahmood Qureshi to come on the stage and please moderate the session.
Who's first? Graham? Consola? Yeah. Okay, I think, good morning all. I think it's obviously a very exciting program going on, and it's a pleasure to introduce someone from Africa and someone who's going to be responsible for bringing together the world community to the World Federation Congress in Cape Town. And really, it is indeed a privilege for us all for hearing the chairman or the president of the Congress address us. And he's going to talk to us on why to become a pediatric neurosurgeon, because he's been trained by one of the world's leading pediatric neurosurgeons, and he has made huge progress and attracts a whole range of young neurosurgeons to go to his center to learn pediatric neurosurgery and pediatric neurosurgery. So Graham, as a world-renowned pediatric neurosurgeon, please give us your thoughts.
Great. Thank you very much, Moody. And thank you to all of you for being here, and thank you for the invitation to come to Pakistan. Amazingly, I've traveled to many countries in the world. Pakistan was #1 on my list of countries that I wanted to get to. So it's just amazing to finally be here. So thank you, Salman. I really appreciate the invitation, and it's really been a thrill the last couple of days. So it's been a fantastic morning so far. Every one of those talks merits a lot of discussion. I just want to quickly, if I may, just sneak in one quick comment about the last talk by Professor Saluddin about training. There's no question around the world that's the one issue that all neurosurgeons feel incredibly passionate about. How do we ensure that the next generation of neurosurgeons is going to take our specialty to another level? And I think it's a tremendous challenge for all of us in less resourced countries. But the one thing we do have is enormous capacity to give people proper clinical training. And I think it's quite easy to be dazzled by all the literature coming out of the developed world talking about simulation and new approaches to training. But I think at the end of the day, it's about clinical practice. And I think we have incredible richness in countries like Pakistan, like South Africa, like many other otherwise under-resourced countries. And we're still able to, I think, train extremely good neurosurgeons. And this meeting certainly indicates to me that Pakistan is doing a fantastic job in that respect. So Professor Sharif gave me the topic of why become a pediatric neurosurgeon. And I guess the context is that Pakistan appears to me, and I hope that I will be proven wrong in the discussion, but appears to be a country where pediatric neurosurgery hasn't really taken off as a distinct subspecialty. And that's true of many countries in the world. And my task for the next 10 minutes is to try and give you an indication of why I think pediatric neurosurgery is a great route to follow. Just a word of acknowledgement to our hosts, and particularly to Imad and to Mehak, who've looked after us incredibly well. Thank you so much. And just also to acknowledge how fragile our world is. Professor Sharif and I had the incredible joy of being in Kinshasa in Democratic Republic of Congo just a month ago. And the biggest group of all at that meeting was from Niger.
a country in West Africa that has very recently developed a neurosurgical training program. And Aminath Kalani, who's the head of neurosurgery there, a woman leading a neurosurgical training program in Africa, was there with 10 of her trainees, and they were amazing. They were absolutely fantastic. And because of a coup in their country 2 weeks ago, they can no longer travel, and their future is now looking very bleak. So I think just all of us, let's just embrace the opportunity we have to get together and recognize that we can't take that for granted. I've got no disclosures other than the fact that I've really loved my career. So just bear that in mind as I wax lyrical about pediatric neurosurgery. The only thing I love more than pediatric neurosurgery is cricket. And I think this is the moment where Pakistan and South Africa fell in love as cricketing partners. That famous run out when John T. Rhodes flattened the stumps to run out into Mamul Haq in that famous World Cup game, and now sort of readmission to cricket. So the older people in the audience will remember this. Maybe the younger ones don't, but it was one of those emblematic moments in world cricket. Okay, so why did we choose to become neurosurgeons? And I'd really recommend any of you who are interested in that philosophical question to have a look at this article by Aaron Cohen Goodell, which I think really summarizes very, very powerfully the many, many reasons that one might choose to do neurosurgery as a career. And as Professor Saluddin says, I think one of the things we need to do is to make sure that all medical students are exposed to our field, understand what we do, because there's a lot of misinformation, misunderstanding about what we do. It really is an amazing career. It's not something you ever want to persuade somebody to go into neurosurgery, but anybody who has an interest, I think we really have an opportunity to kind of help them to understand just what an incredible career it can be. So having chosen to go into neurosurgery, what is a particular attraction of changing your focus to neurosurgery for children? So the ISPN is one of the organizations that really advocates for pediatric neurosurgery around the world, but it's not just about pediatric neurosurgeons, it's about children. And so recognizing that actually the world's population pyramid, particularly in countries like Pakistan and South Africa, is with a median age of 17, 18. Pediatric neurosurgery is really where the critical mass of the work is. And in order to really advance the future of neurosurgery, we've really got to make sure that children are getting proper neurosurgical care. Probably the first recognized pediatric neurosurgery was Don Matson in Boston. And I really love this comment that he made, that pediatric neurosurgery is work well rewarded by the innocent faith of the patients, their uncanny resilience and ability to get well, and by their parents' understanding and gratitude, and by the great variety of conditions that can be corrected. And I think that's one of the key things about pediatric neurosurgery, that it has tremendous variation. So we have a wide range of pathologies. In a sense, pediatric neurosurgery is the last of the general neurosurgeons. But within that field, there's been explosive growth of subspecialties. And take, for example, pediatric functional neurosurgery. In many respects, it's pediatric functional neurosurgery that's driving the massive growth of functional neurosurgery as a discipline. Teamwork is non-negotiable. You've got to be able to work in multidisciplinary teams. There's some really very interesting technical challenges. But the question is, what differentiates a pediatric neurosurgeon from a well-trained general neurosurgeon who does a good job treating children? So there are a few pitfalls that you kind of become accustomed to if you're a pediatric neurosurgeon. One of them is that the clinical assessment, the default finding is that the kid's normal, and that's often not the case. And unless you're really familiar with assessing kids, you can make some serious blunders in that regard. You need to think twice about imaging. It's often a lot more of a challenge to get imaging in children, quite apart from the issue of radiation in young children. And you've got to take development into consideration, not just development the nervous system, but development the musculoskeletal system. And you've got to think long term, that a 5-year-old child you operate on today may live for another 80 or 90 years. And if you do something catastrophic to their spine, they're going to have a very long time to kind of bear the consequences of that. But for me, the reality check, and I think this is a very powerful challenge to pediatric neurosurgery as a discipline, that I would estimate that 80% of kids in the world are not operated on by pediatric neurosurgeons. They're operated on by very good general neurosurgeons or surgeons or even medical officers in some countries, and maybe even people who don't even have a medical qualification. Whoops, sorry. That's not looking so good. Do you want to use the other one? Thanks. Okay, so within that spectrum, pediatric neurosurgery, what has truly changed our practice? So over the course of my career, I've seen the advent of MR as a modality that's widely available to children, and ultrasound come back in a big way. Obviously, navigation plays an important role. So imaging is really fundamental. We were talking on the bus coming here about technology and ways in which technology may or may not actually make things easier. No question, endoscopy has made a massive difference. And I'll talk about that a bit later when I talk about hydrocephalus. Multimodality monitoring, my colleague in Cape Town, Tony Figaji, is probably the world leader in multimodality monitoring in traumatic brain injury. And that makes a massive difference in improving your patient outcomes. Intraoperative neurophysiology, no question, that really enables us to push the envelope in very exciting ways now, particularly in pediatric dysraphism and oncology surgery. Collaboration, I think because the nature of pediatric neurosurgery is being intensely collaborative, there have been collaborative research groupings that have evolved in pediatric neurosurgery like HCRN. Very importantly, global neurosurgery and the notion of policy and starting to change things through prevention. I'll mention very briefly folic acid. And then there are obviously new technologies waiting in the wings. Molecular biology, I think for many of us in low resource countries, that's still a bit of a distant dream, whether that's really going to change things for our patients. And obviously neuromodulation can still be a very expensive undertaking, even if it does make a big difference. So the emblematic condition for pediatric neurosurgeons, without a doubt, is myelin-meningeal. Two big challenges with myelin-meningeal are the fact that it's largely, not entirely, but largely preventable. And that if you diagnose it early enough, you potentially have the opportunity to intervene before the baby is born. And then the third challenge that I've highlighted there is the notion of transition of care, that as children now are surviving and getting into adolescence and adulthood, we have a completely different set of challenges to face as they navigate that very difficult transition. So just to highlight the role of food fortification of folic acid. So Pakistan, unfortunately, is a country that does not yet have food fortification. I see Professor Khan nodding there. So Tariq, maybe you can tell us at the end of this just what is happening in terms of getting that to happen in Pakistan. There's no question, this is an absolute obligation. And the World Health Organization has now passed a resolution calling on all governments around the world to set up and pay attention and make this happen. So there's a challenge for your community as neurosurgeons. But it goes beyond just food fortification. Understanding why it is that this makes such a difference is an incredible scientific challenge. And the sort of interplay of the genetic predisposition and this environmental factor of folic acid, I think, is one of the really most pressing scientific questions we can address in neurosurgery. Fetal surgery, for most of us around the world, is just a completely unrealistic notion. Obviously, in highly resourced countries where antenatal diagnoses are made early, it's an option. But I think for all of you practicing in Pakistan, certainly for us in South Africa, we're a very, very long way away from having fetal surgery available for babies with spina bifida. Closed spinal dysraphism is a different story. And I think this is probably one of the conditions where pediatric neurosurgeons really have a lot to offer, because these are complex, rare conditions. But if you practice as a pediatric neurosurgeon, you do start to get the cumulative experience that enables you to make decent clinical assessments and figure out what treatment to offer. So early in my career, I found it incredibly demoralizing operating on these lumbosacral lipomas. It felt like a complete waste of time. And then Dackling Pang came along with this really exciting approach to radical resection of lipomas, reconstruction of the spinal cord, and published very compelling data. Certainly, I found it very compelling. So we got Dackling to come along to Cape Town and do a few cases with us. And here's a case before and after a child born with a mass on the back, very subtle motor deficits, has surgery, complete resection of the lipoma. And we've become very, very persuaded about the value of this intervention. I mention this because one of the I think, false assumptions is that pediatric neurosurgery is just about closing myelin-meningeals and putting in shunts. And there are a lot of highly technical challenges that face the pediatric neurosurgeon. In fact, quite interestingly, when Ghazi Yazigul gave his plenary address at the World Federation meeting in Istanbul in 2017, he focused almost entirely on pediatric brain tumors as the new frontier for really pushing the envelope in terms of microneurosurgery. So do not think that pediatric neurosurgery does not have interesting technical challenges. And it's no point in doing a beautiful operation if it doesn't make a difference. As Daphne has shown, really kind of developing the technical skill to do these operations better results in better outcomes for your patients. And you can find this literature in his various articles. William Harkness, some of you will know, one of the presidents of the International Society for Pediatric Neurosurgeons and an early adopter of global surgery. So William really advocated for developing surgical care for children around the world, established an organization called Intersurge, and sadly he developed a malignancy very soon after this and died. But Intersurgeon has remained, and there's an incredible legacy. And what Intersurgeon tries to do is to match young aspiring neurosurgeons to areas of need and areas of training. And I think for those of you who may be interested in pursuing further training in pediatric neurosurgery, I'd really encourage you to look at the ISPN website and to look at Intersurgeon. So just my last couple of minutes, if I may, I just want to kind of give a final sort of wrap up of my vision for pediatric neurosurgery. And I think that the reality is that the world's population of children reside in Asia and increasingly in Africa. And in order to really grow our specialty on your continent and on mine, we really have to develop our capacity to deliver high quality neurosurgical care to children. And it makes sense from a few points of view, not just the burden of disease that we face, and you can all think of the many different conditions that kids have. It makes sense in terms of training, and not just doctors, but also nurses and other healthcare professionals. It makes sense in the range of research opportunities that we have. It makes sense in terms of the power of advocacy, as I mentioned, around folic acid, but it also makes sense in terms of leadership. And I think one of the most important roles that we can play as neurosurgeons is to really go out there and advocate for our patients and start to change the way in which society is structured and our healthcare systems function. So for those of you interested, as I said, you can look at Intersurgeon, you can look at the ISPN website and find out about fellowships, either go visit centers abroad, find places for longer term training. There's also a lot of information on the ISPN guide about pediatric neurosurgical conditions if you want to go and read up about that, particularly before your exams. And then just to end off with, so this paper was published last year in the Journal of Global Neurosurgery about pediatric neurosurgery in Pakistan. So it seemed to me that neither of the authors were actually neurosurgeons and was looking at the field of pediatric neurosurgery, but really from a public health point of view. And I'd be very interested in any comments from any of you who might have seen this paper and any thoughts that there may be within the neurosurgical community in Pakistan about developing pediatric neurosurgery. So just in the last couple of seconds, for those of you who haven't been to Cape Town, we are hosting the World Congress in December this year. If you haven't submitted an abstract, although the deadline is closed, we can sneak in a few more abstracts. So please feel free to write to me if you are keen to come to this meeting. It's really easy to get to Cape Town. All of the airlines that fly through the Middle East have direct flights to Cape Town, and it's really close to get there from Karachi. So there's my email address. If any of you want to get in touch with me, I'd love to hear from you and love to have a great turnout from Pakistan and in Cape Town in December. Thank you very much.
Thank you very much, Graham, for an excellent lecture. Any questions? Tariq.
Thank you very much for really excellent talk. Yes, we've been working somewhat because of my involvement with the G4 Alliance and with the group GAPSI group for folate fortification. So we've been talking to the health functionaries, government functionaries in Peshawar, and we hope to have a big public awareness seminar in February in the Global Neurosurgery Conference on the topic of folate fortification, which I think people have not realized how important it is and how simple it is. And it's just like iodine fortification of salt has literally finished those big thyroid goiters which we used to see from the northern areas. Also, on the point of regarding pediatric neurosurgery, I think in the faculty they've been talking a lot about that. We have recently appointed a pediatric neurosurgeon trained in Weill Cornell, 2 years fellowship on hands-on. So hopefully, slowly they're going to develop that. And I think slowly people are having an interest in pediatric neurosurgery as a specialty other than general neurosurgeons doing pediatric neurosurgery, which is in itself a very difficult field. Thank you.
Thanks, Doctor.
Hello. So I would like to comment. Actually, I am the health representative of Sindh regarding hydrocephalus and spina bifida. I am currently working as a neurosurgeon in Hyderabad, and we carried an outreach program, and it's still continued. And we've seen so much patients because we belong to a public sector hospital. So in public sector hospital, there are a lot of patients of pediatric neurosurgery, especially those spina bifida, hydrocephalus. And the government is working, I'm working with the government on the term that we should do, these outreach programs should be collaborated with all the government sector hospitals. So the point is that the what you said and what professors have said, and since we are also doing it, and we should look forward. Yeah.
Thank you.
Thank you very much, Professor. Thank you. Our next speaker is going to be Dr. Hassan Sayed. His parents come from Lahore, but he's based in Washington. He's going to be talking about craniopharyngiomas.
Good afternoon, everybody. First of all, I want to say how excited I am here in Karachi. I want to thank you for the invitation and everyone's hospitality. This has been a great conference so far. Today, I'm going to continue on the theme of pediatric neurosurgery and talk specifically about craniosynostosis. This topic can be quite in-depth, but I hope to cover as much as I can in 15 minutes or so. So I want to dissect this topic into 3 objectives: reviewing the history of craniosynostosis, providing an overview of head shape evaluation, and then comparing some operative management techniques from our center in Washington, D.C. So looking at the history of craniosynostosis, I think this quote really exemplifies the nature of craniosynostosis and why we treat it. In 1978, Przansky, who is a craniofacial surgeon in Chicago, described craniosynostosis as a drama of nature between the storm and stresses of the growing brain and the skull itself. And this is primarily why, as neurosurgeons, we treat craniosynostosis, and that is to allow for growth of the brain itself. The origins of craniosynostosis date back as far as the 8th century BC. It's been described in many literatures of ancient times, but it really wasn't until the 18th and 19th century that the pathophysiology behind craniosynostosis, specifically how cranial sutures grow and the causes of premature fusion in terms of brain growth and development. Dr. L.C. Lane in 1892 came out with this article, and this was known to be the first child who was treated, at least in North America, for craniosynostosis, in which the mother of the child exclaimed, "Can you not unlock my poor child's brain and let it grow?" As a result, he did perform surgery on this child, but 14 hours later, this child passed away. And that really halted any surgeries for craniosynostosis. In fact, in the 1890s, Jacobi, who's considered the father of American pediatrics, in an international conference in Rome, stated that the hands take too frequently the place of brains. Such rash feats of indiscriminate surgery are a stain on our hands and sins on our souls. And this really halted surgery for craniosynostosis until its resurgence in about the 1930s, where Ingram and Matson in Boston popularized the suturectomy technique. And largely, there were significant advances in anesthesia, blood transfusions, and surgical technique that led to safer surgeries. In fact, only 2 deaths in about 400 patients. And certainly in the mid-1960s, Paul Tessier, craniofacial surgeon, worked to provide a critical momentum and began to change the concepts of surgical approaches, not only to treat the brain itself, but also the craniofacial and plastic principles that we use today as well. There is a whole host of techniques and surgeries and extensive cranial remodeling procedures that were done in the 60s to the mid-1990s. Certainly there were some limitations in the simple suturectomies and strip craniectomies for advanced late diseases that were recognized and also provided reasons for these types of surgeries. And so we'll talk a little bit about the midline procedures that are done for certain craniofacial or craniosynostosis surgeries, the PI procedures, modified PI procedures, orbital advancements, and so on. And recently in the 1990s and 2000s, the endoscopic strip craniectomy followed by helmet therapy was recognized, and something that our center really promotes as a first-line treatment, depending on the age of the patient as well. So going on towards evaluating the head shape, I think we all know the basic principles, but really important within pediatric neurosurgery to take an adequate history, understand the head shape at birth, the head turn preference, whether or not there's torticollis, and whether there's a family history of craniosynostosis. Going beyond that in terms of physical findings, documenting the cranial index or the cephalic index, which I'll mention, the position of the ears and nose, whether there's any asymmetry, and ridging around the cranial sutures. In terms of imaging studies, there are a host of studies that can be performed. Typically in the US, the CT head is performed to confirm the diagnosis of craniosynostosis prior to surgery. Speaking on the cephalic index, it really gives an idea in terms of the shape of the head. It's defined as the biparietal diameter divided by the occipital frontal diameter. Normally it's between 76 and 90%. We really use this for scaphocephaly and sagittal synostosis, where a cranial index of less than 76% is something that we are very suspicious for. Plagiocephaly is another condition that is non-operative, but certainly something that we see in patients in the US, particularly because of the Back to Sleep campaign and leading to the asymmetry that we see. So surgical management of craniosynostosis is broad. It really depends on the center. It can involve open cranial vault remodeling, which we see on the left side, or endoscopic suturectomy followed by helmet therapy, and anything in between. This is just an example of a 5-month-old boy with scaphocephaly. This child is positioned prone. You can see the preoperative scan demonstrating the premature fusion of the sagittal suture. We elected to perform a cranial vault expansion where we removed about 4 to 6 centimeters of the biparietal craniectomy, did barrel stave osteotomies, as well as some flattening of the occipital bone. And this is a CT scan that was done 2 or 3 months post-op, demonstrating the new head shape in terms of it being more round, but also the bone that's regrown over time between 12 and 18 months of age. Another example, a 6-month-old girl with unicoronal synostosis. You can see the ipsilateral flattening of the forehead on the right side, the harlequin swine on the x-ray on the right side, and very subtle findings, including the tip of the nose that is pointed contralaterally. And these are pre-op and post-operative scans demonstrating the bifrontal craniotomy and orbital advancement on the right side. Unicoronal synostosis leads to facial deformities, and it's important to recognize that in terms of ipsilateral eyebrow elevation, opening of the palpebral fissure, nasal bone deviation, and hemifacial expansion. Contralaterally, you can see an eyebrow depression, a deviation of the nasal tip that we mentioned, and so on. Other cases can be complicated as well. For example, multi-suture cranial synostosis. This is a 4-month-old child who had bicoronal and sagittal synostosis. that was dealt with in an open manner, and you can see very adequate results following the surgery. As I mentioned, positional plagiocephaly is something to also be aware of versus lambdoid synostosis. Again, positional plagiocephaly is a non-operative condition and does not lead to any neurodevelopmental delays. So, what are the indications for surgery? There are wide variations of management depending on the center. As I mentioned, treatment will vary depending on the age of presentation, the location and number of synostoses, the severity of deformity, and the preference of the craniofacial team. Two main indications are to correct the skull shape and provide adequate space for brain growth. Speaking about endoscopic suturectomy, as I mentioned, typically this is done at our center at 3 months of age or less. Sometimes we push this to 4 or 5 months of age, but essentially during this surgery, the abnormal bone is removed, and really it's the helmet, the cranial molding helmet that's worn up to 12 months of age that is doing the job, and so it's very important to emphasize that for parents. The pros for this surgery are smaller incisions, less blood loss, and shorter hospital stay. The cons are the responsibility of using the helmet in order to get the most appropriate outcome. The cranial vault remodeling surgeries are done at an older age. Usually, 6 months or above for sagittal synostosis and 9 to 12 months of age for frontal advancements from metopic or coronal synostosis. Certainly, these do essentially require blood transfusions and have a longer hospital stay. Cranial molding helmet, it's really important, at least in the US, to have a relationship with an orthotics team that's able to manufacture a helmet. Parents, follow up with this team, after every couple of weeks to get the helmet adjusted and to follow hopefully the improvement in the head shape itself. So when we think about craniosynostosis, the epidemiology, it occurs and usually in 1 in every 2,000 to 2,500 live births. It can be single suture or multi-suture, syndromic or non-syndromic. Sagittal synostosis is the most common, followed by coronal and metopic. Lambdoid synostosis is exceedingly rare, but we do see that at times. It's important to also know the normal closures of the sutures. The metopic suture closes first, anywhere from 3 to 9 months of age, followed by sagittal, coronal, and lambdoid at adult ages. This is beyond the scope of the talk, but also important to understand the craniofacial syndromes and something that can be seen related to craniosynostosis as well. So speaking about the timing of surgery, 3 to 9 months of age is largely considered optimal, also because of endocranial remodeling that can occur if the treatment is done at an earlier age, reossification of calvarial defects, as opposed to an older age where sometimes defects occur and need to have subsequent surgeries to fill. Certainly there's malleability of the calvarial bone that allows for better outcomes, as well as minimizing facial dysmorphisms. Certainly there are ages greater than 12 months of age that are needed as well for calvarial, but in this patient population, calvarial bone is less easily molded. There's unpredictable reossification, and the skull base itself doesn't necessarily change. So at our center, less than 4 months, we employ endoscopic techniques. 6 months or older, there is an option for spring or distractor mediated techniques. And again, older ages, whether they're 12 months or at older ages than that, open cranial vault remodeling surgeries. Speaking to older children, sometimes you don't necessarily see these patients until they're 5, 6, 7 years of age. At that point, typically it's just followed unless they do have clinical that are concerning for elevated intracranial pressures. They certainly may have signs of papilledema or require ICP monitoring in order to determine whether a cranial vault expansion surgery is needed. So how do we counsel patients and parents really on surgery? Risks can include bleeding, infection, durotomy, CSF leak, a need for reoperation. Preoperative considerations, typically for endoscopic procedures, we don't place an A-line or a central line, but certainly precordial Dopplers to evaluate for and monitor for air embolism and having blood in the operating room. Complications really for this age group is blood loss and making sure that we stay on top of it. There can be dural tears that can lead to CSF leak, and recognizing those intraoperatively is important. So speaking in the few minutes I have remaining, speaking specifically on cranial types, sagittal synostosis, as I mentioned, most common, usually seen 3 to 1 in male to female. This results in scaphocephaly because the skull cannot grow wide and essentially grows long, and there's associated dysmorphisms as well. The history behind sagittal synostosis and treatments have varied throughout time. In the early 2000s, there were really 3 operations that dealt with whether there are compensations that occur equally or more compensation that has occurred anteriorly or posteriorly. An H-type craniectomy was done, sagittal strut bone grafts were placed, and there was an AP squeeze in order to correct the head shape itself. If the forehead was more affected, then there was flattening of the forehead that occurred in surgery. Posteriorly, if it was lengthened or if there was a large occipital knob, then that was flattened. And so these were more complicated surgeries. Since that time, there have been other procedures. For example, the flag procedure, the foreshortening and lateral expansion of the cranium activated by gravity procedure, which is the earlier picture that I showed before with good outcomes. And certainly endoscopic means have provided really good outcomes, and there have been papers that have described various centers' outcomes as well. For unilateral coronal synostosis, we mentioned the the clinical features that we see. This is a 10-month-old girl with right unicoronal synostosis with those cranial features. Surgical technique as an open is a bifrontal craniotomy, and then removing the orbital bandeau and advancing, sometimes over advancing that area that's been affected in order to prevent the retrusion that occurs usually after surgery as well. This is a 6-month-old girl that was treated for right coronal and metopic synostosis. Again, a larger surgery that involves cranial vault reconstruction. Certainly endoscopic techniques provide adequate results as well. This was a 3-month-old boy with right unicoronal synostosis. And these are some pictures after surgery that really demonstrate a very good outcome regarding preoperative and postoperative measures. A more complicated case with a 1-month-old girl with bicoronal synostosis. And someone who had comorbidities as well. Many surgical techniques, whether it's frontal orbital advancement done at a later age, distraction to allow for brain development, followed by a frontal orbital advancement, or simply doing an endoscopic suturectomy followed by helmet therapy. For this particular patient, we ended up doing a posterior distraction followed by a frontal orbital advancement. Just to demonstrate a bicoronal synostosis that was treated endoscopically. These are postoperative scans that were done with good results 9 months post-op. So in the interest of time, I will skip towards the end just to show our numbers. We've done about 600 cranial synostosis cases. Since 2019, we've done more endoscopic procedures, again for sagittal synostosis. So I think it's important for any center to have a team that's dedicated to cranial synostosis surgeries. For those patients who are referred early, it's important to educate the pediatricians in order to provide these referrals. This is our children's hospital in DC. And I thank you for your time.
Thank you so much. We are running out of time, so if somebody has a short question, we can allow that.
Okay. It's a very nice presentation. First of all, I'd just like to congratulate on this. It's really a very important topic. Because in Pakistan, we used to come across with the patients who come with a delayed craniosynostosis. After the best age is to operate before 6 months or 6 months. But if we get the patient with at the age of 3 and 4 years with the orbital shallow orbit and proptosed eyeballs with a raised ICP, and what's your take on this? Have you been involved in such cases where the age is more than 3, 4 years?
I think that's a great topic, and it's something that you will find multiple opinions on. Personally, the cases that I've seen at an older age, 3 years, 5 years, 6 years, most of those patients have sagittal synostosis.
Wow.
So there is, some physical appearance that's seen, although not as bad as, for example, that you mentioned, unicoronal synostosis. But in those patients, typically what we do is we treat based on whether there's signs of elevated intracranial pressure, whether the CT scan shows there's a thinning of the cranium, whether there's papilledema present, or headaches that are not explained for other reasons. In some cases that are equivocal, we'll place an ICP monitor. If the ICPs are high, then that's definitely an indication for surgery. Otherwise, we just continue to monitor the patient over time. But that follow-up is important, particularly for the neurosurgeon as well as for an ophthalmological exam, because papilledema can present later on in life. From a I guess facial plastic standpoint, one could argue that if the parents are really pushing towards surgery, it could be possible. Although I wouldn't necessarily do that simply for that reason, because there are risks involved with these types of surgeries as well.
Thank you very much. You can always ask questions during the lunch break if you have any. Next speaker is Dr. Noreen Mushtaq, who is a pediatric oncologist from Aga Khan University. And she is going to be talking about pediatric medulloblastoma.
Can you hear me now? Oh. Okay. So just a little bit. So thank you, Dr. Ahmed, and thank you everybody for inviting me to give this talk. I'm a pediatric oncologist, and my specialty is neuro-oncology. So I'm a pediatric neuro-oncologist and section head of pediatric oncology at Aga Khan University Hospital. So when I came in the room, I just realized that I'm the only other than neurosurgeon person. Everybody is a neurosurgeon, and I'm the only person who is an oncologist here. So it gives me a privilege to be with all of you. So medulloblastoma, we all know that it's the most common malignant brain tumor of pediatric age group. So it commonly arises from the pluripotent cerebellar neuroectodermal cells. They are usually undifferentiated round blue cell. And it can also, these kind of cells can also present in pineoblastoma also, and in many other cancers in pediatric age group. But for medulloblastoma, we do have these round blue cells. They frequently metastasize. Around 30% of the pediatric medulloblastoma can metastasize in the spinal cord, and around 2 to 3% can have metastatic disease in the bones as well. So it's always essential to have a pre-op MRI spine, which is a necessity to have with the MRI brain with contrast in these patients. Whenever you suspected a patient with medulloblastoma, you should have a pre-op MRI spine with the brain. So pathology, we all know. So this is the old classification way back to 2007. So the morphologically, they divide into 4 subgroups, which includes the classic medulloblastoma, the round blue cell. Then we have the desmoplastic nodular. Around 7% of the medulloblastoma have the histopathology of desmoplastic nodular. They usually associated with infants. The other one is the medulloblastoma with extensive nodularity. Again, slightly less common than the rest of the pathology, but they usually present again in the infants. Then anaplastic and large cell. So this is still the standard of histopathology, which we used to see in our part of the world, in LMIC, especially in Pakistan, because we don't have the molecular subgroups available in Pakistan and many other countries of LMIC. So historically, and we are still using the same risk stratification, medulloblastoma is divided into average risk groups and poor risk group or high risk groups. So the localized the disease, the better the outcome. The disseminated the disease, the poor the outcome is the same. So the older the children, their outcome is better. The lesser the children who are less than 3 years of age have a poor risk outcome because of many factors. Their morphology is different, their outcomes are different, their biology is altogether different. And of course, we can't treat infants as the same as we are treating older children. So extent of resection is extremely, extremely important if we talk about medulloblastoma outcomes. So the more the resection, the neototal or the gross total resection, the better the outcomes. And if we have a biopsy or a partial resection, the children do present with a poor risk group. Posterior fossa location comes in the average risk group, and the rest is poor risk. So in the Europe, classic and desmoplastic nodular come in the category of the average risk file. The large cell or an anaplastic comes in a poor risk group. So the management of medulloblastoma go back to 1925 when Dr. Bailey and Cushing's started giving radiation to these patients. So surgical option is the gold standard, while followed by the radiation, which people have started giving in 1930s. And first attempt was giving as X-ray therapy. Whenever they found out that when they did the autopsies of these patients who died with medulloblastoma, they found out the children who received this X-ray therapy, there was no evidence of medulloblastoma, while they do have evidence of radiation necrosis. So then it comes the treatment that, once you have the surgery, you can have the radiation, and then the outcomes would be better in these children. So this was the paper in 1953 by Peterson. And, so these are the techniques which have been used for giving radiation at that time. So since 1953, the radiation has been incorporated in the medulloblastoma treatment, but the main standard of care is surgery. So you have a gross total resection, you have near total resection, the outcome would be great. Then followed by craniospinal radiation, as I already showed you that in 1953, Peterson has given this. So since then, so there is a boost in the posterior fossa and then the craniospinal radiation. So the chemo incorporated quite later in 1970s when Dr. Packer have included cisplatin, CCNU, vincristine, and cyclophosphamide in different regimen. So, but there are many combination of therapies which we are using for these patients, and the outcome is good. It's not less than 50%. If you had a good surgery, you have timely radiation, and you incorporated chemotherapy at proper time. But what are the points? So if we talk about outcomes of medulloblastoma in Pakistan, it's not more than 30 to 40%. And why is that so? We have to make several decisions while we are having these patients with medulloblastoma. So age is extremely important. So here, as there are very, very minimal neuro-oncology training in our setups, so we don't know either we have to give radiations or no. So extent of disease, if it's metastatic, of course, we have to make this decision because many patients who comes across with many neurosurgeons or oncologists, they don't have MRI spine. So we actually don't know. We knew about this thing in the end when they go to the radiation oncologist where they are planning for the craniospinal radiation. So it's better to have an MRI spine up front to evaluate that the children have metastatic disease. Then extent of resection. So if I give you the data of the children who underwent complete resection, it's very, very small. So most of the centers other than Ahan, they opt for partial biopsy or upfront shunt, followed by biopsy or subtotal resection because of many factors. They don't have the pediatric ICU, they don't have the pediatric services, so they opt for biopsy, to make post-op care easier. But what happens later on that because of this disease, And because of the poor resection, they tend up having poor outcomes. For the histopathology and biology, we only knew about if this is a medulloblastoma or not. So, but the biology, we don't know. So we have to make this decision to evaluate the histopathology and biopsy also. So if we talk about the survivorship of the average risk medulloblastoma, it's more than 70 to 80%. But that's a Western data. If you talk about Pakistani data, it's not more than 50%. And 50% for good centers. Like if you talk about the other center, the public sector hospital, it's not more than 20%. So, but what are the important lessons? So this is like, it's a well-defined management option, surgery, radiation, chemo, but what happened later on? So these children usually have poor quality of life whenever they come across with the surgery, radiations and chemo. They have endocrinological issues because of the radiation they are having. They are short stature, they have poor cognition. So the lessons we have to learn with all these problems with surgery, they may have mutism, which is a very, very important point, especially in children from LMIC, because we don't have those services with us. And of course, the quality of radiation they are having. So our aim is to reduce mortality, which needs to have more effective regimens, reduce morbidity, need to reduce the dose of radiation, and modify chemo and understanding the disease biology. So this is a paper, a previous paper, like an old paper in 2006, and it's about the cerebellum mutism these children are having. So we do have our data, it's not published yet from AKU, and we have around 60% of cerebellum mutism in our center. And I have no idea what is the rate of cerebellum mutism in the other centers of Pakistan, but this is a very, very important patient. Most of these children do have cerebellum mutism after surgical resection. And then they have early aging of adult survivors of medulloblastoma because of the higher dose of radiation and because of chemotherapy. So what to do for the quality of life and the post-treatment care? So there is further, people have talked a lot, and there is various data have been done, various researches have been done. So because of the modification in the radiation and posterior fossa, neurocognition intervention, but how to do it? Like if you know that that's a malignant disease, how can you decrease the dose of the radiation which was there since 1960 or 70s? So this led to the foundation of future studies, which include biological studies, and they include the tumor tissue, CSF marker, and the genomic DNAs. So this is a very important group, a medulloblastoma Advanced Genomic International Consortium. That's MAGIC. And all of these healthcare professionals sit together, and from 45 countries, they have took the 1,200 medulloblastoma samples, and they researched. And what they have found out that medulloblastoma is not only divided on the basis of morphology, but they have different subgroups. And they defined as molecular basis. So they defined it as Wnt, sonic hedgehog, group C, and group D. This was back in 2011. So then this breakthrough paper came in 2012 by Mark Taylor and published in Acta Neuropathologica. And then they decided that it's 4 subgroups: Wnt, sonic hedgehog, group 3, and group 4, which is still there. And and why these subgroups are important and what is the significance? So Wnt usually present in children who are older. They have classical histopathology. They rarely metastasize. Their outcome is excellent. Their outcome is more than 95% if you have a gross total resection. And they are associated with Wnt signaling pathway. That's why it's said as Wnt subgroup. The other one is sonic hedgehog. So they usually present in the infants, and the infant with sonic hedgehog have a better outcome. While if they present in older kids, their outcome is intermediate. They uncommonly metastasize, and they usually associate with patch1 and MYC mutations pathways. Then we have group 3 and group 4, which are usually present in older age children, and group 3's outcome is fairly poor, while group 4 outcome is pretty good. But if you ask, I'll show you my data later on, but why this is important? Why a disease with already defined treatment options, you have to do all these subgroupings while they are not there in LMICs. So they worked more and more, and they found out that there are cytogenetic prognostication within the medulloblastoma subgroups. So if you have Wind, your outcome would be changed. If you have sonic hedgehog, your outcome will be totally different as compared to group 3 and group 4. So, but how to do it in our part of the world? So there is a paper by two of my colleagues, Sebastian Perrault and Vijay Ramaswamy from Sick Kids. And what they found out, so this paper is very relevant in our part of the world. So if you have an MRI scan, you can identify molecular subgroups, and you can identify this MRI as a surrogate marker. You can use MRI as a surrogate marker. So if you see the first one, whenever you have a sonic hedgehog subgroup, you can usually these tumors usually present in the CT angle. In sonic hedgehog, they usually present in the cerebellar hemisphere. The third one, the group 3 and 4 are usually present in the fourth ventricle. The group 3 are hyperintense tumors. They enhance on contrast, and group 4 are usually hypo to iso-intense tumors. This we have used in our patients, and we identify the same classification and the same behavior in our patients as well. So then all of these classification comes to change the risk stratification of the childhood medulloblastoma. So this paper by Vijay in 2016, they have basically risk stratified the subgroup other than the average risk and the high risk to low risk, average risk, high risk, and very high risk. So if you see this, so the children who presented with Wind, who are less than 16 years of age, comes in the low risk group. Children who have sonic hedgehog, the TP53 non-wild type mutations, they come in the sonic hedgehog group, they comes in the standard risk group. Group 3, fully resected, comes in this standard risk. Group 4, fully resected, come in the group 4, while the very high risk groups are the one with the sonic hedgehog with TP53 mutant tumors. And why it's very high risk? Because they are associated with Leaf-Remini syndromes. And the children we have at AKU with Leaf-Remini syndrome and TP53 mutations are all died within a month of surgical resection. So their disease is very aggressive, and they usually don't usually behave nicely, and they don't respond nicely with the chemotherapy and the radiation therapy. So then this is the paper which came in 2017 by again the same group and Michael Taylor, and they subdivide these subgroups into further classification. So now it's not 4, it's 12. So this is the classification further down when you can easily identify which one are the risk groups. So you incorporate the average risk classification, the first classification, the older one, with the molecular classification, and then define your patient's outcome. But fully resected, non-metastatic disease are still 2 factors, and children who are more than 3 are usually children who have a better outcome. Either they have Wind, sonic hedgehog, group 3 or group 4. But when they have P53 mutant tumor, when they have group 3, the outcome is slightly poorer if you compare it with the metastatic disease. So what we are doing in Pakistan, so these are, pretty big research and everything which is going on, what we are doing in Pakistan and what can be done and what our other LMICs are doing. So, as generally the outcome of medulloblastoma is not more than 40 to 50% in LMIC. So this picture is from the teleconference of the telemedicine, which one of my friends have started in Jordan way back in 1980s. So they have started this collaboration with Sick Kids. That's a twinning program they have started from 1986 till date. It's still running. And they have discussed their patients. And what they found out with the help of telemedicine or twinning, they have improved their outcome from 30% to 70%. And not only the medulloblastoma, but they have improved their outcomes altogether. They've started doing subgrouping. They have started doing better evaluation. They have started doing better surgeries and better chemotherapies. And then the SIOP group, the International Society of Pediatric Oncology, gives the other guidelines. So what they have recommended is that the LMIC should have a slightly different guidelines if you compare it the guidelines of the high income countries. So what we are doing in Pakistan, so we have started the same doing initiative back in 2014 when I came back from Canada. And then since then, from 2014 till now, we have discussed more than 500 cases. And out of those more than 500 cases, we have around 50 cases of medulloblastoma, which we have sent to sick kids and have our molecular subgrouping. And so after this collaboration from sick kids, we have started a national twinning programs with 13 different centers of Pakistan, including Children's Hospital Pakistan, Indus, NICH, Shaukat Khanam, PIMS, CMH Pindi, and Northwest Hospital. And we have started this tumor board. So all of these centers are presenting their cases. We are having 3 to 4 monthly tumor boards every month. And till date, we have started this initiative back in 2019. And till date, we have discussed more than 487 cases from all over Pakistan. So we are helping them to develop their own guidelines for medulloblastoma and their own standard of care for medulloblastoma. So this is the guidelines we have established with the help of PASNO, Pakistan Society of Neuro-Oncology, and Pakistan Society of Pediatric Oncology for children of more than 3 years of age. And this is the small data which we had for our children. So we have the highest number of patients we have are the group 4, followed by Wind, group 3, and Sonic Hedgehog. So the take-home message which you have to take home is that MRI spine preferably should be done before surgery. If not done, should be done within 72 hours post-resection. Treatment is age dependent. So if you have a patient who are infant, the treatment is totally different. They don't underwent radiation. They will have a high-dose chemo with a intrathecal or intraomiya chemotherapy with the systemic therapy. And the older the kid, they have craniospinal radiation and the 6 cycles of chemo. So treatment is stage dependent. So for average medulloblastoma, we are giving different regimen. For high-risk medulloblastoma, we are giving different regimen to these patients. So treatment should be always multidisciplinary. So it's not only that, oncologists will continue the treatment, but neurosurgeon, neuro-oncologist, radiologist, radiation oncologist should sit together every now and then and discuss patients in every aspect. So staging coordination between surgery and radiology, timing of the radiation. So we should all know that after surgery, the radiation should be started within 5 weeks of surgery. So what happened in Pakistan, once the surgery has been done, the patient went home and then there is nothing done. And they then came after a 4 week or 5 weeks time for the next MRI, and then a radiation appointment given. And the radiation started after 8 to 10 weeks, which makes them a high-risk group, because whenever you your time period increase from 6 weeks to onward, so the outcome would be, so they are prone to develop relapses. So it's very important that, once your diagnosis has been made for medullo, at that time, the radiation should be included, radiation oncologists and oncologists, and from there, they will take care of this patient for further care. And radiation should be started within 6 weeks of surgery. And the timing of chemo. So chemo should be started after 4 to 5 weeks of radiation. So it's time dependent. So this is the, it's going on and on and on, and people are talking about genomic studies. So with this, I just wanted to invite you. I have seen there is a conference coming up in Cape Town from 4th December, but our conference is from 1st to 3rd December. It's a pediatric neuro-oncology conference, and many of my international colleagues are coming. So please save the date for your presence. So my colleagues, my friends who are from different public sector hospitals of Pakistan, my 2 fellows. So when I started, I was the only pediatric neuro-oncology of Pakistan, but then these are my 2 fellows, Dr. Farah, who is now a faculty at AKU, and Dr. Afia, she's working in Lahore. So we are 3 trained pediatric neuro-oncologists, and Dr. Eric Buffet, who is my mentor on my inspiration of doing pediatric neuro-oncology. Thank you very much. I'm happy to take questions.
Thank you very much, Dr. Noreen Mushtaq. That's a very elaborate discussion on medulloblastoma. Salman, would you be able to guide us in view of the prayers, how we move forward, or do we do this after There are 2 lectures remaining. How do we want to go about it? In the meanwhile, you may ask your question while Salman is going to guide us.
The prayers is at 1:30.
Oh, 1:30. So we,
all the food is here as well. So maybe if you want to take a break and then come back here at 1:40.
do we want to break it now so that the 2, there was one more? I thought Hassan and Graham.
Okay, let's do one more.
We could.
So,
Right. So it would be, you could start preparing while somebody is asking the question to Dr. Noreen.
so my question is from all the senior faculty. The question is regarding medulloblastoma, not pediatric. Recently, last 3 of the posterior fossa tumors which we operated, and all of those 3 were grossly, were radiologically looking like could be meningioma, tentorial, cerebellar, but they, all of 3 were gross totally resected. Reports were done from AKU lab, and all 3 were adult medulloblastomas from 22 years one, and the other was 34, 35, and the last one was 55 years old. So my question is basically from all the seniors, how often you encountered, how you deal such things? Jazakallah.
So is there a question?
Any response? Is any response from the seniors to that question? Perhaps that can be another discussion between. Yeah. So.
I can give you a brief overview of adult medulloblastoma. So it's treated as the same. The only problem with the adult medulloblastoma, the tolerance of cisplatin is really, really poor in adults. So at times you need to change cisplatin to carboplatin, but it's the same. The craniospinal dose is the same. The dose of chemo is the same. But we can change it to cisplatin to carbo, but the outcome is not more than 50%. In pediatric, it's more than 60, 70 or 80, and in VINT, it's more than 95%, but in adults, it's not more than 50%.
Thank you very much. Dr. Hassan Said, please proceed with your lecture. Dr. Said is going to speak to us on endoscopic endonasal resection of craniopharyngioma.
Thank you again for the opportunity. As the program says, I'm going to be talking about endonasal strategies for craniopharyngiomas, but also provide an overview of surgical approaches. The 3 objectives I want to address are reviewing the epidemiology, histology, and presentation of craniopharyngiomas, define the surgical approaches, concentrating on endonasal routes, and discuss some neurosurgical cases with management and outcomes. From this morning, we had a great case that was presented, a craniopharyngioma case that was complicated, and we saw how the discussion went and how long and how many different opinions there were. And really, Rutka published this in the Journal of Neurosurgery in 2002, quoted as saying, there is perhaps no other primary brain tumor that evokes more passion, emotion, and as a result, controversy than does the craniopharyngioma. And certainly we saw that this morning. In terms of the history of craniopharyngioma, it was first described in the 1850s by von Zanker. And in the early 1900s, at least in the US, the first successful surgical resection was done by Halstead in Chicago. Cushing in the 1930s reported 92 craniopharyngiomas in his series of 2,000 brain tumors, and was quoted as saying that this is the most forbidding of the intracranial tumors. Certainly, as technology grew and the endonasal route was popularized by Ed Laws, and in the 1990s by Kassam and other colleagues as well. We know that craniopharyngiomas are really opportunistic tumors that push along the least path of resistance, and they spread along CSF roadmaps. They push and elevate the neurovascular structures, and so it's important to understand the anatomy of the region itself. Craniopharyngiomas can be characterized as prechiasmatic, about 25 to 35%, and those that are retrochiasmatic, or a combination of both, which are definitely more difficult and involve frequent invasion into the hypothalamus as well, which is important to note when addressing these surgically. The position of the optic chiasm is also important to understand, particularly prefix chiasms that are present in about 15% of patients, because this does limit the surgical access for approaching suprasellar spaces through at least a subfrontal approach. In terms of the epidemiology, we say this is a quote unquote benign lesion. It's derived from the embryonic remnants of the Radke's pouch. It makes up about 1 to 4% of all brain tumors, 6 to 9% of all pediatric brain tumors. And the peak ages really is a bimodal distribution between 5 to 10 years of age, which is why as a pediatric neurosurgeon, we see these patients as well as an adult population 40 to 60 years of age. Important to understand the relevant anatomy, which was covered yesterday as well in terms of the optic apparatus, the neurovascular structures, the hypothalamus, pituitary, the ventricular system, and those that also extend beyond what we normally see in terms of the brainstem, occasionally cranial nerves, and the temporal lobes as well. It's important to understand the function of and the anatomy of the hypothalamus and the neuroendocrine function that can be seen preoperatively as well as postoperatively if there are some morbidities related to surgical approaches. This is a beautiful picture of the pituitary and the infundibulum. I think it's important to understand the pituitary function, the hormones, as well as patients who are treated preoperatively, recognizing that correction of adrenal insufficiency can also unmask DI, and it's also important to note. So going on towards the histology of craniopharyngiomas, we talk about the adamantinomatous, the category, which is usually seen in children and are embryologic in origin, versus the squamous papillary, which occur in 1/3 of all adult cases, have metaplastic origins, are solid rather than cystic, and also may contain BRAF mutations, which is important for recurrence or residual lesions that can be treated with BRAF inhibitors, and certainly those that are mixed itself. This was also pointed out this morning in our discussion that the craniopharyngioma can invade the hypothalamus, almost like finger-like projections, which can be seen in these images. And certainly the clinical outcome may be better with those patients who have a squamous papillary pathologies. Craniopharyngiomas can be cystic, purely cystic 10 to 20% of the time, solid about 10% of the time, but the majority are mixed, and certainly calcifications are seen in the majority of these lesions as well. In terms of clinical presentation, typically they are large before they become symptomatic. The symptoms can be present based on location, whether they're sellar, that can result in hormone dysfunction, pre-chiasmatic and post-chiasmatic and retrochiasmatic that result in visual disturbances or hydrocephalus. There can be visual impairments because of compression of the optic nerves or chiasm, as well as the endocrine dysfunction that we spoke of as well. Imaging studies, certainly I always obtain CT scans as well as CT angiograms that help preoperatively for navigation purposes. 90% of children have calcifications, 50% of adults, and MRI scans that really help understand the tumor location and the relevant anatomy itself. So looking towards therapeutic paradigms for craniopharyngiomas, and this is where the controversy arises, there's certainly bias towards surgeons who address these via craniotomy, and there's bias towards doing these cases endonasally. But certainly, I feel like the best approach is to treat this surgically, and the first time is the best time to take care of these lesions. But there's camps for gross total resection versus subtotal resection plus radiation therapy, as we talked about this morning, craniotomy versus endonasal approaches, this does occur, although less commonly, but cyst aspiration, placement of the Ommaya reservoir, and some type of intracavitary therapy as well. And the large variability in terms of treatment really depends, is because no one craniopharyngioma is like another. In fact, lots of craniopharyngiomas will lend themselves to different approaches depending on the surgeon, the center, and their experiences as well. And you can see that in these images that there are different types of craniopharyngiomas. There's many different classification systems for craniopharyngiomas. This is just one by Kassam in 2008. I would probably say that purely intracellular craniopharyngiomas are usually addressed in an endonasal route. The other subtypes and types, depending on the center, are approached through a craniotomy, but also because of the technology with endonasal approaches, can be done via the transsphenoidal route as well. So looking to surgical approaches, again, there are many that we discussed this morning as well. Typically, I will employ the subfrontal or the pterional route, as well as the transsphenoidal route, but there are certainly others depending on the anatomy of the tumor itself. Each case is individual, as I mentioned. The growth pattern really depends on the sella, the carotid structures, and the third ventricle. And deciding on the surgical windows for exposure is key, because that provides the corridor towards resection. You can see in the top picture a lamina terminalis approach versus one that's done endonasally, which also provides great exposure depending on the tumor itself. There are some craniopharyngiomas, for example, in this picture, where there really aren't any good options, and sometimes will require multiple approaches as well. So why endonasal for suprasellar tumors? Advantages: some craniopharyngiomas are difficult to approach from the above. As I mentioned, for prefixed chiasm, for those with sellar extension or retrocrival extension, these are midline tumors. Midline approach, is helpful. But what's key is really looking at the MRI scan, the sagittal scan that you can see in the bottom, and trying to understand the infrachiasmatic window, which really helps in terms of the corridor towards resecting these lesions itself. So some surgical considerations, planning the case, obviously looking at the preoperative imaging, the OR setup. This is sort of our setup on the right side, where it's a two surgeon ENT neurosurgery technique, the navigation system, as well as the endotower and screens, so that the surgeons are comfortable in performing these procedures. And then certainly there's techniques for exposure, resection of the tumor. And as was stated yesterday, you always want to go into starting a case and thinking about how the closure techniques, particularly for these skull-based cases, are important as well. The other thing that we've started to use is virtual reality and augmented reality preoperatively to understand the approaches, to help counsel parents, and also just to understand the anatomy and rehearse the surgery itself. For example, this is a pituitary tumor, which we were able to understand the neurovascular structures that were present. And then intraoperatively, we can also for some reason it's not forwarding, but basically we can overlay these images of the vessels, of the internal carotid artery, of the optic nerves, while we're resecting the tumor. That can be helpful as well. So surgical considerations: planning the bony exposure really depends on the lesion and how it's being approached. Again, these are narrow corridors, but certainly can be formidable, but certainly possible in terms of resection of these lesions. Keys to exposure are doing a wide sphenotomy and posterior septectomy, confirming with navigation the known landmarks, using at least in our center Doppler ultrasound to confirm where the carotids and the vascular structures are, drilling the planum as needed from front to back, removing the tuberculum sellae, and then opening the dura, coagulating the intracavernous sinus, which was described yesterday, and then starting to resect the tumor. So what are some pearls for resection? It's key to identify the superior hypophyseal artery and helping to preserve the optic perforators. If these are cystic structures, draining the cyst and debulking the tumor centrally will help to dissect the walls off the neurovascular structures, identifying the stalk, and then deciding how aggressive to be with dissection and transection into the tuberous cinereum, the third ventricle, and the hypothalamus itself. And certainly something that is controversial, but the intraoperative decision for a total hypophysectomy, depending on how radical one wants to be. So there's one point I want to make. The way that I see these tumors, and this is something that John Jane Jr. really helped me understand, is distinguishing the two types of craniopharyngiomas and how they are develop just in terms of the origin. Those that result in expanded sella originate below the diaphragm, and those that have an unexpanded sella where a transplanum approach is necessary that originate above the diaphragm itself. So cases with expanded sella, the tumor really provides the exposure, as in this case on the right. This often indicates a subdiaphragmatic origin, and there's less chance for peel invasion and hypothalamic injury. And that's particularly important in pediatric patients as well. Cases with an expanded sella can have some exceptions. Not all subdiaphragmatic craniopharyngiomas expand the sella, and supradiaphragmatic craniopharyngiomas can expand the sella itself. So this is just one of the case, a 6-year-old with growth development and visual deficits. And so you can see this is a cystic lesion that was approached sort of a limited exposure, but certainly something that can be done, dissecting the walls off and decompressing the cyst, and then trying to maintain that the diaphragm and the peel structures in order to avoid getting into areas where we don't need to be. This is another case, a 15-year-old with visual decline, was found to have adrenal insufficiency and secondary hypothyroidism as well. Postoperatively after resection was found, had panhypopit, which was expected, as well as DI, because the infundibulum was also taken with a total hypophysectomy. So you can see we use a combination of sharp dissection and ring curettes to try to dissect these lesions, in this case off the optic chiasm and the left optic nerve here. So I'm sorry, for the interest of time, I'm kind of going through these cases fast. Certainly the endonasal approach can also be used for repeat surgery as well. And this 5-year-old patient had 2 previous craniotomies at another institution, and it was best, looking at the tumor, it was easy to approach this from an endonasal approach, and we ended up getting a very good resection. Going towards cases without an expanded sella, these are technically more challenging. As I mentioned, they indicate a supradiaphragmatic origin with potential invasion to the hypothalamus. And so in these particular cases, we're sometimes a little less aggressive in pediatric patients because of the morbidity. But as I mentioned, this requires transsphenoidal, transtuberculum, and a transplanum approach as well. This is just an image and video of the actual drilling of the transplanum. Again, these types of approaches can be tailored based on the tumor itself, and neuronavigation is very helpful in these cases as well to try to determine that case. Certainly there's cases that also, as I mentioned, can be utilized a multi-stage approach. For example, this is a 13-year-old child with headache and visual decline, growth arrest, who had an Ommaya that was placed in an outside facility, but certainly the lesion itself continued to grow. So this was approached through an endoscopic transventricular approach to decompress the cyst and try to help with the endonasal approach that was done as a 2nd stage surgery. Also doing a septostomy to control for the hydrocephalus. And you can see going into the foramen of Monroe, and cauterizing the cyst while decompressing it. We mentioned using the NICO side cutter aspirator that can help decompress the cyst within the 3rd ventricle as well, which can be useful. And then going endonasally to resect this lesion. There was, as you can see on the top right picture, some residual that was left intentionally because of the hypothalamic invasion in this particular case. This child's been followed, elected not to undergo radiation, but has done well so far. In terms of outcomes for surgical approaches, also controversial, but good gross total resections, but certainly CSF leaks that can be seen, good vision improvement as well. We published this in Neurosurgical Focus, looking at a systematic review of these patients that demonstrated good gross total resection. However, there is a bias towards endonasal. Certainly there are cases that are one would say that are easier, that are only cellar based, as opposed to those that are more complicated. I mentioned the reconstruction aspect of things. We use a gasket type of closure, which you can see here, but it's very important in order to avoid CSF leak post-operatively, also using a lumbar drain itself as well. So there's an allograft that's placed, and then in this particular case, a Medport graft sort of to seal that area itself. So conclusions, multitude of approaches. The choice really is dependent on the surgeon, but can also be related to size, location, age, and anatomy, whether it's an initial or second operation. The function is always paramount. Preoperative workup is key. Always looking towards a good OR setup that's comfortable. So the transfernodal approach has a role in management of select craniopharyngiomas, definitely those that have an expanded sella. Subtotal resection, although I didn't talk about this as much, followed by radiotherapy is an option and can produce excellent long-term outcome, but poor outcomes do occur. There have been some centers who rely solely on this therapeutic paradigm. More likely to choose a subtotal resection if it's a large purely cystic craniopharyngioma, or there's some concern for operative morbidity itself. Thank you very much.
Thank you very much. Is there a urgent question as we wind up towards heading for prayer and lunch? Okay, we seem to have agreed that we're going to wind up. We meet at 2. It's 2 o'clock. Thank you.
So another reminder, we'll have dinner today at Governor House at 7:30 p.m. and dress code is formal.
Hello, hello.
Those waiting outside, please come in.
All good. All good. I'll tell you what is next. Graham की talk है. He's talking on surgical management of epilepsy. Then I'll go to the right next week. Right. Okay.
इमाद, उनको बुला लो यार सब कहाँ आ जाए. Graham, you should refuse to start until everybody comes in. खालिद यहाँ अपना इस्तेमाल करो, इमाद का इन्फ्लुएंस कम हो गया यार. Ready to go? Okay. Okay. Now that Luis, Vlad, Khalid are here, I think we've got everyone. All right, Graham. You want to roll on? Okay. Graham Fegan, we've introduced him and everyone knows him. So we will get going with his talk on surgical management of epilepsy, South African experience. Thank you very much.
Treating epilepsy surgically, I think, is one of the most rewarding things we can do as neurosurgeons. So clearly, many of our patients present with seizures. Treating conditions like this is not epilepsy surgery, but it's these often fairly rare conditions that present where epilepsy is the primary problem, not the underlying lesion, that really fall under the ambit of epilepsy surgery. In a sense, epilepsy surgery is as old as neurosurgery itself. Very first operation done by Horsley was resecting an epileptogenic focus in the cortex after trauma. Wilder Penfield is the guy who really sort of puts this aspect of our specialty on the map in Montreal in the early part of the 20th century, and really did some incredibly beautiful work. Not sure any of that would have got through any of our modern ethics committees, but I guess that's a different story. So why deep into 21st century do we still talk about the need for epilepsy surgery? Why is it done so seldom? And I really like this quote from Pete Engel, who was a very distinguished epileptologist in Los Angeles, who said, and I think this is true, that surgical treatment for epilepsy is arguably the most underutilized of all proven effective therapeutic interventions in the field of medicine. So the entire field of medicine, epilepsy surgery is one of the most underutilized interventions. And it's one of the few things that we can really look our medical colleagues in the eye as neurosurgeons, say we've got class 1 evidence that this works. There's a great study done by Sam Weeb from University of Western Ontario, published in the venerable New England Journal nearly 20 years ago, more than 20 years ago now, demonstrating very clearly the patients subjected to temporal lobectomy, much better long-term outcomes than patients who were commenced on medical treatment. So despite that evidence, we still haven't turned the tide. In fact, in the United States, it's well documented, patients often have seizures for over 20 years before being referred for surgery. I've got a colleague in Cape Town, Roger Melville, who's still an incredibly fine neurosurgeon in his 80s, who has been doing epilepsy surgery for 50 years. And Roger tells me that the mean interval of patients have seizures before getting referred to him, in fact, is increasing. It's now over 40 years on average. And he's done over 1,000 epilepsy operations. So that's a huge referral base. We're just not getting the message across worldwide. So it's ignorance within our medical community. It's the resistance of our neurology colleagues to refer patients. And sadly, in some countries, it is still an absence of resources and expertise. But hopefully, by the end of this talk, it'll be clear that that shouldn't be a big barrier. So the notion of intractable epilepsy, if you've got a single focal lesion causing epilepsy, I believe that one day we will be advocating surgery for those patients, even if they're medically controlled. Taking anticonvulsants all your life, I don't think is very good for your brain. But the fact of the matter is, if you're medically controlled at the moment, it's not really acceptable to consider surgery. So it's those patients who either are resistant to medical treatment, they have intractable epilepsy, or the drugs aren't available, or the drugs or the seizures are having an unacceptable impact on their quality of life. And the two things to particularly flag here are the behavioral disturbances in kids. And one of the real wins, I think, in epilepsy surgery is doing it early enough in childhood that you prevent all those long-term cognitive and behavioral consequences. And don't forget about SUDEP. SUDEP is very real. This phenomenon of patients dying unexpectedly from epilepsy. And I'm not sure there's ever been a study that's shown that epilepsy surgery prevents SUDEP, but certainly if you control your seizures, it's extremely likely you'll reduce the chance of SUDEP. And obviously, when you're talking about operating on kids, you've really got to think about their future quality of life. So the conventional approach, your clinical diagnosis, EEG localization, imaging, and if you're really lucky, you'll have a neuropsychologist that can pull all that together. And on that basis, you've got enough information to advocate for appropriate surgery. So the question, though, for all of you in a country like Pakistan and for all of us in South Africa is what actually is really needed for the majority of the world's people. And for me, there are three ways to answer it. The first is the infrastructure you need. The second is to be very clear about what kind of surgery you can offer and that's going to be appropriate. And the third is to kind of really build partnerships in trying to make this happen. So just to focus first on the infrastructure, it's important to have a team. Epilepsy surgery is definitely not a solo operation that you can go out there and start doing it without having the necessary kind of support structures. I don't know about any of you, but I look at those EEGs, I have no idea what's going on. I think most of us neurosurgeons haven't got a chance of interpreting EEGs. Obviously, imaging is what we do. So Radhakrishnan, who's a very eminent neurologist in India, has written very persuasively about how one goes about tackling this problem in low-resourced countries. And he has this notion of a pyramid of care, starting in the community and sort of building steadily through different levels of healthcare to national referral centers where you can have programs like epilepsy surgery. There are a whole heap of barriers that all of us face in our countries that need to be addressed. And any of you interested, that's a really nice review paper in Neurology India published a decade ago. So this is the notion of trying to build up the service incrementally, starting in the community and then figuring out what resources you need at different levels of healthcare, and ultimately working towards national referral centers, which clearly in a country like Pakistan, you would need to have, I would imagine, at least 4 or 5 national referral centers offering epilepsy surgery. And it can be done. Brazil is a fantastic example of a country that came off a very low base in the kind of the late 80s, early 90s, very organized approach to how to actually build up an epilepsy surgery service and just a massive escalation in the number of cases. So that's kind of how you go about kind of getting the infrastructure in place. In terms of the surgery, I think the key thing here is to, when you're starting off, to stick with the proven operations that really are going to make a difference. And it's not complicated surgery. So the concepts are either to go for resection, where you're removing the focus of seizures, or to go for disconnection procedure or neuromodulation. I'm not going to talk about neuromodulation. I think that's kind of really out of the ambit of most of us working in low middle income countries. In terms of resection, the overwhelming kind of number one operation there is temporal lobectomy, and I'll talk about that in a moment. There are obviously extratemporal resections, which are much more relevant. And in our pediatric practice in Cape Town, we do very few temporal lobectomies, do a lot more lobar resections and focal cortical resections. And then disconnection procedures. The paradigm example of that obviously is hemispherotomy. Hemispherotomy is an evolution of hemispherectomy that in fact was first described from South Africa in the 1950s by a guy called Roland Crano, who reported 12 patients. And this is in the days before anticonvulsants, before the CT scanner, 12 kids who Crano had operated on, and actually they survived the surgery amazingly in those days, and very good seizure control. And the truth of the matter is the single best operation we have, even today, is hemispherotomy. If you do hemispherotomy correctly for the correct patient, you've got an over 90% chance of curing the epilepsy, but I'm not going to talk much more about that today. The simple example of disconnection there is callosotomy. Callosotomy is a really straightforward operation. Any decently trained neurosurgeon should be able to do this technically. So the real challenge with callosotomy is choosing the patient correctly, and that needs very careful consideration by a neurologist. From an anatomical point of view, you want to do as little damage as you can. So going from the non-dominant side is a good idea. Being incredibly fastidious about the draining veins is probably the most important part of the operation. You don't want to end up with venous infarct or hemispherical swelling because you've pranged the draining veins. Knowing where you are, following the phelps, not getting falling into the trap of mistaking the singular gyrus and the callosum marginal arteries for the corpus callosum and the pericallosals. And obviously, you don't want to end up back in the vein of Galen. That's not going to be a good day. What do we fear when you do a callosotomy? Well, most important thing is retraction or damage to the draining veins, causing a neurological deficit, ventriculitis or meningitis, which could be aseptic if there's blood in the ventricle, hydrocephalus, and then disconnection syndrome, which is incredibly unusual actually. And most of the time when you're doing a disconnection, doing a callosotomy for epilepsy, you only need to take about 80% of the corpus callosum. So it's unlikely in that situation you'll have a long-term disconnection syndrome. Temporal lobectomy is a great operation in adults, as I said, very seldom done in kids. The key thing with temporal lobectomy is just very simple anatomical principles. Most important thing is to not go too far back from the temporal tip, and or to do that you need to identify the temporal pole, and on the medial aspect not go beyond the mid-mesencephalic point. And you can see that very easily where the brainstem starts curving backwards. It's very easy to appreciate at surgery. Just looking at it in the coronal plane, know where the Sylvian fissure is, and usually you go just either middle temporal gyrus, or you can take the superior temporal gyrus. You have to find the temporal horn. If you don't find the temporal horn, you're going to have a very long day in the operating room. But once you've found the temporal horn, then you're pretty much home and dry. And once you've resected the lateral neocortex, doing your medial resection is pretty straightforward. Important thing is to identify the edge of the tent. And once you've found that, you need to be very careful that you stay subpial and you don't end up in the cisterns that Vladimir spoke about so impressively yesterday. And that's really the essence of doing a temporal lobectomy, and remembering that cisternal anatomy, and you don't want to end up in the cistern. The pier is actually a remarkably robust structure, and if you respect it, you can keep it intact. What do we fear with temporal lobectomy? Well, the general complications of any operation, getting lost, and this is not an operation where you should get lost. It's pretty much the same operation every time you do it. So you can become very familiar with the anatomy. Neurological deficits are either from going too far back or going too far up and pranging the optic pathways, or going too far medially and ending up in the cisterns, or even worse, the midbrain. But probably the most common complication is failure, and that really results largely from inadequate workup and doing the operation on the wrong patient. So is it really an option to do this surgery in low and middle income countries? Well, it is, and it's been proven to be. From Uganda, a series published by Ben Wharf when he was working in Uganda, working with a neurologist called Warren Bolling, who was at West Virginia University, and 10 cases operated in Uganda, in Mbali, which is, as our chair can attest, is truly rural Uganda. 6 out of 10 patients cured of their epilepsy. Amazing. Tunisia, a really good partnership with a French institution. And of the patients who were operated, once again, 10 patients operated, all had class 1 angle outcomes. And so that's fantastic outcome. I should not be here doing this talk, because one of the people I respect most in epilepsy surgery is from Karachi, and that's Zubair Tahir, that I'm sure many of you know. So Zubair published this paper, which came to my attention many years ago, and I've referenced this paper must be 30 times in my career. It's kind of, I don't know, feels bittersweet to be in Karachi now referencing it. But Zubair did work, and I'm sure there are people in the audience that were part of this. Once again, Warren Bolling from West Virginia University was involved. Fantastic outcome. More than half the patients Engel class 1 outcome, and I'd love to hear that this work is continued and that there are people in Pakistan still doing it and building on this. I have seen reference to a national epilepsy plan. I wasn't able to find a copy of it, but I'd love to know more about what has been built on this foundation here. So I've spoken about the infrastructure, I've spoken about the surgery, and in the last 1 minute and 20 seconds, just to mention very briefly that there's an important political issue here, and that's to get our neurology colleagues on board. Epilepsy is a very powerful, very well-organized community. And I think one of the reasons why epilepsy is so well-organized and so powerful is they've been really effective at getting patient organizations on board. So every time the International League Against Epilepsy has a meeting, the International Bureau for Epilepsy, which is the patient group, meets with them. And it's a really powerful alliance. So the neurologists have got huge pulling power in advocating for patients with epilepsy. It's just really hard to get surgery onto that agenda, and we've got to find a way to do it. We've had a bunch of really, really great meetings in Africa, these joint surgery, neurology meetings, looking to kind of build an awareness around epilepsy surgery. But we've got to cast the net wide and work with all our organizations to keep getting the message across. And it can be done. All it takes is one or two people. So Peter Senyonga trained with us in Cape Town. Robert Sabunya, a neurologist, both from Uganda, also trained in Cape Town. They've gone back and they're developing an epilepsy surgery program together. So really it just takes a couple of people working together and then starting to develop the team that makes it possible. So in summary, you can't do it alone. And there are lots of people out there who want to help develop services like this. So find an international partner, learn the basic techniques, don't start with the complicated cases. Technology required is really quite modest. And as I said, start with straightforward cases. Invasive monitoring can wait. To start with cases that the neurologist can diagnose with surface EEG, try and get a neuropsychologist, and all the fancy acronyms, the SysComs and PETs and all that other fancy expensive stuff is really not necessary to begin with. Okay, so on that note, thank you very much. And thank you to all my colleagues back home who are doing the work while I'm having a great time in Karachi.
Thank you very much, Graham, for that excellent overview. I'm sure you've convinced several in the audience that that's the way to go. We have time for one question or comment. As Professor Asif Bashir
Thank you, sir.
comes.
To moderate the next session, I would like to call Professor Louis Barba on the stage along with Professor Muhammad Farooq.
No, you want to call the first one? The first one is. Good afternoon. Let's start the session. Call Dr. Bashir, talk about MIS in tubular surgery. Thank you. Please go ahead.
Thank you, Mr. Chairman. Could I have tech support here? कोई है यहाँ एक से यार यहाँ पे जरा स्क्रीन को इसको बड़ा कर दें इसको एक पे करना चाहता हूँ Perfect. Okay, thank you, Mr. Chairman. It's a pleasure. It's always an honor coming back to Salman's place. This is what I call it, coming to Karachi. This is the first. When I moved from US, all the new, other than Salman, some of the international friends we made was here in Liaquat National. So always an honor to be here. So no disclosures. I've been asked to talk on minimally invasive MIS tubular surgery. So as I look at tubular surgery, it doesn't matter what you're using, microscope, endoscope, working through a tube is just a different perspective when you're looking into achieving what your goals are. So it's a catch term, which is surgery, which is just done more in a different way, less invasively. The goals are the same, achieving what we achieve in the open surgery, but the access is less morbid, less trauma, less muscle trauma. The goals of MIS, of course, to reduce perioperative pain. The This is all outpatient. I don't accept a patient recently, which we had to keep for 23 hours or more. Most of them go home in 3-4 hours post-surgery. And it's the same. If you use a microscope through a tube, if you use an endoscope, the outcomes are exactly the same what you're using. Reduces hospital costs. Of course, patient outcomes are which matter the most. So this is a traditional open approach which has been done. Our practice now over the years has been more involved in revision surgery. So a lot of times, I'll show you some of the cases, are patients who've been already operated. Some have had open fusions, and doing it through a tube initially was more challenging, but now I'm always more comfortable doing it through a tube than doing it open. You can keep the incision pain with open, of course, is longer. How do we transition to MIS? I think I also have been through it, just like most of our friends who are doing MIS surgery. It just transition over time. This is a psychological barrier. You have to decide, once you've learned open surgery, how you transition to MIS surgery. So you only want to see what you want to achieve. You want to protect what is not needed by not exposing. So I think that's a very good point, because it's opposite to open surgery, because I think you cause less damage with MIS surgery as compared to open surgery. You begin with larger diameters. I started with 18, maybe used to be a Medtronic 22 tube also initially for fusions and all that. Currently, if I'm using a microscope, we're doing a microendoscopic decompression or a discectomy. We are using with the metrics, the smallest is 14, but with the stealth, we have a stealth system also, which we use anywhere from about 12 millimeters, the smallest tube which you can use. But always start with the larger diameter. Starting with discectomies is always a good option. And the anatomy, target location of the pathology, expose only what you need to expose, and identify the anatomical landmarks. And expose, remove as much you want to remove with the tube. Use as a big tube as possible. This is for our younger crowds, I think, which are more interested in this. But this is just looking at through this small tube. So this is what changes your perspective when you're doing these. And of course, all the splitting, paraspinal muscles, multifidus. Some of these patients do get myofascial spasm, which is similar to open surgery, especially when we're doing multi-level. So currently at the stage we're doing from L2 to sacrum with one incision, we're able to manage it. Having 2 subfascial incisions, you can manage it about 2-3 levels with a small 12-14 millimeter incision. And the trajectory depends what you want to achieve. Are you doing it for a discectomy? Are you doing it for a multi-level decompression or a fusion? So it's about 1 centimeter for a MIS decompression or a discectomy, about 2 centimeters for a, I'll show you the trajectories as we move forward. So I want, if I'm doing a multi-level decompression, I like to stay closer to the midline instead of going too lateral to preserve the facets also. So far lateral, so this is the trajectory what I was, so about 1 centimeter lateral to the midline is for a discectomy. I don't prefer to do PLIFs, but we do a lot of MIS TLIFs, so 3.5 to 4 centimeter lateral, and about for pedicle screws, it's about 3 centimeter. So depending on how you want to, what type of tube you're comfortable with. In fact, at this stage, I feel uncomfortable when I use a larger tube, because I feel a little lost with a larger tube. So the smallest tube is always the best option, because you can freely move up and down, right and left where you want to go. I don't use a K-wire. I don't use a dilator for that, because I've had CSF leaks from that. To start with, so I use a long bovie, just make a little opening into the fascia, use the bovie, and then you put the next dilator. So guide wire insertion is the first step. You do a first dilator, you do a sequential dilation. If you want to use a 16 or 18, you can go to the larger diameters. We commonly use not more than 12 millimeter with the stealth or a 14 with the then if you're using a endoscope, then the incision is even smaller, right? So you can manage, but the only problem is, you know, just like I say, when in Rome, do it like the Romans do. The problem with endoscopic, when you're in a low middle class country, is the probes. You cannot do more than 2 or 3 cases with that. The cost becomes a real significant issue. So when I'm back in US, I'm operating both places. Currently I'm using an Eloquence, which is, but the cost is no issue. You know, you can get a probe, bipolar probe for every case you want. So these are the steps we go through. Mark your incision, always starting with an AP, always scrubbed. You don't need to mark first and then scrub and all that prep. So dilate over the between the facets, look at the facets carefully when you're looking at your AP and the base of the spinous process. These are normally the 2 types of tubes which are there. The beveled ones, I always prefer a 12 millimeter or a 14 millimeter, this straight tube. But with the beveled one, sometimes, you know, you can have bevel go opposite, so it's a little tough to work around it. So retraction options, we started off using quadrant, which used to open up to achieve, but now you can put about a cage through a 18 very comfortably, if you're putting a banana cage or something for a TLIF. But most of the population, at least in our country, is more degenerative arthritis, osteoarthritis, sort of less of disc issue. So some of the diagnoses which initially we were using, and now we'll show you some of the cases. Standard disc, standard femoral central stenosis, which is the bread and butter. I would say about 80% of the population is what we take care of is stenosis. Synovial cysts. Synovial cysts, in fact, are much more common than we think. A lot of times the MRI is missing it because MRI is not a thin cut through that. And in fact, we're publishing a paper now that the incidence of synovial cyst, or anytime you see a grade 1 or a grade 2 spondylolisthesis, even if the MRI is not showing that, you find it much more commonly than what the imaging is showing. Neoplasm, most intradural extramedullary tumors, not intramedullary, more so intradural tumors we are doing through the tube now. We open the dura, we leave the dura open, we put a little bit of gel foam, Duragen over it, and the patient goes home in 2-3 hours. We've done close to 70 plus cases now for spinal tumors. We'll show you some of those. Posterolateral disc, far lateral disc, about a 1 to 2 finger breadths lateral. You can see a disc here. This is the size of a dime. Very similar to open. It's an ideal first case if you want to start with that. Not a revision, but a version case to start with. So steps of dilation, steps of exposure. It's intralaminar. As we're going through that, you can expose the ligament. I like to remove the ligament. I want to see the dura first, but you know, some people prefer to protect the dura and then remove the. So far lateral disc. You can see a far lateral disc. This is an L3-4 dock at the inferior lateral pars. Same trajectory for stenosis, but you know, you can just, the advantage of the tube is you can move wherever you want. You can go along the TP, you can do a fusion if you want, you can, as long as you have a drill, you can put through that, the angle drill. So central stenosis, most commonly, this is a L4-5 stenosis. You can see pre and you can see post. I personally feel we achieve a much better lateral decompression, lateral foraminal decompression through a tube than doing it open. This is at least in my hands. So again, you can use a metrics. This is what we use a lot of times. This is a 58-year-old lady with neurogenic claudication. Typical case. This is a very common patient. EHL weakness, L4-5 spondylolisthesis. I would say about grade 2, as long as they don't move. Even if a patient moves a little bit on flexion extension, the patient is elderly, you can still get away with because you're not removing the facets. So why do it open? So it is extremely uncommon for us to do open surgery, at least. So this is a generous wide. I think the same case used to take us 70 minutes. It takes about 40, 45, 50 minutes now. And the patient is out of the, so nice wide. We always, here we always do even if the patient has left-sided or a right-sided, we always do the contralateral side. The reason being it takes extra 10 minutes. You just move the tube laterally, go. In fact, we now track the nerve. The more lateral you move the tube, you should be able to decompress the contralateral foramen also. Synovial cyst, you can see a synovial cyst here. Sometimes you don't see it. On this MRI, you can see it. Open versus MIS TLIF. After doing a lot of open surgery from 1990s to 2006 or 7, I would say, when you follow your own patients and 2 years later, they're coming back with back pain and all that, you realize that maybe it's, you have to change. So less and less fusions is, I've also become, my partners used to say that maybe I thought they were older, but I think now when we are getting into that age group, I think they were right. And less fusion is better for the patient unless you're doing a scoliosis or a high-end deformity. So this is MIS TLIF. You can see there are always 2 incisions. Do the interbody first, put the screws in next. And so this is what I want to show you now. So this is something which we were trying to stay away from for quite some time. Patient has already had, this is a patient we did about 2 weeks ago. This is the 3rd surgery this patient went through. We've done patients who've had 4 surgeries also. But this was first surgery was done in London, second surgery in Pakistan with a prominent orthopedic spine surgeon who fused this patient, but the symptoms never went away. So it's the decompression that matters. So what we've learned is putting in a tube in between the 2 rods, right? So the only room you have is along these rods. You can move it as far lateral here. So this is the only limitation when you're working between that. But you can get a contralateral. We did a L3 to 4, L3 to 5. So 3, 4, and 5 decompressions on this lady. And she went home the same day. Posterior cervical. I'm going to touch a little bit on that. This has been our frontier. We're doing a lot of these also. Far lateral disc, C5, most common at 5-6. Stenosis is very common. This is a patient I want to show you, not a few months ago. This is an 89-year-old patient. She was a physician, well-known physician in Lahore. She was being followed. We personally followed her for about 2 years. And then finally, she became severely myelopathic, was having frequent falls. We did it with this 14-millimeter tube. This is intraoperatively. Look at the nice wide decompression. I didn't want to do a C1-2 fusion on an 89-year-old. So I think this is now the next frontier, which really intradural tumors. I think we're running short of time, but intradural tumors are ideal cases. 1, 2-level tumors, ideal cases. Don't worry about CSF leak. It never happens if you do a tubular surgery. Lumbars, intradural tumor, you can see pre, you can see post. You always get it started with 18-millimeter, but most tumors we are doing now is 14-millimeter, which is the smallest. We've ordered 12-millimeter. So of course, results are outstanding. I think the patients do very well. It's not your own results, when you follow these patients are what really matters for these, how you learn and progress. So lessons learned, all of these. Management of dural closure used to be a challenge. We really don't worry about dural. If you're in a 12, 14-millimeter tube, what difference does it make? Never, they're not going to have a overt leak. Conclusions, same day surgery. Of course, minimal blood loss. It's a learning curve, but I think it's very doable. Thank you.
Thank you, Professor Bashir. I have some questions about this presentation. How you close the dura through the tube?
So that's the million-dollar question. I used to spend hours closing dura, I would say in 2005, 6, 7. And then one of my partners came in on a Friday. He wanted the operating room, and I was doing we had a leak. So he came in, Greg Shabilsky, he was a former president of NAS also. He said, I never closed the dura. Why are you closing the dura? He said, I'll show you a tumor. So next Friday, we did a tumor together. He said, you don't need to close the door. Just put a piece of Duragen. It's the CSF will come out. It won't come out through the fascia or the skin. Just put a fascial closure, and we just put a glue derma bond on the skin, and the patients are asymptomatic. So now for tumors also, we don't close the door. Just put a small piece of Duragen or gel foam, whatever you want to do, and it just forms a level. We don't even use Duraseal, no sealant, nothing. And we have a large series now coming out.
There is no pseudo-meningocele there?
No,
Nothing.
There's a track which comes out. We have a lot of follow-up imaging also. There's a track that comes out because the thing is the muscle just takes the tamponades, the space. And since we're closing the muscle and the fascia together, and we have a sub-Q and a skin closure also, and a glue. So it never gets, in fact, we do revisions mostly on patients who have had open pseudomeningoceles. So I think we've seen once or twice, in fact, never on a tumor, which I've stopped closing dura, because it takes about an hour and a half just to put. I used to put 6-Proline with a very small needle with fine needles. So it's not worth it. I think it works out so well. Any other questions? Yes.
In general, that's my feeling and the way how I do the things. But I have a few cases when I had a dural tear. It's a small dural tear. I leave it there. I just put some taco seal on top and hope that it will seal. And most of the times it will seal, but I have a few cases when patients start becoming, and it's usually going to be a week later, or even sometimes I had a just recent case, which was a month later. She developed severe hypotension headaches, and I had to send her to have a blood patch. So what is your
so which size tube are you using? What I learned over time is the smallest tube you use, the less space you do for your entry. Yeah. That is always the best for the patient long term. So I think that causes the tamponade. We've had 1 or 2 patients out of I would say over 2,000 cases we've done now.
Actually, this was full endoscopic surgery. That was not even a tube. So that was basically.
But even smaller incision, even a smaller tube.
So what I started lately doing is, if I see a small breach, usually will be a very small dural tear. I try to stick a small piece of muscle inside just to plug it, and then on top of that, I will put a taco seal. But obviously, that's not with the endoscopic surgeries.
So, Nicola, it's very interesting. I used to be like, since I moved here and we're doing so much high volume here, and the more you look at your own case, if I was not satisfied, I would never. Now, when you look at the patients, if there's a symptomatic patient, then you have to worry about. There's 1 or 2 patients I can think of. Blood patch and all that doesn't work in such patients. But we have a dural leak so many times, especially with revisions. By revision surgery, 3rd patient, sometimes the dura is already open when you go there, when you put the tube in. So that's why I always dock it laterally on the facet and move a medial to a facetectomy before I want to come in medially doing that. So it has not been a problem with, and the cost is such a major issue in this country, right? Taco seal. Salman somehow smuggles a taco seal from outside, but we have not been able to. So it's a luxury, and no, we have Duraseal if used, but we just end up not using it. And the patients are, in fact, we are close to publishing this also, and multi-level 3-level bilateral decompressions.
That's my impression as well, and especially if I do fusions. I do fusion after somebody been there already once or twice, and scar tissues. And I also see a lot of small dural tears, and I'm usually greedy. I like to put a big cage, and I normally will have a small dural nip. Most often I will leave them like that, but sometimes I have some cases. So lately, if I can, I try to put at least a small piece of muscle there just to plug it.
So fusions, in fact, I would expect that the fusions will have more leak, right? If you have become more symptomatic. But with fusions, we've had even better success because with fusions, I don't want to look at the dura. You're doing a revision surgery.
Okay.
All you want to do is remove that facet. Complete facetectomy, stay lateral to the nerves between the exiting and interversing. Do that, do your interbody and get out, and then do your pork screws.
Same
Right.
with me,
Okay.
but maybe I'm greedier like you. I put bigger cages, but lately I use expandable, so I don't see.
Yeah.
Okay, thank
Great.
you, thank you. I think you're a very lucky man and don't have CSF leak. Thank you.
Now I would like to invite Dr. Onar Yemen from Turkey and talk on the vertebral plasty.
Okay, hello to everyone. The topic is vertebroplasty. I think vertebroplasty is, I will finish in 5 minutes. It's really a practical and very effective technique, but don't think it's a simple technique. You may have complications. So the indications are if the pains are not controlled with conservative treatment, and if the patient's quality of life has decreased, you may use this technique. So the main indications are, according to AO classification, you can use it in the A1, the trauma cases. And also this is a good classification that has been described by orthopedic surgeons in osteoporotic fractures. If the score is greater than 6, you have to need a surgery, but you have to decide if you need a vertebroplasty technique or not. So it's easy, simple. You can do it with local anesthesia and also with sedal analgesia. You can decrease the pain. So I want to give you some tricks here. These are the tools that we're using to surgery. So you have to have a good view. I think your technician make your surgery easy. I'm saying that I'm not doing the surgery. You are the surgery. You're the main actor there. If you can see the pedicles very proper, if you can see the end plates very good, you can do the surgery very easily. What I'm doing here in vertebroplasty, we are determining the levels, which level you want, and you have to be lateral to the pedicle that you're going to inject cement. So this is the entry point. If you're on the right side, you have to be at 3 o'clock. If you're on the left side, the entry point has to be 9 o'clock. So on the lateral view, the entry point is here. So the entry point is here. So then you, this is a case example at L5. This is the entry point. In every step, you have to check it. So if you're in the starting point, you have to be at the lateral part of the pedicle. If you're in the lateral view, if you're in this position, on the AP view, you have to be in the center of the pedicle. If you just entered the vertebral body, you have to be in the medial part of the pedicle. So you, another trick that I'm using here, I'm using the key wire to feel the bone in every step. And in every vertebroplasty case, you have to need a biopsy. The thing that I'm using is not a biopsy cannula or something like that. I'm using the bone filler as a, I just remove the inside part of the working cannula and I put the filler inside. I push it down to the anterior part. So I also drill it. I prepare myself for feeding the bone inside. So I'm starting from the anterior part. So every part you have to check if the cement is in the correct position or if you have any leakage. So in every step you have to check the C-arm. This is one side and this is the other side. This is after the vertebroplasty. Another case, that patient was a lowier. I told him you have to rest for at least 2 months or 3 months. He told me that I have to work. Is not there any other solution? I told him about vertebroplasty. This is not a case for vertebroplasty. You can wait for it, but he wanted me to do the vertebroplasty to return as soon as possible to the work. So don't select your cases that has any part as impacting to the spinal cord. What we have done here, we check the lateral part of the pedicle. We go inside, check every step. You see the pedicles are very thin here. We go inside, we take the AP and also the lateral views. So at the end, we prepare this place. We check it if you're in the bone or not with the key wire. We put the cement inside. This is after we have done. So how many cc's do we have to do it? There are lots of literature here, but what I'm doing, I just put 1 bone filler in the thoracic area, 2 bone filler at the lumbar area. So I don't try to finish all the bone filler at the thoracic area. 1.5 is enough. 2.5 for the lumbar area is enough. Nowadays, we have started with the navigation system, especially for the thoracic area. It helps you very much. So you can find the pedicle, you just go inside. If you're sure you're in the vertebral body, you remove it, you place your working cannula inside. So it's really a practical and effective technique, but it has complications, especially cement leakage. This is a case that has a cement leakage into the intradurala. This is one of the friends of Serdar Kahraman. Don't think, how could it happen? It may happen. Thank you so much for your interest. And I'd like to invite you to Istanbul Spine Masters. Thank you. Salman, 7 minutes. Okay.
Thank you. Thank you. I don't know what I'm doing here, but I had to do something. I had to say something. My wife is an endocrinologist. Okay, she works with bone metabolism. Had a very busy practice. I think every day around 6 to 7, sometimes more patients with osteoporosis and vertebral fractures. You know how many cases sent to vertebroplasty? Almost 0. Today is completely different, the management of fracture of osteoporosis we saw yesterday. It is incredible the improvement in the bone metabolism, what we improve in the treatment. I think the whole of the vertebroplasty today in the osteoporosis is extremely limited. I'm not saying almost, I don't know, what is the whole today in the osteoporosis?
We used to do one every week until 3 years ago.
Yeah.
And then since then, so many papers have come out that there are other options and they do very well. And now my last vertebroplasty was 2 years ago. So I think it's very, very rare. Seriously, all of them get better. Either nowadays, if possible, we give them teriparatide. We used to use calcitonin, but now it's banned because of carcinogenic effect. So that's what we use, and majority of the patients do very well. All they need is a couple of weeks.
The cases that I've shown you were the trauma cases, but I don't think like you're thinking. In some selective cases, okay, if the patient has severe pain, if you cannot control it, okay, I'm not saying that apply vertebroplasty to all osteoporotic cases. This is the wrong message, okay? In some cases, if the patient has severe pain and if the patient doesn't want to stay in a bed, or if the patient doesn't have time, has limited conditions, and if the patient says that you can apply it, because lots of patients are coming to the outpatient clinic, they say that a doctor has told me, please do a vertebroplasty, okay? So the indications are not in the limits of the surgery. So they have just an end plate fracture. So you don't have to do it. You can wait for them.
So Louis, a question and a comment to
So Louis, I want to ensure that your wife is seeing all these patients. Hopefully she's not referring to somebody else, right? Or these patients. Secondly, that's a joke. So
I have no idea how to do that.
I think the numbers have gone down with all the newer medications which are coming out for osteoporosis and all that. Una, we still do it every couple, at least 1 or 2 a month, right? For mostly after they've had failed conservative management. But we do a kyphoplasty. What is your take on kypho versus? Because I feel that you can have height restoration with the kyphoplasty. We put a balloon in and you can get a height, and then you can over 1 year. Pain management is the same, but especially when you do your deformity scoliosis, you must be putting some cement as a vertebroplasty while you do that.
If you compare kyphoplasty and vertebroplasty, the only advantage of kyphoplasty, you can restore the vertebral body. But the disadvantage is the cost effect. For all the adult degenerative scoliosis cases, the main problem is the osteoporosis and the pull-out of the screws. So you have to use, if you want to correct and if you want to decrease the pull-out of screws, you have to use at least cannulated screws, or you can put cement inside and you can insert your screws on the cement. So you have to use to, let's say, reduce the complications of your surgery.
Do you know what's happening in the whole world? The people do vertebroplasty, break up and down, and don't treat the osteoporosis. 90% of the patients seen by orthopedics, they don't treat osteoporosis correctly. If they treat correctly, there is no, it's the same way prolactinoma. There is a lot of people operating prolactinoma, macroprolactinoma with deficit. 99% you give one pill and solve the problem. This is the problem. This is the problem.
Just humbly, I want to learn what is the effective treatment of the osteoporosis, except the teriparatide. What is the effective treatment?
Oh, there is a lot. I have no idea about that, but I can do.
I can send you the guideline.
I had a question.
And for pain also, they control.
Give me your brother.
Man, it's completely different world. It's improved a lot. Improve a lot.
Excuse me, I have a question.
It's our no knowledge. It's not to say that it doesn't work. Please, okay. The next speaker. Yeah. Where is the speaker? Come.
Why MIS surgery?
MIS.
Why MIS surgery?
Why?
Miss surgery.
Why?
But I hope this cartoon is not, why is not showing?
We miss your presentation.
Because it's missing. So I'm hoping that I'll be preaching to the converted. So I really hope that basic surgery is more and bigger part of the spinal practice wherever we go. At least that's what's happening. I still don't have official statistics, but the companies which are selling us different devices for minimal invasive surgery, they do more and more money. I will project it is from 2022 to 2032, they will make 3 times more money from medical staff. So it is worth it. It's having. Although my presentation is not There you are. Okay, right. I forgot. Apologize if that cartoon is offensive for some of you. I was said that this is offensive. I'll change it by somebody, not in this country, in another country. Anyway, so this is my place. This is where I work. I'll crack on straight. Exponential surgical tech evolution. You can see for the last 50, 60 years, the surgical techniques are evolving quite significantly over the last 20, 30 years. We have evolved quite many minimal invasive techniques. You can see that we have multiple surgical minimal invasive options. There is no official statistics of how much minimal invasive surgery we do as part of our whole spinal work, but I still have this company data. I don't have anything after that. There are about 30% in US, still not as much in the world, but that's what I told you here is that they're expecting to make more money. So it is more and more people are doing it. So the concept of the surgery, if you think why minimally invasive? So in general, concept of surgery is you have to locate a target inside the body. You have to then reach that target. And by reaching the target, you're breaking tissues which are normal. And that's why you would like to do it as small as possible. And this is the end point that you have to reach, and you can reach it from here. You can reach it from here. So it is, sorry, yeah. So this is the end point in the middle, and you have to reach it from the two sides, and you have to decide which way you want to go. And obviously, it's a no-brainer. If that's my spine, I would like to the left side rather than the left side rather than the right side. So why minimal invasive surgery, Luis? Because now we have overwhelming data to suggest that you will treat your patients with less blood loss, with less infection, faster recovery. The patients will be going out of the hospital faster. You will treat patients that you would otherwise not treat, like old patients, like obese patients. It is cost effective, especially in the long run, if you calculate all the benefits, and it's affordable. I will show you why. So the minimal invasive principles, you have to preserve the muscles, you have to preserve the ligaments. And if you think this is minimal invasive surgery, so we are all doing minimal invasive surgery, but we have to go further. So muscles are one of the most important things that we have to prevent. But of course, there is things which are still deterring us. If we are talking why we have to do minimal invasive surgery, then obviously there is things that we have to answer why we have to go there, why we should go out of our comfort. So yeah, it's a learning curve that is long. There is a radiation exposure. You need equipment, you need specific techniques that you have to develop, but there is solution for all that. So a long learning curve. Yes, it's a long and steep learning curve. And why we say it's a steep learning curve? Because you need to double your time to progress to the next level. So if you do 50 cases, you're still novice, you know what is that minimal invasive surgery. Then when you double your cases, you become hobbyists, you know a bit more. And then you really have to do 200-300 cases to call yourself expert. So that's why the learning curve is steep. Yes, in the beginning, you have to be prepared for disasters. Yes, disasters are coming. You have to be prepared with that. That's inevitable if you're developing a new technique. Yes, your first steps will be difficult. But with proper mentorship and with proper approach, you can break the long and steep path to multiple small tasks, and then you can succeed. So it is something that is inevitable, that will be a big part of your practice. So you have to look into that. So yes, there is radiation exposure. The new navigation techniques are still not completely and widely available. So still many people work with X-rays. We have to think about the X-rays, about the radiation exposure that we have. It is something that I will talk more in details tomorrow, how we use the X-ray effectively and more importantly, safely. But I will tell you a few words today. So it's important for you to not ignore the protective equipment. It is important to appreciate the distance. If you're 3 meters away from the source, you practically can be without any protection. If you're only 60 centimeters from the source on a specific position, then your dose will drop 8 times. And this is what I mean. You can see you have to choose your site wisely. If you're on the side of the source, and then if you're 60 centimeters away from the patient, from the object, your radiation dose drops significantly. So you have to be on the right side, like with anything in life. You have to be choosing your site wisely. Gloves are giving you deceptive security, so don't use gloves. Just don't be fooled to put your body parts under the beam and you'll be fine. Minimal invasive equipment, yes, that is important for you to have. There is multiple different toys that you can use, like special table, like special retractors. But if you think out of the box, you can go around it, and you still can apply the principles of the minimal invasive surgery, and you can do something. It might not be the way that the people in New York are doing it, but if you still apply the principles, that still will be beneficial for your patients. I've personally started with this table in the beginning, and I still use it. Every single surgical table now has a radiolucent part, so it's a matter of proper positioning of the patient for you to be possible to do a simple X-ray, to do minimal invasive. Nearly every retractor can be used in a minimal invasive way. So I still sometimes use this McCulloch retractor, and that gives me decent exposure and still small and less invasive approach than anything else. So with the retractor, you still can you can use nearly every retractor the way you use tubes. By tilting the retractor, you can do pretty decent decompressions, even though you're using minimal invasive technique. So I've done some audit of my practice. I was surprised. Lately, we had a webinar with colleagues from around the world, and it was on minimal invasive and African surgery. And it was said that the Jamshidi needle placement of the screws is not practiced in many places, but unfortunately we still don't have navigation widely spread, so that's needed. So don't forget the old techniques, and with proper technique and with proper practice, you can become very effective with a simple Jamshidi and with simple X-ray. You can do revision surgeries. You can do different things that will be possible to do with the navigated systems. So another problem that is quite often quoted for minimal invasive fusions, for example, is the way how we fuse, the success rate of the fusion. If you use a proper technique, you will have a good fusion. This is now a few years ago, I decided to see how much I have prepared the end plate, and I put an endoscope inside. And I have horrified myself after 20 minutes working in the end plate. It still did not look like the other one on the other side, the way we are used to see, for example, corpectomy in the neck. So a proper technique and a meticulous preparation is important, and that will help you with your fusion rates. I started using lately, I don't use BMP because it's too expensive, but I started using lately this simple device which you can find in every ICU, that is collecting the bone dust when I'm drilling, and so it's separating it from the blood, and then the nurse will do the final squeeze, and it will give you at the end It will give you just a bone dust that you can put in your cage. I use this drill bit, which is known as matchstick, and it's not heating up, so it's not killing the cells. Nerve roots at risk is another thing that's stopping many people to do minimal invasive. I was experimenting with that as well over the years. Initially, I started doing complete facetectomies, but as if we're saying, if you don't want to damage something, you don't expose it. So I started using this overhang technique. You can see down left that piece of the facet in red. I leave it there, and that is protecting the nerve all the time. You can use the steps that you can see, the steps that I'm using here. This 1, 2, 3, 4 is the cuts and partial removal of the facet, and then you can see that the partial removal of the facet is constantly pushing the instruments away from the nerve roots, and like that is keeping it intact. And this is how it looks like on X-ray. You can see the upper and lower cuts that I do on the X-ray there, if you want to do it just with X-ray. And then the hook is demonstrating to you the overhang. And then you can see here constantly on the upper side of the instrument, there is enough space for the nerve to be accommodated and not to be damaged. Minimal invasive surgery. Why? It is, again, less blood loss, less infections, faster recovery. We know all that, but more importantly, it could be affordable. You don't need very expensive instruments to do it. If you think out of the box, you can do it. Start tomorrow. Thank you.
Thank you very much, Nikolai. You have some questions to him about the why miss? If no, I think you can end the session. Thank you very much. Thank you.
Thank you. So to moderate the next session, I would like to invite Professor Amir Saghir and Professor Sardar Karaman to come on the stage, please.
So we can move on to the next session. So the first speaker of the session is Graham Fuller. Yes, he's talking about the global perspective on the treatment of hydrocephalus, lifelong implications. Please, Graham. Well done. Yes.
What I'm going to do, what you asked us to do yesterday, when I can stretch. So yeah.
Yes.
Sharif will take us through another aerobics exercise. And you do the South African. Even at the back. Stand up. Stand up and stretch.
Please stand up and stretch, please.
Right, so get going. So thank you. You'll be pleased to know this is the last time you're going to hear from me. That's the last talk. And Professor Sharif has given me the thrilling topic of hydrocephalus. And the one thing I think one always knows, standing up before a bunch of neurosurgeons, the one operation every neurosurgeon's done is put in a shunt. So every neurosurgeon knows everything there is to know about shunts. So I thought I'd take this talk in hopefully a slightly different direction. So let's start off with a definition. What is hydrocephalus? And the standard definition would be a hydrodynamic disorder, CSF, associated usually with increased volume and increased pressure. I much prefer Jack Walker's definition, which is hydro equals shunts and cephalus equals many. And I think many people in this room would agree with that. And just as a disclaimer, I love shunts. I think they're fantastic, and I love endoscopy even more. And hopefully that'll become apparent why. So Michael Dewan has done some really great work looking at global incidence of different conditions around the world, and has documented, obviously, this massive burden of hydrocephalus in the global south. I mean, that together with spina bifida, major neurosurgical burdens in your country and my country, and important issues to address. So we've written a bit about this. A textbook on CSF disorders. My colleague Nico Ensign and I looked at a global perspective, as this talk is meant to be, and the different treatment options for hydrocephalus. And there's a long, long list. And we know from the time we undergraduates in medical school, when there's a long list of things you can do for a condition, means none of them really actually work well enough. So I think we've still got a bit more work to do in understanding and treating hydrocephalus. There's a great supplement, Neurology India, a couple of years ago, looking at hydrocephalus. And one of the issues that we addressed in an article in that was the nature of hydrocephalus in low and middle income countries. And the truth of the matter is that hydrocephalus in our settings is usually more complex, much higher incidence of infections, post-infectious hydrocephalus, often multiloculated, can be a real nightmare to treat. So you not only have sometimes less advantageous surgical conditions, you also have often more challenging patients to treat who almost invariably present much later, with thinner scalps and poor nutrition and all those challenges, which makes the job a lot harder. So if you look at the ISPN guide, just for those of you who weren't in the previous talks, just once again, just to punt the ISPN, the International Society for Pediatric Neurosurgery, and this really lovely online resource, the ISPN guide, that has lots of information about pediatric neurosurgery. If you look at the section on treating hydrocephalus, there's a chapter by Matthew Vanchon, who works in France, and Matthew has looked at hundreds and hundreds and hundreds of shunts he's put in over the course of his career. And as part of his contribution, has sort of mapped the sort of 40-year survival of shunts. The amazing thing is some shunts, maybe 10%, actually do function for that long. But the vast majority of shunts, I think a pretty good rule of thumb is 50% of shunts will malfunction within the first 2 to 3 years. So kind of that's puzzling, and you kind of think, well, this is a simple thing. You just need a tube to divert the CSF. And when I was a newly qualified, bright-eyed and bushy-tailed young pediatric neurosurgeon, Christian St. Rose came to visit us in South Africa. And I took him on a trip to game reserve. And I remember saying to him, we were kind of sitting under a tree in this beautiful game reserve. I thought, this is the moment to get him wisdom from this great master of hydrocephalus and pediatric neurosurgery. So I said to Christian, what is the secret? Like, because he had developed the Orbis Sigma shunt and had been a real innovator and kind of understood CSF and hydrocephalus in ways that very few neurosurgeons do. And in his very Gallic way, he replied, avoids a bad start. And I think that's the wisest words I've ever heard in neurosurgery. And the truth of the matter is that shunts are always condemned to the end of the operating list, often a junior resident. And actually, I'd put it to you that the most important operation we often do in someone's life is put in their first shunt. And if you mess that up, you're just condemning that patient to a life of misery. It's so easy to underappreciate the importance of that first shunt. It's a simple operation. It's not a skull-based tumor. It's not a complex thing, but the consequences of getting it wrong are catastrophic. So we need to take shunts more seriously, and please, for goodness sake, avoid a bad start, because once you're off to a bad start to the shunt, you're pretty doomed, you and the patient. So Matthew also in that same analysis looked at the outcomes. Pretty much half of kids with shunts, kids with hydrocephalus have normal IQ, but only a third will end up in sort of paid work as adults. And there are many reasons for that. And obviously, underlying pathology is the major contributor, but having shunt complications definitely does nothing to help in that regard. All right, so kind of that's the story of shunt. So classic hypothesis of CSF hydrodynamics. So we get taught this in medical school, choroid plexus churning out CSF, and it flows very conveniently down these pathways, gets reabsorbed in the arachnoid villi, and that all seems very cool. And that got outlined by Cushing more than 100 years ago in the Cameron lectures published in the Lancet. And we know the mantra 500 mils over 24 hours, it's a nice mechanical buffer for the brain, pulsatile flow of CSF. And we, that just kind of makes perfect sense. And many of our interventions are based on that concept. So based on that understanding of CSF flow, we do third ventriculostomies, and it's such a cool operation. And my career sort of straddled the sort of pre-endoscopy era and now the sort of era of endoscopy. And there's no question, endoscopy has completely changed the game in terms of treating hydrocephalus, and can do these operations, beautiful anatomy, which is also nice. And you really feel like you're doing something. And you ask most neurosurgeons how this works, they'll tell you you're bypassing a block. And that's actually what you're doing. So we see a lot of tuberculous meningitis in South Africa. We've also tried to use ETV and tuberculous meningitis. And I'm showing this not to advocate for doing endoscopy and TBM, because it should not be your first choice intervention. It's a complicated and not that easy intervention. But we approach this from the point of view of trying to understand what's happening to CSF dynamics. And my colleague Tony Fagaci worked out a protocol doing an encephalogram, trying to determine if you had obstructive or communicating hydrocephalus. And a number of groups in India who are also treating a lot of TBM said, actually, that's irrelevant. You can do this in communicating hydrocephalus, which is heretical. Like, there's no way. I mean, where's the block in communicating hydrocephalus? But in fact, it made us think a little bit more about what's going on. So it does work. There's no question it works. But how does it work? Does it work by bypassing a downstream block to CSF flow, and you're just equalizing hydrostatic pressure? Possibly. Does it work by altering CSF pulsation? And that would be an argument for using it communicating hydrocephalus. And that's possible. Or does it work through equalizing oncotic pressure in different compartments? And I think increasingly that notion of different oncotic pressure in different spaces intracranially is gaining currency. And of course, if it doesn't work and you've really got your back to the wall, you can think about doing choroid plexus coagulation. But once again, choroid plexus coagulation really should work. If the classic hypothesis is correct, it really, really should work. But since Dandy's time, it hasn't ever really worked particularly well. So there's clearly a lot going on here we don't really understand. And some of you will have seen this paper in neurosurgery last year from the group at UAB, basically taking quite an extreme view that the classic thinking is now so thoroughly disproven, should be chucked out, and the textbooks need to be rewritten. And the thinking that emanated from Croatia around CSF hydrodynamics, in their view, is sort of now the sort of mainstream idea. Now, I'm just going to go through this briefly, and I'm not going through this now to sort of say that this is what I believe, but I really do think that our fundamental understanding of CSF physiology is about to be turned on its head. And that classic hypothesis that served us well for 100 years probably is going to have to be radically revised or completely chucked out one way or another. So in terms of the Croatian, to maybe put it in a simpler term than Bulat, Klarica, Orešković, the Croatian thinking is choroid plexus is not the site of CSF production. There's no circulation of CSF. And in fact, what's at play here is osmolality, not hydrodynamics. And in this paper, they kind of go through some of the evidence on which the classic hypothesis is based and describe their own approach. And this is work done over 20 or 30 years. So this is not some fly-by-night. Some guy woke up and decided they're going to cause some trouble. They've really been thinking about this in a very organized way for a long time. And they're absolutely convinced that their experimental work in hundreds and hundreds of dogs suggests that there's zero net CSF production, zero, that there's no such thing as CSF production by the choroid plexus and flow down the conventional CSF pathways. So in fact, I went to a meeting where they presented and was so intrigued. I went to go and visit them in Croatia. And I must say, I think there's something in this. Even I can't persuade my own department that this is the way to think about this, but I think there's something in this. So part of the way in which I think we need to start reconsidering CSF dynamics on hydrocephalus is thinking much more closely about the relationship between the neurovascular units and CSF, and start thinking in a much more integrated way. And rather than thinking of CSF as some isolated separate compartment, the perivascular space, I think is really kind of the highway to understanding her. And what exactly the role of perivascular space is not that clear. It's the so-called lymphatic circulation that I'm sure you've all come across. Is the notion that there is this flow of interstitial fluid, that fluid flows from the ventricle along the periarterial space, and then through aquaporin 4 channels into the brain, and then somehow exits the brain. Now, the problem is that nobody's demonstrated how that fluid gets out of the brain. So there's no perivenular equivalent of the periarterial space. So there's big question marks there, but the fact is that there's clearly more going on here than just CSF chugging around the sort of the CSF pathways. And there are lots of articles here. This I thought was quite a useful review by some workers in New York, really looking at this idea of how water essentially can flow through the brain and then plays a role in clearing toxic metabolites, but also plays a role in CSF homeostasis. And ultimately, this kind of comes down to trying to understand water in the brain as a whole. So rather than just CSF in the compartments, trying to understand dynamics of water across all the different intracranial spaces. And the fact of the matter is that the brain is actually 80% water. So it's a fairly fundamental thing to try to understand. And I think we've really just had far too simplistic approach to it. So does it matter? Well, if we could only treat things in neurosurgery that we understood, I think we wouldn't be doing very much, because I think most things we treat in neurosurgery, we don't really understand very well yet. So incomplete understanding is definitely not a barrier to trying to do your best for the patient. I'm definitely not saying that we should radically change our approach to treatment. I think if a kid's got hydrocephalus and an adult's got hydrocephalus, you got to do the best thing you can with what you have available, whether it's going to be to put in a shunt or do an ETV or do lumbar punctures, diuretics, I mean, whatever seems to be the rational treatment. But there's so many anomalies, so many things that don't add up, like normal pressure hydrocephalus, like syringomyelia, like low pressure hydrocephalus, all these concepts that we have that are these aberrations that somehow we kind of make some excuse for. But I think the fundamental issue here is that we haven't really actually fully understood the basic physiology. And part of that is, what is the role of the choroid plexus? Is it a good thing to be cooking the choroid plexus or not? I don't know. Maybe not. So I think my conclusions would be that it's definitely worth reading history and understanding where our concepts come from. Probably best to read history yourself and make your own interpretation. We do give things names. I mean, a diagnosis is the most important thing in medicine, but it's also the most dangerous, because once somebody has a diagnosis, we all see how often people stop thinking. And I think once we have an explanation for things, even if it doesn't actually fully explain what we're trying to explain, we stop thinking. The term cerebrospinal fluid is probably unhelpful because kind of implies a very distinct entity, which probably it isn't. We're just talking water in different intracranial spaces. And remember, water and the molecules in it move independently. And a lot of the work that has misled us relates to putting radio traces and other things in water and assuming that those radio traces, their movement reflects water movement, and they may not. And treating hydrocephalus is about a hell of a lot more than just diverting CSF. So just in case any of you didn't get the message about coming to Cape Town, it'd be great to see you there. And on that note, thank you very much.
Thank you. Great. Is there any question or comment about the hydrocephalus?
Mr. Chairman, it's not so much about hydrocephalus, but it's more about what a pleasure it is in this age to listen to a thinking neurosurgeon rather than somebody who's just telling us how to do it. Great talk, Ram. And I was also, like you, extremely intrigued by this Croatia story. And the only comment I have is that I was intrigued enough to trace this, and it first appeared in the neurosurgical literature. I'm making an assumption here, because some young person from America went to visit them, also was kind of taken up by this, and then published it with them in the Red Journal. You know, so I thought, oh, this guy went there, and did he drop his discrimination when he was looking at this? Because there's very little else. You know how things sound true when you can add up strands of information from here and there.
Yeah.
So there's just this. And you've been there and you came away thinking, there's something here.
Yeah.
So I'm also intrigued by this, and I'm watching this space. I really would like to see somebody else do that, because they've done work in the lab, and it's a department of anatomical pathology or something.
It's pharmacology.
Yeah,
it's pharmacology.
It's not serious. So you know, I'm quite intrigued, but it just affects our understanding, but won't affect, I think, realistically what we do. But thank you for that talk.
Thank you, Prof. Juma. Yeah.
Okay, thank you. I am asking for the daily practice, Graham. Is there any trick that you use for an endoscopic ventriculostomy dysfunction in pediatric age or in adults? And any surgical trick that you use to reclosing of the endoscopic ventriculostomy to prevent the ventriculostomy closing?
Yeah, so that's a great question. I mean, I think ventriculostomies close because they're not working. I'm not sure they stop working because they're closed. I think if you've corrected the hydrodynamic disorder, whatever it is, and the ETV is working, then it closes over. The chances of when you redo a stoma, there's a very low incidence of that working.
Okay.
So for me, and we don't have the resources. I don't know how many of your centers have the resources to do regular follow-up MRI scans. I mean, I think the big advantage of an ETV is that it's very cost effective, and it's a cheap intervention. Don't leave any hardware behind. To then be scanning the patient every year, which is the case in some countries, kind of it's just not affordable for us. So we follow the patients clinically. And if they then present, the first time they re-present with features of raised pressure, we probably will redo the ETV, but not with a great sense of optimism. But I think putting in some sort of stent, or people have described different interventions to try to keep the stoma open. I'm not sure that makes any sense. Do you have a experience with that?
Okay. I mean that you use the balloon or the mechanical.
Oh, in terms of making stoma, just a balloon.
Okay.
Yeah. But I mean, the deck forceps are also a good option.
Excuse me.
Cool.
Excuse me, my question is about septated hydrocephalus. We see a lot of complex hydrocephalosis here. Excuse me.
Sorry, sir. Yes,
how you treat a septated hydrocephalus? We see a lot of complex hydrocephalosis. Like there are so many septas there. We put a shunt in one septa, other one enlarges, and vice versa. So how you treat septated hydrocephalus? And a second question, for large hydrocephalosis where mental thickness or cortical thickness is very small, what is the limit of cortical thickness you keep is for putting a shunt in? That it must be so much thick, cortical thickness in huge hydrocephalosis.
Yeah, so to answer your second question first, I mean, those are heart sink cases when you get these kids to come in with massive heads. And I mean, I think ultimately one does need to have some sort of cranial remodeling if you really are going to be committed to a successful outcome. When you put a shunt in, as you say, you know, the thin little cortical ribbon just falls away, end up with huge subdural collections. and you end up then chasing your tail with those subdural collections. And ETV almost never works. And in fact, I'd probably say, and I think you'd agree with this, it never works. It's pointless almost in that situation. So I think a cranial remodeling, which is a massive undertaking, is probably what one needs to do. For your first question, so for multiloculated hydrocephalus, I think the simpler you can keep things in neurosurgery, the better. And for me, the most logical approach is to plan a shunt. And I'm sure you're not meant to do this, but we do. So plan, if you've got 3 or 4 loculations that you're going to get the shunt through, make a few extra fenestrations in the shunt catheter and just put a shunt in and then see what you're left with. I think this idea of trying to be too clever and using an endoscope and making lots of fenestrations and stuff, I'm not convinced. You can't predict
and
whether it's going to work. And I think the simplest thing is put in a shunt, see what you're left with, and then take it from there.
Thank you.
Okay, thank you, Professor
Yes,
Graham.
thank you very much. It is an interesting topic. So there are some patients which are not good candidate for ETV and VP shunt, like premature baby, low birth weight baby, hemorrhagic CSF. For that, we use temporarily ventriculosubgaleal shunt. So what you will comment on this?
Yeah.
Thank you.
So the ventricular subgaleal shunts are great, and we use them a lot in small babies. The important thing, and I suspect it would be as much of a problem for you as it is for us, is to make sure that the family understand that this is very seldom definitive, and the kids need to come back for follow-up, and you've got to follow those kids very carefully, because we've had a few patients with ventricular subgaleal shunts who've come from rural areas, they've gone back, they come back a year later and they've got massive heads, and clearly it's been a complete failure of treatment, because you wouldn't have expected it to control the hydrocephalus effectively. It's a temporizing measure, but the family or the healthcare system, whatever, didn't quite get that message. So I think having people understand that it's a temporizing measure, it's almost never a definitive intervention.
Okay, thank you, Professor Graham. Thank you so much. Okay, thank you for sharing your nice experience. Very nice talk. Our next speaker is Professor Hassan Saeed, and he is talking about theatered cord and spinal dysraphism. Thank you.
Good afternoon, everybody. Continuing on with the theme of pediatric neurosurgery, I was tasked to discuss neurosurgical management of spinal dysraphism. So I want to do this in 3 ways. 1, review the historical perspectives. 2, define what spinal dysraphism is and sort of how I classify it in a simplified way, and then compare some operative management strategies for these cases. So looking at the history, this is something that has been described as early as 10,000 BC, descriptions of spinal malformations, and they've been seen historically throughout texts, as well as these models that are displayed on the right side. The first or earliest description of surgery was back in the 1600s by Van Forest, which he described a neck malformation that he ligated, and ultimately this child ended up passing away. And this similar experience was also observed by Tulp, who was a Dutch anatomist, and because of their experiences, it essentially became a non-operative pathology. But it wasn't really until the 1800s and then the 19th century where, again, surgical techniques were refined, better operative techniques and management strategies were employed, that surgery was recommended for these conditions. And in fact, in the 1850s, at least at the Hospital for Sick Children, was the first time that lipomyelomeningocele were operated on. Fast forward to the early and mid 20th century, there was a recognition of the signs and symptoms of this syndrome itself and its association with urinary, cutaneous, orthopedic, and skeletal abnormalities as well, and this phenomenon known as occult spinal dysraphism. And so a lot of this work also was used to separate the diagnosis of tethered cord syndrome in those patients that existed without any apparent signs or cutaneous manifestations that also lended itself in the spectrum of spinal dysraphism. And when you think about the modern era, there's improved diagnosis with imaging studies, and the standards of care have improved, not only from a neurosurgical standpoint, but also from a physical medicine and rehabilitation standpoint for these cases. In the 1940s, Ingram and Hamlin described 280 cases of myelomeningocele. In the 1960s, the standard of care for these cases, at least for myelomeningocele, recommended surgery within the early days of life. And certainly we've seen the importance of folic acid supplementation and the use of ultrasounds as well in the care for these patients. So when we look at the spectrum of the historical path for treatment of spinal dysraphism, we see initially Tulip's advice against surgical management, and now we're seeing in the US prenatal diagnosis and in fact prenatal surgery for these conditions, and I'll discuss that briefly as well. So looking at the embryology, I think we're all familiar with the normal embryological development, including primary and secondary neurulation, where the neural tube forms and the neural tube ends up becoming the central nervous system. Of course, failure of the neuropore to close can cause neural tube defects. The anterior neuropore leads to something incompatible with life, with anencephaly, and the posterior neuropore, as we know, leads to spinal dysraphism. The embryogenesis can further be summarized into 3 stages, but certainly we know best with primary neurulation, secondary neurulation, and some of the conditions that can occur because of aberrations and retrogressive differentiation that can lead to phylum terminale conditions as well. So it's important to note cutaneous manifestations when it relates to spinal dysraphism, especially occult spinal dysraphism. You see images of vestigial tail formation, cutaneous hemangiomas, subcutaneous lipomas, hypertrichosis, and sacral dimples, particularly above the gluteal crease. And so that's important to note in the workup for these conditions. So what is spinal dysraphism? It's a midline fusion defect, and this defect can be with the bone, with skin, with the spinal cord and spinal column itself as well. And so this is how I classify spinal dysraphism. Ultimately, there are those that are open conditions like myelomeningocele and others, and then closed spinal dysraphism with subcutaneous masses that can include lipomyelomeningocele and terminal myelocystoceles, and those without subcutaneous masses that are more occult, including split cord malformations, spinal lipomas, tethered spinal cords, and dermal sinus tract. The condition of tethered spinal cord is really something that's diagnosed clinically, not necessarily radiographically. Again, it can lead to symptoms in older children with back pain, numbness, weakness, bowel or bladder incontinence. And it's really characterized by an abnormally low-lying conus that's tethered and associated with a multitude of dystrophic conditions. And again, the radiographic diagnosis does not always correlate with clinical presentation, which is also critical in terms of whether surgery is recommended or not. Looking at the position of the conus, we know that when a child is born, it isn't the final position of the conus, and so we typically will wait 2 months postnatal to determine the final position of the conus, which is important, especially for those babies that we do get ultrasounds for. So in terms of myelomeningocele, I'm certain that the surgeons who are here in Pakistan can talk more about myelomeningocele compared to the US, just probably given the amount that you see. But there are around 2,500 births per year in the US. This results, as we talked about, because of the failure of caudal neural tube closure, and leads to a small posterior fossa, Chiari-2 malformation, and other radiographic conditions that we know about. There's also a large presence of hydrocephalus. 85% can be in the caudal thoracolumbar spine. And again, they're associated with folate deficiency as well. At least in the US, there is prenatal diagnosis with maternal AFP and ultrasound for initial screening. In terms of the ultrasound findings, we oftentimes see the so-called lemon sign, which is scalloping of the frontal bones, and the banana sign, which is an abnormally shaped midbrain and an elongated cerebellum. We will also order fetal MRIs to look at the anatomy in more detail as well. And on the left, you can see the ultrasound findings of the so-called lemon sign and the banana sign. This is just an example of fetal MRI that we will often get with the prenatal team that demonstrates this spinal dysraphism state. Speaking specifically about myelomeningocele, there's a spectrum in terms of signs and symptoms. Oftentimes there's lower extremity paralysis depending on the level. These myelomeningocele can be ruptured or unruptured. And the management prior to surgery involves prophylactic antibiotics and then closure within 24 to 72 hours. These again are errors of neurulation, and the surgical objectives really are to protect and preserve the neural tissue, identify the placode, and reconstruct the neural tube in order to untether the cord, do a dural closure, and reapproximate the skin and fascial tissue. This is just a case of a thoracolumbar myelomeningocele with kyphotic deformity, which again was treated in the same surgical manner that we talked about. Again, pictures of the closure that you all know very well about. So speaking about the intrauterine closure, so there was a MOMS trial that was published in the US of 183 patients from 3 centers. And what they found in terms of outcomes postnatal closure versus prenatal closure was at 1 year, the shunt rate was lower, Chiari-2 malformation was lower, and ambulation was higher as well. But certainly there were some disadvantages, including increased preterm labor, wound dehiscence, and early retethering as well. Since that time, there are many different techniques to do this, whether it's open or fetoscopically done through a 2-port or 3-port technique, closures done in a single layer up to 3 layers. And so these are all ongoing discussions currently. With respect to management of hydrocephalus, the simultaneous shunting that was done in the past has been abandoned. Not all patients need shunts, as we know, particularly those with lower myelomeningocele, and there can be an association with higher morbidity as well. Typically at our center, we watch after closure of myelomeningocele, and if there are signs or progressive enlargement of the head circumference associated with ventriculomegaly, we will treat. The question is whether we put a shunt in versus doing an ETV with or without choroid plexus cauterization. There have been many papers to address this. Certainly those that have seen success doing the ETV with CPC. My personal preference is doing an ETV with CPC in this particular patient population using the flexible endoscope. And this is just a picture of that setup. We turn the head as if we're doing a right-sided shunt. If we do need to abandon the procedure for an ETV, but it also helps patients who don't have a septum to drop the choroid plexus all in one direction, and so the cauterization can be done in an easier fashion. And so this is just pictures of performing the ETV and the choroid plexus cauterization as well. Speaking towards folate fortification, I know that we mentioned this as well, but very important to advocate for this at all levels and all countries as well. So moving towards lipomyelomenigoceles, these are closed spinal dystrophism with subcutaneous masses, first described in the 1850s. 1 in 4,000 births in the US. And it's relatively a misleading term, but it really implies herniation of the neural elements through a defect with a subcutaneous lipomatous mass that protrudes through a bony defect, displaces the dura, and infiltrates the tethered cord. Neural elements usually remain in the spinal canal, but it's important to understand the anatomy and approach this in a way that's safe surgically. Lipomyelomyosarcomas are associated with these cutaneous manifestations, including a soft tissue mass and skin dimples. And the symptoms can be similar to what we've discussed already, but the evaluation involves an MRI to understand the anatomy of the lipoma, where it is within the spinal canal and what can be done. We also typically will do urodynamic studies as well, but ultimately the operative goals are to detach the spinal cord from tethering, decompress this intramedullary mass. We use ultrasound, CO2 or YAG laser as well that will help shave this fatty tissue as well, and then reconstruct the spinal cord and dural sac. Split cord malformations are also very interesting anatomically. They're extremely rare, 1 in 5,000 live births in the US. The peak age is 4 to 7 for presentation, and also 12 to 16 years of age. And historically, many terms have been used to describe this. There are 2 types, and essentially they're differentiated by whether there's 1 or 2 dural sleeves. The surgical management for this, if symptomatic, is to untether the spinal cord, whether that's cutting the phylum, burring down the bony spur, and dealing with anything that could be, again, tethering the spinal cord. So this is just a case example of a two-year-old boy who hadn't walked, had some hypertrichosis, and was found on this MRI scan to have the split cord malformation, looking like it was, in 1 dural sleeve. And so these are some intraoperative pictures demonstrating the phylum that's thickened, the bony spur that's first burred down prior to cutting the phylum in order to detether the spinal cord. Very briefly, terminal myelocystocele. This was something of interest where I did my fellowship in Chicago. There are many cases, partly because of McClone, who was a pediatric neurosurgeon there, and his interests, as well as Robin Bowman. But terminal myelocystocele are a rare form of spinal dystrophism that constitute approximately 5% of skin-covered lumbosacral spina bifida. And the condition particularly can be associated with what's called cloacal anomalies, which can include omphaloceles, bladder exostrophy, ambiguous genitalia, and imperforate anus. So this is an interesting category in terms of spinal dystrophism. But the Chicago experience, there are about 55 patients in a median follow-up of 12 years. There were 12 cases in the 1980s, and by 2010, there were about 9 cases. But these terminal myelocystocele were then stratified with those with cloacal anomalies and those with non-cloacal anomalies. And essentially, those with cloacal anomalies had a high incidence of cloacal exostrophy, which led to, and this category led to more neurological deficits as opposed to those with non-cloacal anomalies. They're again associated with fatty mass and a lipoma. In terms of surgical repair, this condition was associated with more CSF leak compared to others. And when we look at long-term clinical outcomes, again, urinary continence was better in those with non-cloacal groups than those without. I'm going to skip the spinal dermal sinus tract and fatty phylum. Other than speaking about tubular retractors, we do use tubular retractors for sectioning fatty phylums. Certainly, the anastomose clips are helpful in terms of dural closure in these conditions as well. Not all low-lying conuses need to be sectioned. So just important to note that there are some non-surgical treatments for this, and not everything needs surgery itself. Thank you.
Any questions?
Thank you. It was a nice presentation. I would like to ask about a query that whether a patient having a myelomyosarcoma with the carry type 2 malformation, like with the tonsillar descent, what do you proceed? Like you have an MRI of the child who have tonsillar descent with the meningocele. So you operate for the meningocele first, or you go for the tonsillar, you deal with the tonsil first?
So sorry, if I understand you correctly, for a patient who has myelomeningocele, which by definition they have a KRA2 malformation, you would treat the myelomeningocele first, closure of the myelomeningocele. There's certain population of patients who, can develop some symptoms that are related to a Chiari and may need a decompression, but ultimately it's the closure of the myelomeningocele that's important.
Well, I'm asking this because I have seen some patients who we operate for meningocele, and they suddenly die, and there is no complication at all. They suddenly die. What I feel is that with the patients with who are having tonsillar descent, and if we do the myelomeningocele, the sudden loss of CSF pressure, they further cause the tonsillar descent, and they may cause the cardiorespiratory arrest.
Yeah, I'm not certain the reason of why that would happen in your experience in that patient, but typically the standard of care is treating the myelomeningocele and then giving that time to see with the KRA2 malformation. It's also difficult to do that surgery in a very young age as well, and it's higher morbidity related to that as well.
Okay, thank you.
For patients with what is your treatment plan for patients in who presents in after 18 years or 20 years, and they present only with backpack with intact neurology? So do you operate these adult Tether syndrome patients?
Yeah, so that's a great question. It's also something that as pediatric neurosurgeons, we deal with too, this transitional time for adults. And there are cases where we do that, particularly if there's conservative measures that, haven't helped. Or two, doing urodynamic studies is also helpful because it's an objective measure to see if there is any abnormalities within the urodynamic studies. And if that is, then that's objective evidence to do surgery as well.
Okay,
Yes.
we are moving on the next.
Thank you.
next
One
section.
important question, please. Hassan. Sir, just one question. You mentioned that you have abandoned the simultaneous closure of myelomeningocele and putting a shunt patient having hydrocephalus.
That's correct. At the same time, yes. We usually don't do that at the same time unless there's significant hydrocephalus, with a large head circumference, splaying of the sutures, things like that. But we don't necessarily put a shunt in at the same time as closure of the myelomeningocele.
It will not be better that in a same anesthesia, and it will decrease the further.
I mean, I think that there might be an argument for that, but not all patients may need a shunt, and so we're finding that out more now with observing and following these children. But that's not to say that a shunt shouldn't be placed if it's clinically indicated.
Okay, now we move on to the skull-based session.
So for the skull-based session, I would like to invite Professor Rashid Jumma and Professor Naeemur Rahman to please come on the stage to moderate the session.
ऑर्डर पता है क्या है, नेम तुझे पता है? यहाँ पे क्या हो रहा है?
thing. So welcome to the final session of the day. With me is Dr. Naeem Rahman from Faisalabad, and I'm Rashid Juma from Karachi. And we're changing the order slightly. So we're going to let Dr. Inam work in tandem. So he's going to do his two presentations together. So Athar, welcome. And your first presentation, please.
Everyone, Hassan, I didn't see you when I entered. So, I was like blindsided. So, Assalamu alaikum. Thank you very much, Salman, and all the wonderful neurosurgeons that you have collected over here. Thank you, Naeem. Thank you, Dr. Jama. I wasn't sure what is the format. So I just put some cases together because I think we learn a lot from just looking at the cases. So, and thank you for allowing me to put these two talks together. We have a meeting of the annual neuroscience conference. That is also running in parallel. So for you guys to know, there's a Society of Neuroscience, which is Pakistan Society of Basic and Applied Neuroscience. And we have been doing annual neuroscience conferences for the last 10 years now. Now it's 9 years. And it's a basic neuroscience, but there's applied stuff in there also. So if you're interested, join it. This year, it's going to be University of Karachi. Next year is going to be in Lahore. And, that's where the real neuroscience stuff is. Clinical neurosurgery is okay. It's not neuroscience, okay? But that's okay. I think most of the guys don't understand that, right? All right. So I will start with the glioma thing. So let's see. How many are residents here? So, okay. And any medical students? Oh, good. Okay. Excellent. So let me put this case up. Fatma, thank you for putting it together for me, right? All right. So here we go. Starting with, okay, all right. So it's a 54-year-old gentleman, KPS 90. And it's a known case of right frontal oligodendroglioma since 2012. Had a resection done in 2012, was doing well. And then that was in surgery in 2012. And at that time, the new classification hadn't come in. So we had called it oligodendroglioma 2 with 1p19q code deleted. So if you look at it, this is I thought that this would be a smaller room, so I was planning to ask questions from the residents. But if the residents are, if they feel like, it will be wonderful if they can respond to the answers. So where is the location of this tumor? Can anybody tell me? Kahan par hai isme tumor in the T1 mirror image? Can you localize it with respect to the motor cortex on this thing? So remember, we have all these wonderful neurosurgeons coming from North America and South Africa and other places, and these guys are belonging to HIC. We are talking about LMIC, and so not everyone in Pakistan will have functional MRI. So yes, we will have MRI, and based on that you can figure it out. So where is it located? Any idea? Okay. Yes. Okay. So if you look at it, it's hard to say, but this is over here, and this is superior frontal sulcus, and this looks like the omega sign over here. So this I'm assuming is the pre-central sulcus, and this is the central sulcus, right? So if anything, it's really in the premotor area. So this is the motor cortex. Probably that looks like. We don't have the superior central sulcus very clear over here. All right. Over here, it becomes a little more obvious because the central sulcus is going to go like this. And this looks like in the premotor area. So here a resection done of this tumor without deficits and did well. This is since 2012. So it's about 11 years, did quite well. But then notice, what we want to notice are these hyperintense changes in T2, and then if you can see them on FLAIR. So that's what one needs to follow, these things. Because you might have removed the one with the contrast, but contrastectomy is not the goal. And as we followed it up, we realized that actually there's some growth in the flare, which is in 2014, and kept on increasing until 2022 October. And we see a much more flare signals over here. The resection was over here. So it's encroaching onto the motor cortex. See that one? See, this is a very good omega sign over here, right? So this is getting into the motor cortex. So we planned to do it with the awake craniotomy. And unfortunately, we could not do a whole lot because everywhere that we tried approaching it, he would start to get some deficits. So we ended up getting just a biopsy out of it and not really resect much more than that. We did have a DTI as well, but then that wouldn't have helped a whole lot because just going through the cortex was a problem. Most of it was covering the motor area. So now what we have over here, I don't know if you guys can see it. This is a typical pathology. So I think the neurosurgeons in training should know how to read the histopathology slides also. That's a classical way of neurosurgeons a few decades ago. And I'm sure Dr. Juma would probably used to take his own samples to the pathology lab and sit there with the pathologist and look at it and then come back to the OR. So if you look at these cells over here, this is Friedegg appearance, clear cytoplasm with the cell in the center. Now the chicken wire appearance, that's a lot of stretch of imagination. And I've talked to a lot of pathologists, you really don't see chicken wire appearance, but then just say yes to them, yes, it's chicken wire appearance. But the chicken wire appearance is like you see some vessels that are crossing over, but never typical. Okay, but what's more important is over here. So you see that GFAP is positive in this one. This DAB, diaminobenzidine staining. IDH1 is positive. Now this IDH1, when you say IDH1, you're talking about the mutant. And there are two ways of doing the IDH. One is the mutant way, one is the immunohistochemistry. And if you're not sure, then you go to the PCR, you do the molecular analysis. So this is IDH1 positive. And then you have OLIG2 positive here. You have ATRX positive here. And the Ki67 is pretty low. It's difficult to see over there, but it's pretty low, just few dots here and there. So this is a typical picture of oligodendroglioma 2. There is not much of malignant cells looking in histopathology. GFAP is positive, IDH1 mutant is positive, and the OLIG2 is positive, and ATRX is retained. So if you have that combination, that's oligodendroglioma 2 because the Ki67 is low. If the Ki67 was high, then we would be moving towards the oligodendroglioma 3. And there's no oligodendroglioma 4 now, and there's no oligodendroglioma 1 according to the new classification. Okay, so basically this is what we had on this gentleman, and so that was one case, right? Okay, so all right, then I will show you another case, which is a problem that we face in Pakistan very frequently. And that is this thing, that this gentleman, 29 years old, he presented with absence seizure for 1 year. And in April 2022, it was found to have some cystic lesion with minimal contrast enhancement. Look what happens. Upfront radiation, gamma knife, 15 gray at 50%. This is nonsense. I've been trying to say this for the last 20 years, and this still goes on. It's just very disappointing, very depressing that kuch log seekh hi nahi sakte hain cheez. They need to go back to medical school and redo the medicine and redo the neurosurgery before they understand these things. You don't submit a lesion, except for very few, just for example, acoustic neuroma, schwannoma, those are typically looking. You don't submit a lesion to gamma knife or to radiosurgery unless there is some medical reason that the person is so sick, can't have a biopsy. So this person ends up with that. And, and I'm not against gamma knife. Gamma knife is perfectly fine. Gamma knife is actually more accurate than cyber knife. It's the ethics of the people who are doing those things. That's what bothers me the most. Gamma knife is more accurate than cyber knife, but clinically the outcome is same whether you apply gamma knife or cyber knife. Right. So you notice this lesion over here, and so what are you going to do about it? This is in the left temporal lobe. He's having seizures. Got a gamma knife done, having more seizures now. This growing. So I think you're pretty shy to answer. Nobody is willing to put your hand up. I mean, it's very simple. वहां से कोई anybody from there? AQ resident? Ahmed? Is that Ahmed? Yes, Ahmed. हाँ. क्या करेंगे इसका? I mean, it has had radiosurgery, but it's growing in size. So you are going to remove it, right? And once you remove it, are you going to think about selective amygdalohypocampectomy or not? So that's the question, because it's right infiltrating the hippocampus, right? So that's something that you want to think. And typically we go around and ask our neurology colleagues and get some answer from them. But then eventual decision has to be in your hands, whether you are going to remove the tumor only or go with the selective amygdalohypocampectomy as well. So in this case, and then we don't have a whole lot of tests to figure out whether this lesion, which is on the left side, is going to leave a deficit or not. So I think it's best to do it awake craniotomy, stimulate the hippocampus, look for the deficits, look at the language and other cognitive things. So in this case, we decided to go for, so you see this flare image, how infiltrative it is over here. So we decided to go for selective amygdalohypocampectomy along with removal of the lesion. And where is it? Okay. And it was showing contrast enhancement also after all the gamma knife or the radiosurgery done. Okay. So that resection done, and this is what we get. So this was a frozen tissue. Forget that. Look at this. There are a lot of cells, a lot of amyloid material, multinucleate cells over there, right? And Ki67 is almost very low. This is the main tumor bulk. But look at this, there is some amyloid material here. And you see these things? Isko naam bata sakte hai kya cheez hai? This pinkish thing that you would see in these kind of tumors, that pinkish rods, pinkish. Anybody? Yeah, chairman, obviously, sir. Sir, thank you. I mean, you should have yeah, you guys know about it, right? Don't you? तो बोलो ना आगे से. Acha. So this is the Rosenthal fibers, right? Now this is not a very classic presentation. You have to look for it. This is from Wikipedia, and the classic presentation is the big Rosenthal fibers flowing in there, and anybody from 2 miles can say this is polycystic astrocytoma, right? So some multinucleate giant cells and things like that occur in the polycystic astrocytoma that we see over here. Over here, see this, and then we found that in the hippocampal area, there was infiltration. So we did the right thing of doing selective amygdalohypocampectomy, right? The Ki67 is, a little bit high over here. And now, so polycystic astrocytoma should never get radiation. The only treatment for polycystic astrocytoma is surgical resection, no chemotherapy. This gentleman received radiosurgery. So what do I say? After, in the first 20 years, first 5 years, I was like, what's happening? Next 5 years, I was upset and angry. The next 5 years, I just kept quiet. And now I'm very upset. It is unethical for those people who are giving radiosurgery to these patients, and it's unethical for the neurosurgeons who are sending patients for this purpose. Those neurosurgeons also need to go back to the medical school and do the residency again. Just getting very upset. Okay. Hassan, that's fine. That's, after 20 years in Pakistan, you get so upset, right? You are like, all right. So next is, let's see. Let's do this simple case over here. Okay. So 52-year-old, I should have removed these things. I forgot that. My residents did not help me with that. The identifier should have been removed. So 52-year-old lady with KPS 50, left frontal lesion, and neuronavigation carried left frontal craniotomy, maximum safe resection. So the reason I'm showing it because I want to eventually bring you to the histopathology. So this is the lesion over here, it's right near the motor cortex, not so high up, but it's difficult to see over here. But then awake craniotomy is the right thing for it. And in this case, with the awake, so yeah, you see this enhancement over here. So, when you have this kind of enhancement, it's not really anything but GBM and maybe grade 4 astrocytoma. We did surgery on her. There's minimal residual left on the Sylvian fissure because it was stuck to the vessels, and don't mess with that. You're not going to change a whole lot of outcome of the patient by removing that little thing. I mean, it works very well if you have a very good team. And if you are working with the Mitch Berger's group in UCSF, it works fine. But don't mess with the Sylvian fissure with vessels in there by trying to remove that small piece and thinking that I saw that graph that if you remove from 97 to 99% of tumor, the prognosis improves. Here, I have done this mistake, bagging up the vessel in the Sylvian fissure and giving a stroke. So it's best to be on the safe side. And the reason I'm trying to tell you guys about these things is because I think what we need to train the residents is not to be the best neurosurgeon in certain area, but first of all, let's try to train a standard, raise the standard up and try to bring things into normal range. We are very far from the normal range at this point. So anyway, so this is, pleomorphic cells over here and a lot of highlight material, and IDH is positive or negative? Anybody, come on. Negative, right? So if IDH is negative, and cells look very pleomorphic, it is, according to new classification, is GBM, right? If IDH was positive, then you would have a problem, then you would say that it's probably astrocytoma grade 4 with so much pleomorphism and all that. So remember that part. There are certain non-canonical astrocytoma grade 4, which would be IDH negative, but still, with other features that suggest it's astrocytoma grade 4. By the way, GBM grade 4 nahi kehlata hai. It's just GBM is GBM, right? Okay, so we're done with this one. How much? 15 minutes are over? Okay, all right. So then let's see GBM progression. Well, I mean, I wanted to show the multifocal also. Here, let's do this one. I just all right. So this is a 68-year-old female, right? Okay, let me go to this. Now, what do you say about this lesion? What does it look like? Any idea? Fatma, you guys can't say because we just discussed this case this morning, right? Right. So yes. So it's a contrast enhancing lesion. There's not much necrosis you see in there, but then what you see is that it's in different locations. So you call it's either multicentric or multifocal, pro high grade, right? And how do you differentiate between multicentric and multifocal? Look at the FLAIR images. Now the FLAIR images suggest that it's all connected together. If it's all connected together, then it's not multicentric, it's multifocal. I don't know how the multicentric multifocal is going to pan out with the new classification of that has come at new brain tumor classification. However, now looking at it, the dilemma that starts to appear over here, it looks like malignant. It does have this fried egg appearance, little bit of chicken wire in here. This is the chicken wire thing, right? And then there are these lot of mitosis, right? And then GFAP is positive, IDH is negative. OLIC2 is positive, ATRX is retained. Ki67 is very high. So we really don't know you can't fit nahi ho raha hai. So a lot of these ones are classified as not specified, but most probably with the ATRX retained, most probably one can do a molecular analysis of the IDH. Most probably is going to be high grade 3 oligodendroglioma, because if you look at the histopathology, that looks like that, right? And then if you look at the italics retention, OLIG2 positive, it's just the IDH is negative, which goes with the oligodendroglioma. So most probably it's going to be that. Acha. So that was just to give you some idea. So one has to think about whenever you're going after a glioma surgery, obviously you guys all know about it. Location wise, you decide the incision, whether you decide for awake craniotomy, it depends on where it is located. If it's near the eloquent area, then it's always best for that. So talking about awake craniotomy, so awake craniotomy can be used not only for glioma, but for other purposes. So here is a case of awake craniotomy in epilepsy surgery. And I think this was one case which I think was quite interesting. 19-year-old gentleman with generalized tonic-clonic seizures since the age 5, getting followed MRI, and this lesion was just not growing, but the seizures were getting out of hand, and multiple medical management was not helping, right? So the diagnosis was it may be low-grade glioma, but it's possible that it's maybe a just simply dysplastic tissue, right? And what we did was we did it with so we don't have those large grids that we use in because it's very expensive. Even this strip, Dr. Juma uses that also, and I don't know if I use the same strip that Dr. Juma you used. We sterilized it, but this is like 50,000 rupees. So the interesting thing was that although the lesion was localizing into this part, but then if you look over here in this picture, the epileptic foci were coming in from this part also. So this black thread, we laid it down, and at the same time the patient was awake, so we were checking for his neurological status as well. So there were foci from here, although the lesion was localizing in here based on the MRI resection done. And then what you see is these, spikes that you were seeing. This is just an artifact. These spikes that you were seeing over here, they disappeared. And on the repeat MRI, we went beyond what we would have done, if the patient was not awake and if we were not monitoring it. So the benefit of awake craniotomy, one has to remember that in epilepsy surgery, whether just like I mentioned about that gentleman with the hippocampus and something like this, you need to do them awake. Now, when you are going into deep part and opening up the ventricle, the problem is it happens more than not that they start to have a lot of nausea and vomiting. So try to avoid blood getting into the CSF. And if you can prevent that, then it works fine. For lateral ventricles, it becomes very difficult to avoid blood getting in there, but for temporal horn, it works out okay. So this resection, if you notice over here, this resection goes beyond, and the neurologist, epileptologist was there with us. And if I had done only the based on the MRI, we would have done this part, but sorry. Yeah. Laser pointer. Okay. If I had done with the based on general anesthesia, I would have removed this part, but this part was removed based on whatever finding we had with electrocardiography intraoperatively. Okay. So then the other area that I find awake craniotomy as very helpful is AVM and AVM. Oh, there we go. Okay. All right. Here we go. All right. So in this case, okay. All right. So here is a 22-year-old, what was 22-year-old female who had a right side hemiparesis, and so we have this lesion. And I don't know if it's really worth asking because aap log chup rahenge, jawab nahi denge. So you see that the male supply is by the ACA, right, over here. And there's a main branch coming up to it, but then there's a small branch, and it's really hard to say whether it's coming from the in a pericallosal part or not. but that's supplying it from behind. That's the main one. This is what the MRI was with the after the hematoma, which was removed. But then look at it. So this is the superior central sulcus, right? And what touches that is usually precentral sulcus. And so if we say this is precentral, then this is central sulcus. So here things are distorted. So you look on the opposite side, and based on that, it looks like it's right below the motor cortex, right? And then, oh, there you go, omega sign, right? Anna? So precentral, central, postcentral, right? And it's right underneath that. Okay, so this is intraoperatively, and once we open it up, we're right smack on the motor cortex, and this is the draining vein. If you notice, this is reddish, this is dark, but then you see pulses of red blood coming, oxygenated blood coming in, suggesting that this is draining the so if you notice, this is that vein over there. Okay, all right. So we looked at it, and it was right motor cortex, because every time I would stimulate it, hands would start to move from this part over here in the lower part. A second, laser pointer. Okay, from this part, the hand would start to move, and then legs would start to shake. So couldn't do it. Now there was but the AVM was right below it. And the only way that we could do it, you see this reddish blood coming in there? So it's partially draining the AVM. So this was the only place that we could go in through here and, approach it with an angle. So removing the arachnoid and, slowly dissecting out the tissue over there. And, the first thing that I want to do, I did not use embolization. Waste of money in this case. So you look for that feeder, main feeder, right? So it's right there. You can start to see this ACA right over there, that pinkish thing over here, right? This thing over here. So once you have isolated that, now then the benefit is that you can put a clip on it, because the patient is awake and you want to see if that is giving a branch distal to that, to any motor cortex, because right at the motor cortex, right? So we did that. We waited for 5 minutes. Notice no deficit. So that's good enough for us. So we removed the clip, and then we just basically took it with. And then whenever you cut the main arteries in AVM, always cut them in steps. Don't cut them. Do like 2 or 3 steps, because sometimes they have not been coagulated and they can retract, and then you're in trouble. So now the AVM is showing up. See this over here? AVM is showing up. We resect it. And while we are doing it, we are monitoring the patient. The problem is that we had to dive in back to the area right underneath the motor cortex to get to the posterior part. Now that started to give her some deficit. So, dorsiflexion went weak. She had lost her dorsiflexion when she hemorrhaged, and then this was, when we were doing it, she was losing her dorsiflexion. But then you can't leave the AVM partially done at this point. And typically, if you are careful, and if you're just right at the margin of the AVM, which we did, they recover, and she's actually recovering from her weakness. Rest of the thing, everything was perfectly fine in her, and we were able to save the motor cortex right on top of it, which is right behind that main draining vein over here, right? We were able to save it, and all the tracks were basically going around the AVM, and one can. And then obviously when you're done with it, you want to make sure that you have taken care of all these small bleeding vessels here and there, and the vein was still fine. So although it looks like that, why did I do a big craniotomy? AVM always do a big craniotomy. We were able to remove this AVM with a 1.5 centimeter corticectomy, but we were sort of forced to do that because there was no other space. We couldn't go from here. But let's say if it was in the anterior frontal, then I would have मजे से मैं ये भी निकालता और उसके बाद leave the draining vein. So in this case, we were restricted to this very small corticectomy to remove it, and then this is what we see post. So that's a standard also. Whenever you remove an AVM, always get a DSA, because getting a CTA will not do it. You have to look for the early draining vein, and CTA will not show you the draining vein. So always get that. Another case of AVM awake, right smack at the speech center, which you see. Okay. Yeah. So which you see that it's fed by the through the vertebral circulation, but this is not a vertebral artery that's supplying it. It's basically the PCA, going from vertebral to basilar to P1 to PCOM, and then to the posterior cerebral branches, right? And that's what we see over here, injection of the ICA, right? So both vertebral injection and the IC injection look the same, right? Achha. So in this case, again, we removed it, and usually I remove AVM this fast. I don't know, you guys can't do it probably, right? Remove it this fast. I'm very good. Once it's removed, then what we had, I was just joking. I don't know if somebody took it seriously. So now we have this major vein with a small artery next to it. And, I was afraid whether it's going to cause a deficit, because right in the speech area, even the venous hypertension can cause problems. So we clipped it and then waited for it. And then, baatein karte rahe hum mareez ke saath, and she did fine. And then after that, we were able to remove this last part of the that AVM, and then she did fine. And then obviously you always get a post-op angio, no early draining vein, and AVM is gone. So I'm done with I'm not going to show anymore. I think talking about the glioma is not going to be an easy thing, because there's so many things have changed over time. Try to get involved, try to discuss the neuropathology, because I think over time things are going to change. Now we are moving towards the methylation. So metallomics of the glioma are going to become important beyond the IDH and ATRX and all that. So stay abreast with that. And for awake craniotomy, think about all these things that you can do with awake craniotomy. Thank you very much. I hope I stayed in time. Right? Thank you.
Thank you, Dr. Athar. So we do have time for any questions that you may wish to ask related to the two presentations. And if Dr. Sardar can, in the meantime, come up and hook up his laptop. So any questions related to the glioma talk and the AVM talk? Well, no, the awake craniotomy, but it turned out to be an AVM talk.
Well, awake craniotomy for AVM and epilepsy surgery. All right, thank you.
Dr. Sardar, welcome. Sorry to keep you waiting, sir.
Thank you.
And so Dr. Sardar from Turkey is going to speak to us about a hybrid approach to glioma surgery.
So this is the two consecutive talk about the glioma surgery.
They want to make a second event for completing.
Okay.
Up till now, they are finding somebody.
So I'm going to talk about the hybrid approach for the glioma surgery. So first of all, what is the mean of the hybrid? Hybrid means that the composite of different elements, sources approach, which is bringing us of mixed character, and that means the better than individual things come along through the hybrid terms, to the hybrid surgery. So it means the reproductive cross between the technological devices in the operating room, conjoined imaging and diagnostic technology during the surgery, integrated video display, patient information via IT digital systems, and also multidisciplinary collaboration with the all disciplines. So hybrid surgery in glide terms means the maximal safe resections, particularly the young surgeons. The glioma surgery is consists of the maximal safe resections. That means this is at the end of the day, this is the Malin disease. So we are not mainly responsible for the this kind of patients. The medical oncologist is the owner of this oncological patients. So we have to careful about the maximal safe resection in glioma surgery. So that means we should do the minimize craniotomy and minimize the iatrogenic cerebral injury, minimize the morbidity, minimize complication, maximize Karnofsky score, and also minimize the residual tumors. So that means they provide the convenience for adjuvant therapies for the medical oncologist, also radiation oncologist. What are the advantages of the hybrid surgery, which is including the improved patient outcome with the more convincing surgeon and team, short anesthesia and surgical time, low complication rates, short hospitalization, and also minimize approach-related injuries, stereotactic craniotomy and percutaneous intervention also, and also the radiation safety and overall lower cost of care. So hybrid neurological operating room consists of some radiological tools, which is including the open MRI, ORM CT, neuronavigation, stereotactic systems, and also the other radiological investigations co-registered with the MR images. You can have a carbon fiber radiolucent operating table, optical filters for microscope with the fluorescein or IC in the cyanide. And also you can have a neuroendoscopic assisted approach for the hidden zones with the microscope. And the mandatory, you should have a frozen pathology during when you are dealing with the glioma surgery. And also nowadays we are routinely use the intraoperative multimodal neuromonitorization. So ORM CT brings us the frameless stereotaxy and real-time imaging update for the neuronavigation, and also we can use in the spine. Neuronavigations brings us the frameless stereotactic biopsy, and we can do the stereotactic craniotomy, stereotactic transcortical incisions, and simple cortical mapping with the MR tractography merging with the neuronavigation. So this is the navigations. You can easily determine your tumor sites, and also you can determine your craniotomy sites with using the neuronavigation, frameless neuronavigation. So, and also the other advantage of the frameless stereotaxy is we can do the stereotactic biopsy in suspected radiology over the 70H low Karnofsky score patients, multicentric locations, and deep and eloquent areas. How we decide about these indications, I will tell you later. And this is the case example, 57 years of female patients. The patients had only the headache and weakness. The PET-CT, she hadn't any primary lesions. MRI, suspicious multicentric brain lesions, metastatic or glial tumors. So we do the stereotactic biopsy with the decision of the tumor board. So this is the sample confirmed by the administering fluorescein sodium with the operating microscope. This is routinely, we are using the fluorescent sodium with the fluorescent microscope when we are taking the stereotactic biopsy, and then in the operating theater, we confirm our biopsy with the fluorescent microscope. You see, this is the normal appearance of the stereotactic biopsy material, and this is the fluorescent uptake of the material. And also you can see the very clear yellowish color in here. So the pathological results, glioblastoma. The other hybrid tool is the multimodal neuromonitorizations, which is required a strict collaboration with the anesthesiology, because you have to save the amplitudes with using the IV anesthesia. You have to have the consultant neurologist, and you have to know false positive and false negative values. So this is the neuromonitorization. I'm passing this video. So another important tool in the hybrid operating filtered operating theater is the fluorescent microscope. So it's very useful to differentiate the tumoral tissues and real-time fluorescent. You can do the real-time fluorescent cerebral angiography with using the fluorescent microscope. This is the case example. I think that the video, yes. Now video is working. So we do we use the navigation again at the beginning of the process. And this is the fluorescent microscope view. You see, we are taking a biopsy sample for the frozen pathology first, and then we are going to complete the resection of the tumors. And you see very clearly yellowish, colorful tumoral tissue in there. And you see this is now the normal microscopic view. We are coagulating some supplement vessel and here. And then we are removing the tumors, and at the final state of the operations, we again check the tumoral area for any residual perilesional tumoral tissue. You see, this is the normal tissue. This is the perilesional tumoral tissue, and the fluorescent microscope is very useful to check your final step of the operation. So if you look at the literature, you see we can reach the almost 100 resection percentage of the tumor resection in high-grade gliomas with using the neuronavigation and also the fluorescent microscopes. And also it brings us the very cost effectiveness in terms of the maximal safe resection of the gliomas. So another important part of the tumor surgery is the multidisciplinary team meeting. You can learn so many things from the other disciplines. So it's mandatory nowadays. So neuro-oncological boards is working with the OECI, ASCO, and NCCN guidelines, and you should have evidence-based decision making within the multidisciplinary team meetings, and every kind of decisions can be made in this kind of meetings. And then we have a molecular neuropathology. And nowadays, the molecular pathology and also the genetic pathways of the tumors is very important part of the oncological treatments. You have to know that this new classification of the gliomas. Now we know that the glioblastoma, if the patients had the IDH white cells, this is the glioblastoma. If the patients don't have not the IDH wild types, and then we put into the astrocytoma group. And you see the microvascular proliferation, necrosis, TERT mutations, endothelial growth factor, gain amplifications, or 7 chromosome or 10 chromosome amplifications or loss of the chromosomes provides us the genetic diagnosis of the glioblastoma. The other ones is the astrocytoma and also the oligodendroglioma. So everything is going through the genetic pathways and also genetic molecular pathology nowadays. So the other problem is that the follow-up of the glioma surgery. This is the 60 years old male patients. You see the glioma in here. This is the confirmed pathology. So we are resected the glioma with the same operating conditions, under the same operating conditions, with using the neuronavigation, neuromonitorization, and hybrid hybrid operating theater with the fluorescent microscope. You see, we are going through the fluorescent microscope and passing the video. This is the normal view. And this is the postoperative image of the patients. This is a standard way to follow the glioma patients. Within 24 hours, we had a postoperative MR images to complete to assess the patient's resection types. And then we discussed the patient's situation in the neuro-oncological tumor boards. This is the wild type glioblastoma. So this is the postoperative 4 months. And this is the postoperative 14 months. And now you see some contrast enhancement around the tumor locations, but our neuroradiologists suggest that this is the pseudo tumor progression, pseudo response of the treatments. So that's why he suggests the perfusion MRI, and the perfusion MRI, you see the hypoperfusion around the tumors. So that means we don't have any recurrence in here. So that means we do not consider again the second surgery. So we are assessing the glioma with the Reno criteria. That means first of all, the tumor size, progression, steroid need of the patients, clinical presentation of the patients, and we have to assess the progression of the patients. Usually we see in early periods in MGMT positive patients, and also we see the radiation necrosis at delayed period, and we can see the pseudo response, and we have to assess all of these parameters with the advanced imaging, which is including the perfusion MRI, diffusion MRI, spectroscopy, TRAM, and PET-CT. TRAM is relatively new techniques, merging the MRI and the metabolic activities of the brains. The red means the necrosis, you see, then blue is the tumor. This is the NCCN guidelines for the low and the high-grade gliomas. Of course, with the tumor board decisions, we can operate the patients again, second surgery, also third surgery. And the other game changer is the stereotactic radiosurgery. It's a outpatient procedure, treatment time within 3-15 minutes. It can be performed with the hypofractionated fashions. There is no sedation, no restriction for the daily life activities. On the other hand, we know the SRS plus temozolomide can cause a high risk of severe myelotoxicity, and also sometimes the radionecrosis with the immunotherapy can cause some severe toxicity. So as a summary, the glioma cases, it requires a multidisciplinary hybrid approach is essential in glioma cases within support of the neuroradiology and molecular pathology. Treatment and follow-up approach depends on your tumor board decisions. You can do the stereotactic biopsy. Usually we are preferring the maximal safe resection for this kind of patients. You can use the hybrid surgery with the ionome, neuronavigation, fluorescent microscope, and frozen pathology, and then we can perform the radio and chemotherapy, and also targeted therapies in the second line for the glioma patients. And the last part of the glioma treatments is the stereotactic radiosurgery in small recurrent cases. Thank you very much for your attention.
I think very high-tech job. How many centers do you have in Turkey, with such facilities?
So, sorry for that.
How many centers do you have in Turkey with such facilities?
I think 5 or 6 centers.
Very good. Very high-tech job.
But yes, if you have a hybrid operating theater, you should have a very special person to implement all of devices, yes, together.
Yes. Any questions? Any comments? No, I will invite Professor Luis Barba for his next talk. Okay, thank you. Skull-based chordomas. Okay, good afternoon. Thank you again for the opportunity to be here. This wonderful country, wonderful people. And I enjoy very much this time here. And let's talk about one tumor that is the example of the skull-based surgery, the skull-based surgeon. Chordoma is inside the bone. Chordoma eats the bone. Chordoma is like this very small animal. You have the tree, You have the table and go and eat inside. When you see it totally destroyed. Sometimes you have very nice table, looks like perfect. At the evening, you see there is something there. When you look, the table is completely dead. This is the chordoma that's going eating the bone slowly and destroying the area. Chordoma is from the midline. The majority is coming in the junction between the sphenoid bone and the occipital bone. In this area here, they can go lateral, can go medially, can go superior, can invade or displace the dura, but the majority of the time go driving through the soft bone, the cancellous bone of the skull base. He can go to the cavernosinus, displacing the cavernosinus, or sometimes invading the cavernosinus, but it's soft tumor. But the way that he goes, he's taken away and go slowly in getting the places. But everything need to have in mind that the tumor has some rules. Okay, the tumor is especially in the bone. It means you did not only remove the soft part, but remove also the bone. The free time recurrence is directly related to the extension of the removal. See, you need to talk with the patient that sometimes you need more than one approach. Have to come from here, sometimes you need to come to the lateral. When you talk to the patient, the same, you need more than one time. The tumor is extradural, come from extradural to intradural. Could use extradural approach more than intradural approach. The chordoma is different than chondrosarcoma. The chondrosarcoma is a little bit more lateral and the behavior is different. The name chondrosarcoma looks ugly, but the chordoma is much worse than the chondrosarcoma. And aggressive removal does not mean morbidity. Aggressive removal means remove the soft tumor, but also the bone. This is the rules you have in the book in chapter 13, the 10 rules of the chordoma that are very, very important. I said some of them already, but the preoperative CT as important as MRI, the cytogenetic study, follow the patient, the intraoperative navigation, a very important thing that can help. Also, the endoscopy is a big point of that. But what's the trick to try to find and to cure a chordoma? Cure of chordoma is a very difficult word to say. But if you have a case like this, a young guy that went to the ENT to correct the septum, have some difficulty in the septum, but found this small tumor here. This is the only chance that you have to cure this patient. Has no symptoms about the chordoma, but it's the only way that you can remove totally the mass and remove the bone around. You cannot wait to do surgery in this kind of tumor, or wait to see if there is symptoms, maybe late. Situation like this one, a small young girl with pain, just pain in the neck, and found this lesion inside C2. You did a biopsy, confirmed to be a chordoma. This patient needs a radical removal. What's radical removal in this situation? You can come transoral, you can remove the mass transoral, you can go posterior and fix in the same act. You go anterior first or go posterior first. I like to go posterior first and anterior later. Do you know why? The tone can give a problem for you. You cannot do like this situation here. It's happened with me. A patient comes overseas. I did the surgery. I removed the maximum I could, but I left this small piece here. And I told the patient, okay, go home and come back in 2-3 months to take this tumor back. He didn't come back. He was asymptomatic. When he came back, there was a very large tumor like that. I lost the opportunity to save this guy. What I should say, I remove this part. Okay, go 1-2 weeks, come back, let's do middle fossa here or try to remove this part of the petrous apex. tell this is for the patient would be the best chance, not send back and wait for recurrence. It's very important, like you do with termita, that the insect that eating bone. If you want to save the table, you need to clean, and after you put something. In Brazil, you call gimo. See, you have to. This is the radiation therapy. You not cure chordoma with surgery. We need to do the radiation therapy as a complementary. So it's not just adjuvant; it's a complementary treatment. The complementary treatment have two options: the proton and the photon. The best one is the proton. You know, the chordoma needs very high doses of radiation. And the proton do like that. You call Bragg peak, very high doses and come down. With photon, you have like this. See, the periphery will be completely different because this is important, this proton and photon. What's the problem? It's very difficult to get. I don't know if you have in Pakistan. I don't know if you have in the area here. It's very expensive machine, more than $20 million. See, this situation is difficult to get the best treatment. But if you don't have proton, you can do photon with a very nice way to reconstruct. You show that when you do surgeries alone, when you do biopsy, when you do surgery plus radiation therapy, there is completely different the results. But one thing that is very important in the chordoma, this tumor change his cytogenetic behavior. The recurrence tumor is much more aggressive than the first time. If you do surgery, there is a small piece of tumor, you give radiation, in the recurrence, is more aggressive. If you don't give radiation, in recurrence is more aggressive. I don't know why. There is some change in cytogenetic. Because this is the first time, is very important. The first time to be the maximal treatment. Chordoma can seed is a case that several cases described in the literature that there is chordoma in the teeth, chordoma in the nose, secondary to the approach. Because they treat as a malignant tumor and you need to treat like that. You know, skull-based surgery, skull-based surgeons, they like to do to develop a new approach. Everyone cut one small piece of bone and see, trans something. You see, now you have transoral, transmaxillary, trans something. And the skull-based surgery is different than the skull-based surgeon. Skull-based surgery, we need to know every kind of approach. I'm seeing today a lot of people say that I have skull-based center. What approach you do? Transnasal for pituitary. It's not skull-based surgery. It's like spine center that you do just lumbar disc, not spine center. Well, lumbar disc surgeon is completely different. In the skull-based surgeon for chordoma, you need to know every kind of approach. Because sometimes you need for the nose, sometimes you need for cranioorbital, sometimes you need anterior petrosal, posterior petrosal. Every situation is different. Because this you need to train in every kind of approach. Navigation is very important, you know, it's a fixed disease. Not like glioma that you take CSF leak and you lost totally your orientation. In the chordoma, it's totally fixed. See, the navigation is very important. But also is important to have what you call 3D view, to know what's coming behind. To have a tumor, and there is normal structure in the back, you need to know where you are. It is extremely important. And today you can do a real-time navigation. When you put the navigation in the drill or in the dissector, you have a real-time navigation because it's a fixed disease. Intraoperative CT is good, it's not a reality to every place in the world, but it can help you, just not only to put the screw, but also to do the resection. The endoscope changed the history of the chordoma. Why? You can see areas that you never imagined you couldn't see. For this small hole, you can go inside, you see if there is tumor intradural, you can follow the tumor intradural, you can see bilateral the ICA, you have all spectrum, all view, just the endoscope gives to you Sometimes a very simple procedure you can do without any fancy technology. You can do a very simple transoral approach, yet you need a microscope, maybe a CR. You can get the instruments that the ENT has. Just open the mouth and go there and take the tumor. What's the trick to do the transoral approach? Don't lose the midline. You cannot lose the midline. What's the trick to keep it in the midline without neuronavigation, without any image? That's follow the joint. If you follow bilateral the joint, you know where you are. In skull-based surgery, the tumor deforms the normal anatomy. We need to have some points that are fixed. In this point, you orientate yourself. This is the trick to work in the base of the skull. And you have a case like this, you can clean and dissect like that and fix post-operative in the same act. You do like that. Sometimes you have case like this, and you have the bilateral effect, bilateral, the condyle. We need to do the surgery to remove the tumor and cranial orbit, cranocervical junction fix. Sometimes the tumor go up. I used to do like that in the past. Come transoral, remove the hard palate, you can go to the clivus. Now it is history. Also is history this kind of approach, the maxillotomy. That was very nice approach. The dentist can do, the maxillofacial surgeon do for you. They can do this very, very simple. I did this several cases, but now with advance of the endoscopy, you don't need more this approach, but you can have the view from C2 to the base of the frontal lobe. You can do like that, bilateral, you are not need more that, but you can have exposure as wide as you can. The majority of the tumor is limited to the midline. When you go to chordoma, you never know if there is a small piece intradural. And the skull-based surgery, before open, you need to be prepared to close. It's very, very important. See, for this is important, the flap. In the cranium, you have the pericranial flap. Here you have the septal flap. It's vascularized flap that will close the base of the skull. From up or from down, you can close the base of the skull. You can do a very simple procedure also, the transcolumellar approach, just open a little bit here, you have the same view with the microscope or with the endoscope. Of course, with endoscope you have wider view and you can work and see much better. You have a case like this, you just follow the anatomy here, you open the sphenoid sinus, you go direct to the tumor, you can get the same situation. See, what is the incision here? This is the transcolumellar approach. You cannot see anything. You can go directly to the tumor. You can have a case that's go lateral here, extend to the posterior part of the cavernous sinus. Just follow the tumor. See, just follow the money. If you want to catch somebody, just follow the money. You catch him. The same thing happens if the tumor. You see, the tumor is here. You just follow the tumor. You can get the tumor direction. But same situation, smaller and larger and larger and larger. In another situation, tumor is getting bigger, bigger and bigger. But if you follow it, you can go and he give you the way. Same situation, everyone the same. But the trick of chordoma is not just remove the soft tumor. The trick of chordoma is this. Drill the clivus, drill the normal bone, the pseudo-normal bone. Because if you continue drilling, you find island of tumor separate. This is the trick. You see, now you start to see was normal bone. Now you have bone here. The bone is invaded. In this part, we will make the difference, not just the soft part that you are getting and remove. And at the end, you can go there. Sometimes you need to follow the dura. Sometimes you need a little bit, open the dura in the posterior fossa, in the clivus, expose the area. You can put the endoscope into CT. Oh, I'm just in the half time. Okay. Okay, you have pre and post-op. The limitation, the ICA. I know today the people from the north, they are coming here and arriving here. They go with the endoscope, the lateral go to everywhere. I remember Professor Fish was looking the world through the ear. He was taking nasofibroma, angiofibroma that was coming out from the nose in the 80s, in the 90s. He was coming from the lateral here. Now they are coming from here and reach here. I'm sure that very soon they will take a transnasal approach for convexity meningioma. Maybe they find a nice approach to do that. But it's limited to the midline. Go to the midline. Don't need to go lateral. Why to play with the ICA if the ICA in the middle? If you bleed the ICA, what you do? Cry? You have a lot of technique how to close the ICA? Not. Let's learn how the approach. Skull-based surgeon know how the approach in the skull base. Sometimes you need to go lateral, like this situation can come from the nose. Of course you can come from the nose. You can come here. But for chordoma, you need to remove not this part. You need to remove the bone also. You need to drill the bone. In this way, the best way is coming from the middle fossa. The pit in the middle fossa, the petrous apex here, you can get as the same situation to do from the nose, you do from the face, from the anterior and from the lateral. Here you use the fascia of the temporalis muscle. See, you have that. At the end, it's rotate and close the cavity. Same situation, large tumor like that, you remove and put fat. You had a chordoma, now you have a big lipoma. There you have a big fit of fat. In the end of the surgery, you need like that. There is no more tumor. Here's the cavernous sinus displaced, the petrous apex, here's the posterior fossa, but we need to drill this part and remove the area. And pre and post-op when you rotate totally the temporalis muscle. Sometimes the tumor is in the condyle. The majority of the time, the condyle is recurrence. It's not originally, it's tumor recurrence in the condyle, or you need to do that. You can come, you can go lateral, you can open the condyle, you can drill the condyle. This case was recurrence. You go as normal, looks like a normal bone, but you decide to find tumor in the neck. Inside is that. And you go and take and remove it. The same situation like that, just follow the anatomy now from the petrous bone. You're coming from the lateral part. And the pre and post-op, you can get and clean that. When you need fixation, the chordoma is different than meningioma on the other tumor of the area. The chordoma, in great part of the case, you need fixation, but don't do like I did. This is 1996 was the cover of the Journal of Neurosurgery. Okay, Journal of Neurosurgery, American Association, cover. I was very happy. See, 12 case, cranial, rheumatoid arthritis, unilateral fixation was the cover. Was the worst idea. Do you know why? 12 case, 8 came back. Because we are fixing the cranial cervical junction just unilateral, and the other lateral was moving. Fail. 12, 8 came back to fix. If you want to do fixation to the cranial cervical junction, do bilateral, don't do unilateral. See, it was just one side, and the tumor came back. The most important thing. Everything that I said, you can understand about the surgery, the anatomy, the surgical technique, but for disease is not the solution. For solution of the disease is in the research. In the chordoma, we need to study more. Now there is a chordoma foundation that you can get and have more information and more things that you can do to evolve in the treatment. Thank you very much for, sorry for the long time. I passed too much. Thank you.
Any questions?
Thank you.
So, Dr. Benes, can we invite you to the podium, please? And Dr. Benes has a great experience with AVMs, and that's what he's going to talk to us about, offering tips and tricks of the trade.
Feeling that now it works. Good afternoon. Thanks for the invitation. I really enjoyed being here. And since this is an educational course, I will try to show you just the tips and tricks how to resect an AVM. There will be nothing really like statistics, nothing really like results, nothing about the indications, only the surgical problems. If you would like to get all the other information about the AVM, it's in respective chapters of this book, which we have published some 4 or 5 years ago. I have put together 20 points about the AVM treatment, how to behave, what to do. But since we are definitely restricted by the time, only those highlighted in red I shall go through, because I consider these to be the most important ones. So large enough craniotomy, definitely AVM surgery is not for keyhole surgery, well beyond the nidus, because then you get a good orientation and you will have your flexibility. Open dura carefully, that's probably one of the first points which I will show you on video, what may happen. Then dissect the arachnoid. So this is about the opening. You see the dura overlying the nidus, and in very many cases, there are adhesions between the nidus and the dura. Should you reflect the dura, as in tumor surgery, you would tear the nidus, and usually the adhesions are between the vein and the dura. So you would tear the draining vein, and of course the surgery would be much faster, but a little more messy than expected. So this is the first thing, opening the dura. Prepare for everything. This is another case, again, exactly the same. And you see that it's directly overlying one of the main draining veins. So be careful about it. The next point would be, see this left-sided AVM and dissect en passage vessel. That's probably the most important point I would like to make. Treat any vessel in the surrounding of the AVM as en passage and preserve it, and cut it only when you are really sure that it enters the nidus, because there may be really ischemic trouble with the vessel. You would think, all right, this is the feeder, it would fit with the angio, still it may be en passage, so treat it always like that. Very patient coagulation. It was said here always that you should cut the vessel stepwise. Just open the lumen, and if it doesn't bleed, you can go on. If you would cut it, the ends would retract into the tissue and you would just chase it, destroying the brain. So cut it stepwise, be sure that it's coagulated well, that it's closed, and then cut the rest. So let's see it. You see the tiny vessel on the surface of the nidus. Why doesn't it work? It does. So that's an tiny en passage vessel. So you would preserve it because it belongs to the brain, doesn't belong to the AVM. And it exits from quite a large artery, which is at the center of the image, a little to the right. You would think, all right, this is the feeder. Don't close it. It may mimic the feeder. The main feeder may be elsewhere. So just keep it in place until later. This is it. That's the bridge between the two draining veins, and underneath is the artery with that side artery which doesn't belong to the AVM, looks like feeder. Don't occlude it now because it may not be a feeder. Let's go forward. Identify any bleeding point. If there is any bleeding, just deal with it permanently. Otherwise, these points of bleeding do have very strong tendency to multiply, and suddenly you get lost and you are in the field of blood. So go point by point. If there is some bleeding, treat it, occlude it, coagulate it, use the clip, whatever, but don't go forward before you really deal with it. And again, There the position. This is the same AVM. And you see the bleeding from the vein. That is the circumferential vein. This is one of the main draining veins within the nidus. It bleeds rather nicely. I wouldn't tamponate it. I wouldn't do some half measure. I always would occlude it permanently for the time being. And only after that, I will go on. And now we are dissecting underneath the nidus, see the little artery, which is appearing there. We are on the left side. This is the Sylvian fissure where the vein is, and you see the main artery, which was at the beginning mimicking the feeder. It was not a feeder, it was the normal MCA. We are on the left side, so occluding this artery would end up with a big deficit. This is after, you don't need it. Again, once more on passage, I'm really obsessed by that. You see the AVM. You see at the beginning, on the right-hand side, you see the artery entering the nidus. You are tempted to occlude it because it fits with the angio. You think this is the feeder. Don't do it unless you are sure. This is a little later, and there in the middle, underneath the vein, something's appearing, some big major vessel. And this is it. Suddenly there is a main feeder coming from underneath, from below. This is about the coagulation, patient coagulation, and then cutting stepwise. It was already shown and demonstrated earlier. And this is at the end of surgery. You see that the vessel, the artery, which looked like feeder, asking for being occluded, definitely has nothing to do with the AVM. It's all en passage, so do preserve it. Deep feeders, they are the most trouble. I guess either Spetzler or Martin said that at the beginning of AVM surgery, you have the feeling that you are the best neurosurgeon in the world. It's when you are in the sulcal phase, then you get deeper into the white matter and suddenly it becomes a fight and suddenly you think that you should have been doing something else, like dermatology or whatever. So PL epinemal feeding arteries, these are the difficult ones. Do not hesitate to use clips because they are the best to occlude. The coagulation doesn't help. Those are pathological vessels where you have nothing to do, and especially the feeder coming from the vertical. The typical AVM has its top in the ventricle, and that definitely is the feeder, which is impossible to coagulate. Just find it, clip it, and then go ahead. If you would try to coagulate, you will chase it down to the basal ganglia, and you will have a trouble. You see the AVM, you see that it reaches the ventricular side, and the red arrow clearly shows the feeder coming from the ventricle wall. And this is the surgery. You see the ventricle at the top, and the feeder is here. I wouldn't dare to coagulate this vessel. It would be almost impossible. That would rupture and I would get lost. So use the clips to occlude this vessel, cut it in between, and only then go ahead. You know about the ventricle, you know about the feeder. This is one of the last feeders of the AVM. Once you occlude it, you are nearly done. So use 2 clips and then cut it in between. You can go on. This is after surgery. Then this sounds like a logical thing that you would preserve the vein, the draining vein for the last. It's hemangioblastomas, AVMs, whatever you like to preserve the last vein. You see the simple AVM, grade 1. You see that there is one draining vein going posteriorly into the sigmoid sinus. That seems like an easy job. Look what happened. Everything went fine. There was no problem in that. I don't know if it will play. What can I do to make it play? Any idea? All right. Thank you. You see, everything went well. Very straightforward and easy resection. The vein is hidden below the cotonate on the right-hand side. Now comes the only moment when I became lazy. I wanted to have it more comfortable, so I used a retractor. And obviously I tore the only vein which was draining the AVM. It's not a big trouble and big deal to close this way by coagulation, but look what happens. The AVM is bleeding incessantly. The brain prolapses through the opening. So this is really a situation into which you wouldn't like to get, with the logical request to occlude the vein as the last. And here we go after the surgery, and you see that the resection cavity is much larger than needed for such a simple AVM. Fortunately, there was no neurological consequences. So here are again the points I wanted to highlight, some of them. Once again, en passage artery is the important part, and deep feeders is another important part. This is just the surgical group. We do not need to talk about it. We had a morbidity mortality of 2.6, and those were only grade 3 and 4 AVMs. We do not deal with grade 5 at all. And the efficacy was 97. And this is the best thing, how to advise the patients what they should choose. If you let them choose from natural course, the green line, endovascular, which is the blue line. Endovascular as a definite treatment of AVM is useless because you never can beat the natural course. You only bring the complications. Then the radiosurgery, that is violet, it decreases the risk of rupture and risk of deficit by half, which is just fine. And then surgery, which is definitely the most efficient and even the safest, the 7% morbidity mortality at the beginning. But should you choose carefully your AVMs, that the black line, that's our series at the bottom, then you really beat the natural course within 5-10 years. So if you would think about it, if you would be careful with your indications, you may really get a good results. So this is, as I said, I'm not going to talk about the indications, but just shortly, Spelzel-Martin grades 1 and 2 are definitely a surgical entity with no respect to presentation, with no respect to patient age up to 60, 70, with no respect to anything. Just do not use any radiation, do not use any endovascular, just go for straightforward for surgery. Grade 3 are individual, it's a very heterogeneous group, small, deep-seated, large surface, so it's really very individual, and sometimes some combination is needed. The best combination which was not studied was surgery following failed radiosurgery. I had an opportunity to operate on 4 cases after the failed gamma knife treatment, and these 4 surgeries were definitely the easiest AVM surgery I had, because the vessels now are hyperplastic and you can coagulate them. That was really easy. Use monotherapy. We quit using endovascular treatment for brain NVM some 6-7 years ago because there were unnecessary risks. And if you take the risks, you have an AVM, 3 endovascular sessions before surgery, 1 surgery. So it's 4/7 the risks. So you expose the patient to 28% of risk of morbidity mortality, which never ever can be the natural course. It's better to observe than use this. And that's probably everything I wanted to share with you. Thank you for your attention.
If there are any questions, please. Now I will request Professor Rishi Juma for his talk on management of AVMs.
The educational course and inviting me to be part of it. My talk is really not so much how to do it and how I do it. It's much more about the really more important thing in AVM surgery, which is the decision making. And quite frankly, my own sense is that a lot of neurosurgeries in our neurosurgical community tend to shy away from AVM surgery because really of just not having enough time to spend on these difficult cases, but also not really being able to come to grips with making the right decision, because it's not the easiest thing in the world. And I want to start by saying that this is a seminal paper from about 30 years ago. And it makes the point, if you can quickly read the abstract, it makes the point that this is rare, but potentially a very serious and even lethal condition, and that the risk of lethality doesn't go away unless you do something. But it's exactly what to do and when to do that has always been troublesome in that period of time. And that's why the contribution of Professor Spetzler was so important and seminal, because it allowed us to take some simple parameters related to AVMs and then arrive at a recommendation for the patient. And as we all know, they looked at nidus size, they looked at the pattern of venous drainage, and they looked at the eloquence of the area of the brain that the AVM was sited in. And generally, so there is a sixth grade, which is basically death, but their division into 1 to 5 has kind of stood the test of time. And then 1 and 2, the outcomes are very good, quite honestly, whatever you do. 3, we're going to talk about again in a minute, and 4 and 5. And so a kind of, in a sense, they raise red flags against a certain kind of AVM, which really has bad results, however good your surgical services are. But as they look more and more into their experience, this is as Spetzler looked more and more into his experience a few years later, he realized that you can actually, for practical purposes, say AVMs can be treated as A, B, or C. A are the low grades, and those you can offer a treatment to and surgery to with confidence. 3 is a little complex, but 3 is potentially surgical, and class C patients, which is 4 and 5, are not. So this is the scheme that I personally have also used. I mean, without so you using Spetzler-Martin to come at a simple ABC formula, and this was also in the clinic, quite honestly, quite helpful. And I urge my young colleagues to look at this and use this as a simplified version of your decision making. It's the grade 3s that are the problem, because there are subtypes of that size of AVM, which may vary, the location may vary, and sometimes some cases that look like because this cerebellar AVM is close to an eloquent cerebellar nucleus, and therefore it should be in a higher grade. But because of its a very circumscribed nature, single draining vein, feeders that are manageable because they were coming in from the surface, from the outer surface, and not from the front as in inferior cerebellar, for instance, and quite easily done. So this looked like a grade 3 and a grade 3B perhaps, but in fact at surgery was like a grade 2. The other factor that was not taken into Spetzler-Martin's classification was hemorrhage, because there's no doubt that if you have an AVM presenting with hemorrhage, the risks of rehemorrhage rears its ugly head, and you have to constantly worry about that. You certainly have to worry about that in the first 4 or 5 years of after the ictus. But on the other hand, the hematoma does do a certain amount of the parenchymal dissection, and anybody who has experience with AVMs will tell you it's the parenchymal dissection which is the most troublesome, because that's where arteries and veins are exiting the nidus. So in numbers where going around sometimes is very difficult. So this is a hematoma around a deeply sited AVM on the posterior central gyrus, and because we got into the hematoma, you actually come into it from the bottom, and it was just a very facile dissection. So one of the big things that Spetzler-Martin didn't really look at was compactness of nidus, and we know that AVMs are arteries and veins with distinct borders, but sometimes the border is not very clear, and those diffuse AVMs with ragged border with brain intermix forces the neurosurgeon into more deep parenchymal dissection, which is really what he doesn't want to do, to be able to do this without loss of much brain. You know, if eloquence was not an issue, if you can move well beyond the border of the AVM, it's actually really a very, very, very simple operation. But the fact is that to save function, you always try and work close to the AVM. And it's that border between close and too close that is what causes the most grief. And so if you have a compact nidus, this dissection and this work around the AVM is much better and easier to do. The group in Toronto, this is the brain cerebral AVM group in Toronto, published this back in 2006 and really caught the attention of the neurosurgical community. People who've been dealing with AVMs knew this from their own experience, but they showed very clearly that if you look at the odds ratios, the odd ratios were more significant, not so much for size as much as for compactness of nidus. This was a significant change in our thinking, and I just wanted to share with you a patient of mine with AVM, but as you can see on the MR, compact nidus, in very close to the visual radiation, and that compact nidus allows you to get a specimen to which almost no brain sticks, because you're always working at that junction. So that the compactness of diffuseness of the nidus is a very important feature which the surgeon must look at and analyze and factor into his thinking. Dr. Benes, who had a wonderful series, and I'm very impressed with your numbers, spoke to us about the perforating arteries. And what he didn't say was the term that you hear most in America, the red devil. But they like talking about things like red devils, you know. But you're absolutely right. And here's somebody, if you look at this AVM on a lateral view, it really looks like, okay, this is going to be mesial, largely pericallosal, and some callosomarginal and and I should be able to do this. But when you look at the AP and you see the perforators coming in, I looked at that and I said, no, this man has to have stereotactic radiation. So the deep perforators are thin, fragile, difficult to occlude with cautery. And if you end up like, it's possible, this may work out fine, but it's possible that you may chase the lenticular stride feeders into the internal capsule. And for a young person, that's a disaster. So to sum up, the factors that contribute to surgical risk include, of course, liquefaction, deep venous drainage, diffuse nidus, but also deep perforating artery feeders, larger size. And that's why the Spetzler-Martin helps to a certain extent, but needs to be supplemented with the information or the scheme that was brought to us by Lawton and Young. And Lawton and Young factored in and brought in age. Again, anybody you talk to somebody like Dr. Benes, who's got a large experience, he'll tell you it's amazing how well the young children will do with even serious deficits over time. And so the age factor is actually a very important factor. So A, because of the recovery, and B, their brain is fuller, but the vessels are easier to handle. But the other thing is what I mentioned earlier, whether you've presented with a seizure or whether you've presented with a hemorrhage can be quite important, because bleeding is an adverse factor. And I've spoken to you about the compact nidus. So Lawton Young produced a supplementary score, and that supplementary score is scored after 5. So if you combine Spetzler-Martin with Lawton Young, you have a selection out of 10 points, and it gets you a better sense of who's going to be a safe surgical candidate and who's not. I just want to produce one of the tables from their paper, because in this paper, they also talk about a full model, and their full model includes not just age and eloquence, but also a perforating artery supply, which, as I've already mentioned, is an important element that one must try and factor in as much as one can, because that's one particular factor that troubles the surgeon the most and causes most grief to the patient. So I want to just say a quick word about embolization. There's been a lot of talk about embolization. I was pleased to see Dr. Atharidam walk away from this meeting after his presentation, in which he said, embolization is not great, because he used to sing pantheons to the joys of embolization, and I was never really very impressed. The thing about embolization is that as you do more and more AVM surgery, you realize that it helps, but not that much, and you can do without it. And my last sort of thing on this is that you've got to also consider the cost, because embolization kind of doubles the cost of surgery in our setting. So embolization is okay and can be used, but the information we have from various trials is that standalone embolization in the hope to a cure, which some interventionists try and plug for you, is not a great idea. I want to just share with you the thing about preoperative embolization that I mentioned, that if you do it, you're trying to reduce the volume by targeting the nidus, but more important, reducing the intraoperative blood loss by targeting feeding vessels. But there's recent reports that it may actually spoil the result by its own adverse events, and sometimes making the surgery more difficult. And I must tell you that having seen my own patients suffer vein occlusions and other adverse events of embolization, I'm not a great fan. And then, of course, there's the cost factor. But apart from the 2 or 3 things I've mentioned, I just want to bring this to you. This is a patient who was embolized in, I think it's 216. And then on your left, on the right, you can see, no, I'm sorry, below, you can see a follow-up angiogram a year later. And look, the lenticular striates, perforators that were there before are much more obvious now. And a year later, they're much more obvious even then. And that's what he came to me with. And they said, can this man have surgery? I said, you know, if you had come earlier, I might have considered this. There's no way I'm going to do this now because the risks are too high. So just quickly about radiosurgery, I don't want to say too much, but, you know, if of course, if you're in high Spencer-Lawton-Young territory, then it's extremely helpful. The results are good, but we've seen lots of people who've had AVMs subjected to radiation who come in the interval period with hemorrhage. And I've also operated on people who 3-4 years later have had non-occlusion. There's either recanalization or non-occlusion. I just want to just share quickly a case of a patient who presented with seizures. So it's unruptured. But, you know, if you have significant seizure activity, then medication is not going to control this. And even doing radiosurgery doesn't improve that much, to my mind, the seizure control. And in this particular case, I discussed with him that, look, your visual field may be affected. He was willing for that. And we were able to get this out, and his seizures immediately stopped. He's still on medication about a year or so down the line, but the seizures were now controlled with medication, having not been so before. Quickly about unruptured aneurysms, unruptured AVMs, this data Dr. Benes shared with you. I just want to say that the Aruba trial really was a disservice to people with AVMs, because look how, when the Aruba trial was published, suddenly the number of unruptured AVMs that were being subjected to treatment just completely dropped off the chart. And at the same time, no treatments went up. So this is at the time of the Aruba trial publication, the treated patients went down and the untreated patients went up. So more recently, and I don't know if the Czech centers were involved with this, a number of centers put their data together and looked at surgical treatment of AVMs in 2 parallel registries. This is the TOBUS trial. It was published this year. And you know what? Without going into the details, the results were excellent for surgery, with surgery being curative in 88% of these patients. Now, obviously, the surgeons would only select patients that they thought were going to have good outcomes, but it's certainly much better than not doing anything. And finally, a couple of quick cases. I just want to say that for compact nidus, even in the motor area, when you look with functional MRI, you can find the function is often shifted. It's a well-known saying among people who are interested in AVMs that there is no brain inside the AVM. So the eloquence is disturbed in the dissection. And if you have a hematoma like this person does, then even central things you can do without really causing a deficit or extending the deficit at all. And finally, I just want to leave the plea that look at the AVM and analyze it. I just want to take you through this particular, this is my last case. On the left side is the AP of the angiogram, and it looks awful. But if you look carefully, a lot of that awfulness is actually a giant varix here. And you can just see on the CTA that the AVM is in the Sylvian fissure is not too big. It's this that's bad. And, you know, honestly, this is not the most difficult case I've ever done. It was a Sylvian AVM because that space by the huge varix was created. And once you got this feeding artery and it was going straight into the AVM, the whole thing deflated. And so my plea is that the surgeons need to look at these cases with an analytical eye and try to see whether it fits the profile of patients we know who are going to do well, and then offer them the best treatment that we have, which is surgical resection for the appropriate patient. So that's my conclusion. I'm going to end here. Thank you very much for your attention.
Very good papers, sir. Very good recommendations and reminder of especially recommendations.
So Dr. Borba is not going to do his talk just now. So well, thank you all for being here for this session. And that concludes the proceedings for the day. Salman, am I right?
So there is quiz.
Oh, but there's a quiz that Dr. Borba and Dr. Hassan are going to do.
Auxiliary the recommendations, age related and this.
Oh, Purani. Time locking young. I thought it was for the trial. Trial a big.
So participants who are in the WFNS educational course group, WhatsApp group, can find the link there, and those who are not, they can copy the link from the screen. So the price is only for the people who got registered for the workshop.
So the number of people who are here are less than 1/3 to people who have registered. You've got a very good chance to win. So the two people who win, 10,000 rupees each. Are we all ready? Are we all ready? Yes. Yes.
Here.
So has everyone finished filling out the form? All right. So the first question here, the most common mechanism of translational C12 subluxation is, the following answers are axial loading, distraction, extension, or flexion. So let's see what the what's that? Oh, okay, got it. So what, number two, what force mechanism leads to the fracture in the image below? That's A, flexion compression, B, pure axial load, C, extension distraction, or D, shear.
Is everyone locking their answers in? All right, on to number 3. You are evaluating a 33-year-old woman who was in a motor vehicle accident and was thrown from the car as it flipped. Imaging is demonstrated below. What is the diagnosis? So the answer choices are A, type 2 Dens fracture, B, traumatic spondylolisthesis of the axis, C, Jefferson fracture, or D, atlanto-occipital disassociation. All right, on to the next question. You are asked to evaluate a 65-year-old patient who was discharged from the hospital 1 week ago after undergoing decompression of a right-sided subdural hematoma. She has noticed some clear drainage from her incision and has had a persistent severe headache all day. PET CT is done and demonstrates below. What is the diagnosis? Your answer choices are A, subdural hematoma, B, epidural hematoma, C, tension pneumocephalus, or D, subdural empyema. Next question, 40-year-old man who was out drinking with friends and was involved in a car accident as an unrestrained passenger. He is sleepy in the trauma bay and his head CT is demonstrated below. What is the most likely diagnosis? All right, and your answer choices are chronic subdural hematoma, acute subdural hematoma, an epidural hematoma, or a traumatic subarachnoid hemorrhage. Next question, which surgical approach is typically used in a TLIF procedure? An anterior, posterior, lateral, or midline approach? Number 7, what is the primary goal of performing a TLIF procedure? Is it A, decompression of the neural structures, B, restoration of vertebral alignment, C, fusion of adjacent vertebrae, or D, removal of spinal instrumentation? All right, number 8, in TLIF surgery, the inner body cage is typically placed in which anatomical location? Is it A, anterior to the vertebral body, B, posterior to the vertebral body, C, within the disc space, or D, adjacent to the pedicle? Number 9, which type of graft material is commonly used for achieving inner body fusion in TLIF procedures? Is it A, autograft, B, allograft, C, xenograft, or D, synthetic polymer? Moving on to number 10, what is a potential advantage of using posterior pedicle screw fixation in conjunction with TLIF surgery? Is it A, decreased risk of infection, B, enhanced vertebral body height restoration, C, improved stability and fusion rates, or D, reduced postoperative pain? All right, following on, number 11. Which endoscopic surgical approach is commonly used for resecting anterior skull-based tumors involving the pituitary gland? A, transsphenoidal approach, B, transcallosal approach, C, pterional approach, or D, suboccipital approach? Number 12, what is the most common type of endoscopic skull-based tumor? Is it A, meningioma, B, glioblastoma, C, vestibular schwannoma, or D, pituitary adenoma? Number 13, in endoscopic endonasal surgery, which of the following structures serve as the key landmark for identifying the sphenoid sinus? Is it A, ethmoid sinus, B, maxillary sinus, C, the sellar floor, or D, the cribriform plate? All right, 14. When using endoscopic techniques for skull-based tumor resection, what advantage does the angled endoscope provide over the straight endoscope? Is it A, greater magnification, B, better depth perception, C, a wider field of view, or D, reduced surgical time? Number 15, in endoscopic surgery for clival chordomas, which vascular structure must be carefully preserved to prevent severe hemorrhage? Is it A, superior sagittal sinus, B, the ICA, C, basilar artery, or D, middle cerebral artery? Sixteen, basic indications for surgery and craniosynostosis. A, correction of skull shape for aesthetic and psychosocial purposes. B, create space for brain growth. C, to prevent developmental delay. D, to prevent neurological deficit, or E, all of the above. 17, which one of the following procedures for craniosynostosis can be done at early ages of life? Endoscopic suturectomy, cranial vault remodeling, frontoorbital advancement, or use of helmet? Number 18, what are the factors that determine the outcome of medulloblastoma in pediatric population? Is it tumor histology, extent of surgical resection, age of presentation, postoperative radiation, all of the above, or none of the above? 19, which histological variant of medulloblastoma has a more favorable outcome? Is it classical, desmoplastic, large cell, or nodular? Number 20, which histological type of craniopharyngioma is more common in the pediatric population? Is it papillary, cystic, adamantinomatous, or none of the above? 21, lack of documentation and proper communication among team members can lead to medical errors. Most common error related to surgery includes wrong procedure, wrong site of surgery, or wrong patient. Number 22, PEEK and carbon fiber cages provide more rapid and higher fusion rate than titanium because, is it the modulus of elasticity of titanium is lower than the bone, due to which the cage may subside through the vertebral body end plates, or titanium is more suitable in osteoporotic patients? C, carbon fiber and PEEK has a modulus of elasticity that is closely approximated with natural bone, allowing true load sharing and less stress shielding between bone and device. Or finally, titanium is excellent in radiographic follow-up for demonstration of fusion. 23, incidence of wound infection is found to be highest in scoliosis neuromuscular, for discectomy, posterior fusion with instrumentation, or endoscopic spine surgery. 24, which of the following is a contraindication for the application of cervical traction? Is it A, atlanto-occipital dislocation, B, type 1 Hangman's fracture, C, a 10-year-old child, D, unilateral locked facets, or E, bilateral locked facets? 25, which of the following syndromes is associated with ipsilateral findings of motor weakness, loss of proprioception, and vibratory sense with contralateral loss of pain and temperature sensation? Is it Brown-Séquard syndrome, posterior cord syndrome, anterior cord syndrome, central cord syndrome, or lateral cord syndrome? 26, which score on SLICS is definitive for surgical management for subaxial spine injuries? Is it 3, 1, 2, 4, or 6? 27, what is the SLIC score of a burst fracture with intact discoligamentous complex and intact neurology? Is it 3, 1, 2, 4, or 5? 28. Factors leading to delay in diagnosis of C-spine injuries include all of the following except A, neck pain and tenderness, B, concurrent head injury, C, altered state of consciousness, D, poor radiographic visualization, or E, multiple injuries. 29. Which of the following is most common type of spinal cord injury? Is it complete cord injury, central cord syndrome, anterior cord syndrome, posterior cord syndrome, or my favorite, Brown-Séquard syndrome? Finally, 30. In cervical or high thoracic lesions with both hypotension and bradycardia, which of the following drug is best for maintaining hemodynamics? Is it phenylephrine, norepinephrine, dobutamine, dopamine, or epinephrine? All right, has everyone locked in their answers? Don't all answer at once.
I will not fail.
Good job. No, I think we should believe them. Yeah, they got the same score. They should answer all the questions then. Yeah, is it too late to raise?
Great one here.
Yeah.
Okay. You have two patients with Twitter adenoma. Okay. With vision loss. One has the prolactin level very large. Okay. Prolactin level is 4, just 4. Okay. The other one has a syndrome of acromegaly. Okay. Very high level of growth hormone. What your approach for this tumor of very low prolactin level? Just 4. What your approach for the tumor with growth hormone? You first, okay. What you do for with the prolactin?
With low prolactin level, I would go for excision biopsy because it's non-functional pituitary adenoma. And for acromegaly as well, I would go for excision biopsy because primary treatment is for microadenoma, and for resectable microadenoma is excision and then followed by the hormonal therapy.
I can understand anything I said. Okay. You go directly to surgery. Okay. Give my paper. Okay. Okay. And you for the prolactinoma?
So the levels are low, but clinical impression is high. So I would like to repeat a lab, thinking of hook effect. That may be a lab.
Sure. And you?
Sir, for prolactinoma, I would go for medical management. And for growth hormone adenoma, I would go for surgery.
4. You give me medication. Just 4.
So
Very low. Very low. Why medication?
it might be hook. It might be hook
You
effect.
treat.
No, yeah. And for growth hormone, I'd go for surgery.
No, you wait for the growth hormone now. For the growth hormone now, how you do? Go surgery. Okay. Okay. No medication for the growth hormone. Later. Can you decide the winner? Okay, what's the correct answer for the prolactinoma? Huh? The correct answer is the lady said the hook effect. 4 is too low. When you repeat, probably you have to dilate it. Diluted. Diluted. In your 4 may be 4,000. See, it's very important in prolactinoma when we suspect suspect of prolactinoma to repeat. It's important to repeat. Good. This hook effect is very, very important. Make the difference. And the treatment will be medication. See? Prolactinoma, this the micro, the small one, the surgery is good. The medication can control, but the surgery is very good and can cure. For macro, you have to start with medication. It's completely different. In growth hormone, you need surgery. Except you start with medication and the patient has a lot of morbidity. For example, cardiac dysfunction, you can compensate with medication after you go to surgery. I don't know if Okay. They tie. Big guy is treating, he has no idea what below, but he's treating. She's operating. Let's see. At the end, he'll be correct. He'll be correct. Yeah. Oh, give to me. Both of you. Go de middle. Photograph, don't come down. Sir, group photograph.
हाँ? कल भी होगा भाई। कहा ना, मतलब यही टाइम हो जाएगा, 5 साढ़े 5 बज जाएंगे। अच्छा, आधे घंटे हलवा लगाओ, आधे घंटे का हाँ, तो जगह पे जाओ, आ रहा हूँ मैं, पहुंचवा देता। राशिद भाई, आपको पैर हटाने पड़ेंगे, कानून के पैर लंबे होते हैं। हाँ, पार्किंग में चलते हुए जाओ इतना लंबा। हाँ, चलना छावड़ से बात हुई, क्या कह रहा है? बोलने में आऊंगा कामरान भाई, मैंने बोला कि जो तुम्हारा 3 बजे तुम्हारा इवेंट शुरू हुआ है, यहाँ पे आने का बोल रहा था। यहाँ की क्या करेंगे? खड़ू मार जाएंगे शायद। नीचे क्या? लाइव होगा ना वहां से?
वहां से लाइव नहीं कर रहे।
अच्छा
देखो वो सेशन अलग होगा, ये सेशन अलग होगा, ओटी से लाइव अलग होगा।
अच्छा।
एक साथ है।
साकिब भाई को बताया है ना?
मुझे भाई को पता है ये बात।
बस
ठीक
ठीक
है,
है।
देखो ओटी वाला यहाँ पे दिखाना होगा।
हाँ
ठीक है, जब हम बोलेंगे तब
ऐसे ही है।
यहाँ से वॉइस, वहां से वॉइस, दोनों तरफ से।
बिल्कुल बिल्कुल, वो तो
ठीक
होता
है?
है। हाँ ठीक है।
दो चीजें ये हो गई। नीचे वाले जो सेशन है ना, वहां पे कुछ लाइव नहीं दिखाना, लेकिन वहां पे अपना सेशन चल रहा होगा।
अच्छा
ठीक है,
सही है।
तो बंदे लेकर आना कल।
कल तो होगी टीम। कल क्योंकि कॉन्फ्रेंस हॉल नहीं है, होगा तो शायद टीम ही होगी।
आज 11 नहीं बजने तो वो लोग करते हैं आप। अब अभी कॉल करो वो अभी आए। कितने मिनट कह रहा है कॉफी तो हमारे अभी तो देखो ना।
आपका गार्ड तो हो गया ये ना।
कि अब 8 बजे बंद हो जाए करेगा। मार्केटिंग ने ये काम कर दिया आज।
तो जी
8 बजे का गाइड बना दिया
हॉल का।
साइन होंगे और 8 बजे के बाद ये थोड़ा आने वाले वक्त में बंद हो जाएगा।
ये हॉल या ऑडिटोरियम?
ऑडिटोरियम।
अच्छा फिर हम क्या करेंगे?
हमारा भी वो गया ना हिसाब किताब। को ये 2 बजे जाता है लड़का और सुबह 6:30 बजे से पहुंचना भी है।
अच्छा
तो ये सिस्टम में सब आराम से काम करते हैं अपना, तो उसका लेटर बन गया है और ये आगे पेनल फ्लैग जो लग रहा है ये भी खत्म हो। तो जो बाहर
लगता था बड़ा।
आज लेटर तैयार हुआ है, मार्केटिंग नहीं करा है। एमडी के बाद जाएगा, साइन हुआ, खत्म का बाद लियाकत के जो प्रोग्राम होंगे ना मेडिकल कॉलेज से, उसमें हमें रात को देर तक पढ़ सकते। सब अपनी मर्जी से आ रहे हैं, सब अपनी मर्जी से जा रहे हैं, वहाँ का काम चल रहा है। जैसे तो यहाँ से भी ले लेना
ऐसी है।
और दूसरे को अखबार में
बिल्कुल ऐसी।
आप लोग 6:30 बजे नहीं पहुंचे होते, लेकिन मैं यहाँ 6:30 बजे पहुंचा हुआ। क्या कोई आए या ना आए, क्योंकि मेरा वो अभी अम्मात ने आके बोल दिया ना कल फोन को कि यार तुम कहाँ हो, मैं तो बंद पड़ा हुआ और ये भाई सबसे पहले आए। आप आए थे ना, खुला हुआ था नहीं खुला हुआ, 6:30 बजे का आया हुआ।
राशिद में पहुंच गया मैं।
पूरा दूध भी था ना मेरे।
कल की तो नहीं है ना मीट।
घर से निकला 7:30 में, 10 मिनट के अंदर मैं मैं यहाँ घुसा ना, बाइक ना वहाँ लगेगी। ठीक है, मैं सामान रख दिया। मैं वहां से बंदा निकल रहा था, उससे बाइक पे बड़ा यहाँ उतर गया, फोन आ गया।
तो अगर कामरान भाई नहीं आए तो मुझे बताएंगे वो।
मैं कार्ड दे दिया मैं आपको, मैंने
जी जी दे दिया
दीजिए ना। मैं डर गया, मैं भी उन्होंने कहा यार बातों में कैसा ना।
ठीक है फिर आप मुझे बता देना अगर कल वाला सीन और
भाई कल वाला
नुकसान हो गया ना। बड़ा हल्का जाता है यार, एमबीस की स्पीड में जा रहा है। यहाँ पे क्या करना है, बोलो कौन आ रहा है, क्या है?
कितने 2 व्यूअर्स थे
क्या यूट्यूब पे? देखते ही नहीं है कोई। कौन देखेगा, बोर्ड थोड़ी होना किसी को।
ये चीजें ना ये लोग बाद में निकालते हैं सब।
ये बाद में किसी को काम अगर निकालना हो।
पकड़ लिया
अभी तो कोई भी न्यूज़ नहीं आ रहा। ठीक है भाई,
चले फिर मैं लगा दी इंशाल्लाह।
यहाँ पे
यहाँ पे फाइबर वगैरह की होनी है सेटिंग, बिछी हुई है, उसकी सेटिंग कर रहे हैं। काशी भाई वगैरह आ रहे हैं अभी, फोन कर रहे हैं अभी। क्या बोल रहे हैं, रिपोर्ट बात कर रहे हैं। वहाँ पे बैकअप है,
ड्राइव ले जाओ।
हाँ ड्राइव तो ले
यूएसबी लगी हुई है ना,
यूएसबी लगी हुई है।
आज सेकंड्स में कॉपी नहीं हो रही थी ना,
कल भी नहीं हुई थी सेकंड।
तुम लोग ही कह रहे थे 1 सेकंड।
मैं थोड़ी बोल रहा हूँ,
कितनी देर आ रही है?
फोटोग्राफर
कितनी देर आ रही है?
मेमोरीज बहुत कम आ रहा है ना, यूएसबी है ना।
नहीं मैं कह रहा हूँ कितने जीबी की है?
जीबी तो आपका फोटोग्राफी है आपकी,
कितनी स्पेस है जितनी तुम डाल रहे हो?
स्पेस तो होगी 562 MB।
नहीं
यूएसबी में हाँ स्पेस तो होगी, जा रही है, वरना तो एरर आया था।
कितनी चेक करो, ये ना हो ना आगे चलने के बाद रुक जाए।
नहीं है 12 GB स्पेस है।
बस ठीक है।
अभी किससे बात हुई थी? क्या बोल वहाँ कॉन्फ्रेंस हॉल का
खत्म हुआ है
अभी खत्म हुआ हाँ? वही सेटअप की वजह से तो कितनी देर में आ रहे शामिल को बोलते हैं अब छोटा एक बोर्ड भी भिजवाओ ऑडिटोरियम में पॉइंट फुल होगा यहाँ पे
ये तो हट जाएगा ना
हाँ ये तो हटा दे तो आज भी कोई न्यूज़ नहीं था मतलब
और सोए
लग जाएगा कुछ करेंगे लॉक होता है ना दिखाए दिखाए
चाहिए हो जाए
नहीं लग जाए 10 मिनट लॉक खुलते हैं ना तुम लगाओ सीधा से लगेगा
छोड़ दो
आप बात कर रहे हैं ना आप कुछ नहीं करते
पूछ लो ना तुम बोर्ड का भी बोल देना बोर्ड का भी बोलना कि बोर्ड भी लेकर आए इसके ऑडिटोरियम के लिए पॉइंट कम पड़ रहे हैं फुल है बोर्ड
हाँ जिम्मेदारी है बेटा जिम्मेदारी नहीं करते हमारी कोई जिम्मेदारी नहीं सारी जिम्मेदारी ऊपर की बैठे हैं कहाँ जा रहे
सीनियर डॉक्टर
हमने कहाँ जाना है मजबूरी है हमारी
सीनियर डॉक्टर अभी आया
कल कितने 7:30 बजे तक ना लगेंगे मैनेजमेंट हमारे मैनेजमेंट कौन से मैनेजमेंट ने बताया कब नहीं लगेंगे बोली फोन की बात करना चाहिए इसको बताओ अगर हमारा नहीं है फिर वो कितने सारे अभी भी अगर ऊपर अगर भगवान हटके लेके आने देता है तो खड़ी कर देगा बोलते हैं क्या हो क्या आप बात करिए ना तो बेहतर बढ़ेगा आप एकदम बात कर बेहतर बढ़ेगा ना वो काम जल्दी हो जाएगा उल्टे बोल रहा हूँ प्रेशर बढ़ेगा ना तुम बात करेंगे क्या था ऑडिटोरियम तो सुबह 7 बजे स्टार्ट होगा मैं आया था मैं तो भागा भागी में खाया था वहाँ तो बस यहाँ पे जरा जल्दी आ गया ना, मतलब आधा घंटा तो बंदा वेट कर सकता है, लेकिन 2 घंटे बहुत ज्यादा हो जाएगा। वो तो कभी की पड़ेगी मेरी, ये तुम लोगों की है मेरे पास, एक मेरी की तुम लोग को ये बाकी तो यहाँ पर आ जाओ डब्बा था। लेकिन आधे पौने घंटे बिजनेस क्लियर तो मैं वही कह रहा हूँ कि 2 घंटा वो वहाँ पे रुक सकता है ना, उसको वाइंड अप कर लेगा। इलेक्ट्रिक मार्किंग रखी ना, इन्होंने रखी मेरी ज्यादा दूर में रखा। हाँ थोड़ा लेकिन जल्दी कर जाते जाते भी रास्ते में वो भी ना लगे। वो सिस्टम है कि रूटीन है हाँ अपने पास रखो तुमने बॉडी कभी ऐसे तो आते नहीं है जल्दी, लेकिन कभी पहुंच गया ना जल्दी नहीं आया वो मुझे बोला नहीं कि ना ये तो कॉपी करके मैं क्या बोलूं, हम तो समझते हैं लेकिन नहीं समझते। तो आपको कॉल करके करेंगे तो आप कॉल दिया है को कॉल कर रहा हाँ हमने कॉल किया ठीक है ये लोग कितने में गए थे सैन तुम लोग गए थे नहीं है खाते बैठे बहुत बड़े नहीं तो वो नीचे रिसेप्शन पे देते तो डेटा भी तो है ना, वो रिस्क नहीं लेना चाह रहे थे, फाइव के थ्रू भी नहीं भेजे थे, फिर इन लोग को निकालता जो 12 बजे की तरीके 12 नहीं यार मैंने तो रात में बुलाएंगे साथ में आगे भाई नहीं गए तो आगे ना पहले हमें बात करी हां मैंने कहा मेरी नंबर से करी मैंने अपने 9 बजे कोई वो नहीं है तो अभी रिप्लाई भी नहीं आया उस टाइम पे नहीं इस पे नहीं आया ना, ये तो कह रहा हूँ मैं कि व्हाट्सएप पे अगर वो भेज रहे होते तो मैं उसको आता था नहीं उन्होंने हमारे आदमी देखी थी लेकिन तुम्हारे नाम में भेजा तो आपने काफी पहले भी बात करी अभी कल तो जाते जाते बोला हाँ टीम बोल दूंगा तो वहाँ तो एंड हो गई ना, वहाँ कॉन्फ्रेंस 2 दिन का अभी क्या कर रहा है भी आ जाएंगे भी काम
आदिक भाई सानू ये लोग बोलते हैं
ठीक है जब मैं उधर थी ना तो सारे नीचे रह गए
मेरा
चेक करके लेके गया मुझे नहीं पता क्या करते
ये खा लेंगे अभी तो थोड़ी देर में भूख लगेगी
मेरे स्टार्ट से लिखे हुए माना फाइबर है मेरे साथ देखना नहीं है
वो वैसे तो सबके प्रिंटेड है आपको नाम तो लास्ट में आया भी एक्स्ट्रा ठीक है वही तुम बाइक नहीं खरीद सकते हाँ हाँ बंदा सब है तो फिर ऑडिटोरियम भेज दिया हाँ ऑडिटोरियम में भेज दो ना वही
ये तो लगेगी सीधी करके लगा दो लगी हुई थी तो वो सब पढ़ना है
वेट सब आगे क्या आगे
अस्सलामुअलैकुम। मतलब क्या मतलब? तीन दिन पहले कब किया भाई? कल तो मैंने देखा था मिस कॉल आई थी। अबे मैं शादी में चला गया था, उठ के सो रहा था मैं घर पे जब तुम्हारी कॉल आ रही थी। अभी तो है बैठा हूँ, टाइम जाकर नेशनल में आ जाओ। एक्सपो में तो वाइंड अप हो गया, अभी कॉन्फ्रेंस हॉल खत्म हो गया, वहाँ पे वो लोग सबमिट रहे हैं। 11 अगस्त। हाँ ना, वो कॉन्फ्रेंस मेन हॉल जो था ना वो खत्म हुआ, बाकी लगा हुआ। हाँ, फूड एंड एग्रीकल्चर। हाँ, फूड एंड एग्रीकल्चर का मतलब वो क्या बोलते हैं, खाना और मतलब काश्तकारी। खाना खाना उगाना। नहीं, मैंने कहा वो बता दूं ना, तुम्हें बताओ। हाँ, जाने वाली है, हम तो तरस गए यहाँ बैठे बैठे लाके, अभी खत्म हुआ यहाँ पे। और यहाँ भी सेटअप भी लगाना। ओटी ओटी का सेटअप लगाना है। छोटा सा सेटअप, इतना बड़ा नहीं है। आ रहे हो तुम? एंजॉय हो जाएगा, थोड़ा तफरी करते। एक्सपो तो खत्म हो गया भाई, 5 बजे खत्म हो जाता। हाँ, 5-6 बजे खत्म है बस। हाँ तो भाई क्या तुम्हारे लिए बैठे रहेंगे? सुबह जल्दी से खत्म होती है। क्या सही है, नहीं आ रहे ना मतलब? तो भी दे नहीं दिया तुमने? नहीं तो तुम बाबू नहीं जा रहे एक्सपो, तो यहाँ आ जाओ, मैं ये बोल रहा हूँ। चलो बताओ बताओ, जल्दी बताओ। नहीं नहीं, सेटअप नहीं, तफरी के लिए बोल रहा हूँ। सेटअप तो हमें भी नहीं लगाना, हमें नहीं थोड़ी लगाना है, काशिफ भाई का काम है। सिर्फ काशिफ भाई का काम है, वो आ रहे हैं, वो ओटी लगाएंगे बस। हाँ हाँ, आ जाओ भाई, यही बैठे हैं। ओके ओके, अल्लाह हाफिज़। कौन सी? MK5 सुपरा। किसने लिए? UK 079 इंडिया फोटोग्राफर। दुबई नंबर प्लेट में गुड करो। अच्छा, मैं खुद इंतजार कर रहा था कब करेगा, क्या रिएक्शन। वैसे नॉर्मल अगर ये इंक्लूड भी नहीं करता है हाईवे पे, उसके मीटअप के लिए 200 लड़कियां थी खड़े थे, कितने मीटअप प्लान नहीं कर पाओगे। कर लेते तो पूरे स्कूल के लिए जितने बच्चे क्या कर सब ये मीटअप प्लान कर परमिशन के साथ पूरे भागते हैं वहां से।
And I'm really frustrated now. Big वैसा होता है कि भाई हर दिन हम लोग डॉक्यूमेंट दे रहे हैं सब कुछ ओके है I don't know फिर भी नहीं प्रोसेस हो पा रहा है जिनको कॉल आता है कि भाई आज वाले एक गाड़ी रेडी बट एट एंड ऑफ द डे जब हम वहां पर जाते हैं कुछ ना कुछ नहीं दिक्कत आती है मैं मानता हूं मेरी गलती थी कि परसों जैसे डिलीवरी मिल रही थी उस दिन मैंने डिलीवरी ली नहीं एंड आई वेंट टू दिल्ली पर उसके बाद मेरे को बोला गया था कि भाई जिसे ना पाओगे ना उस दिन आपकी गाड़ी निकल जाएगी कल हम लोग पहुंचे कल मैंने कहा ठीक है आपको कुछ नहीं चाहिए होगा आप बोले कि नया बिल ऑफ एंट्री साइन होगा वो कमिश्नर जी साइन करेंगे सो कमिश्नर जी के पास जा रहे हैं कमिश्नर जी के पास फाइल सुबह से पड़ेगा and still it has not been signed. I don't know what is happening at all.
पाकिस्तान में ये
frustrated हो चुका मुझे frustrated होने के भाई बाप भैया कहाँ रह गए पूरा मैं आपको आज का सीन बता देता हूँ आज भी बात हुई है मैं नहीं बोलता वहाँ के जो बंदे हैंडल कर रहे होते हैं गाड़ी मिल जाएगा 100% है तुम 4 बजे कंफर्म करके पूछो कि गाड़ी मिल जाएगा तो खुद मिल जाएगी सो द थिंग इज गाइस अभी बात कर रहा हूं बोले आ जाओ कमिश्नर जी से मिल लो अगर उन्होंने आज साइन कर दिया तो यू विल गेट द कार नहीं मिली तो फिर आई डोंट नो क्या कहां क्या लिखा है मैं अपने घर से ऑलमोस्ट 15-16 दिन हो चुके हैं मुंबई फंसा हूं या एवरी डे रेंट एयरबीएनबी खाना पीना
नहीं दे वो
थोड़े आप लोग खर्च हो चुके हमारे इस ट्रिप पर व्हिच वाज नॉट सपोज्ड टू हैपन सच
बड़ी है 1.5 करोड़
क्या
क्या
हाँ
दादाजी नहीं इसको बड़ी थी अच्छा 6 महीने के लिए नहीं है प्रोसेस 6 महीने बाद जाएगी तो ये 15 6 महीने बाद वापसी भेजना पड़ेगी इसको
हमारी जब उनके बंदों से बात हुई
ये बंदा दुबई से इसने करवाई ये सारे पेपर
फाइल आई है मॉर्निंग के लिए अगर आप वहां से ले लो और they are waiting for the approval because they are filing a
लेकिन 5 मिनट है 2.2
now all these are technical terms ऐसा होता है ना that when you file a manual development you require the approval from the highest authority which is the commissioner जब तक उनके signatures नहीं होंगे and you have to have a valid reason why you want to have a manual development instead of the online submission because online submission may it takes minimum 48 hours for them to respond back, ask you for the clarification. Uske aage, whatever you have to upload all the documents, agar approve ho gaya, फिर okay. अगर नहीं हुआ तो वो submission में ही रहता है. इसीलिए he said that we need to opt for a manual development. इसीलिए भी और हमें बोला system down. ये बोला कि भाई import वालों का system down है मनीष भाई ने. So देखो मनीष भाई से कुछ मतलब नहीं है क्योंकि मैंने सचिन भाई को दिया था ये सब कुछ इंपोर्ट कराने का सचिन भाई से डायरेक्ट मैं बहुत फ्रस्ट्रेट हो चुका है सारे प्रोसेस से बिकॉज़ मुझे नहीं समझ में आता कि मेरे कितनी मैनुअल फाइल ऑनलाइन फाइल मुझे पूरा करना है मंडे मिलेगा मंडे बोलता हूँ मंडे मिलेगा मैं मानता हूँ हमारी मेहनत जब मेरे को बोला गया था कि हो जाएगा वेडनेसडे लास्ट तक तला निकल हम लोग अगले दिन अप्रूवल ले लेंगे हो जाएगा आज थर्सडे गाइस एंड आई होप आज हम लोग जा रहे हैं कि लाइक गाड़ी मेरे भाई शराब गाड़ी ऑलरेडी 10 तारीख को ये आई डोंट नो तो अगर हम लोग आज गाड़ी लेके निकलते हैं तो पहुंचेंगे नहीं पहुंचेंगे मैं बहुत डिप्रेस फील करूंगी सब कुछ करवा दिया पे भी कर दिया लाइक पेड एवरीथिंग ही नहीं दिया गाड़ी मैं क्या बोलूं यार मेरे को भी पता है लोग भी बहुत एक्साइटेड है बट ये जो कस्टम का प्रोसेस है ये मेरे हाथ में नहीं है गाइस मेरे हाथ में होना तो सच और एक और ये प्रोसेस जो है मनीष भाई के भी हाथ में नहीं है but he assured us because he had that level of contact. He said कि भाई हमारा हो जाएगा and I know it's basically not in his hand. Exactly, it's not his fault as well, but उनकी साइड से everything was little late. और फिर मनीष भाई ने से श्योरिटी मिलता है कि बात हो जाएगा सही हम लोग भी आगे कोई बोलते हैं कि हो जाएगा अब ये मनीष भाई का आगे कुछ नहीं आई डोंट थिंक वो भी बेस्ट कर रहे हैं बट एटलीस्ट अगर एक स्पेसिफिक डेट मिल जाता ना कि भाई 10 तारीख को गाड़ी मिल रहा है तो मैं पहले से ब्लॉग में बोल के रखता कि 10 तारीख को गाड़ी मिल रहा है बीच में कुछ भी चेंजेस होते तो वी वुड हैव गॉन फॉर इट फिलहाल भी चल रहेगा इस कॉन्फ्रेंस इवेंट एंड वन मोर थिंग आई वांट टू ऑन द रोड एंड इट वाज माय एज ये तो इनकम है नहीं it was my agent